Yeah.
Fine, great. Nice to see you.
Yeah.
You'd like to share your screen?
We're all just on the internet. So,
good morning, Pandav sir.
We are live, doctor.
Okay.
Okay.
Dr. Arup, you can start.
Okay, so a very good morning, friends, and a warm welcome to the first glaucoma session of the BOA MOS Summit. And I am really grateful to the organizing committee for giving me an opportunity to chair this session. And we have a series of interesting talks lined up. And I think though one or two speakers may not be there, but still I think we can compensate by having a very vibrant discussion session if we have any time left at the end of the entire, all the didactic lectures. And with these introductory comments, I think we'll get going and request the first speaker to come on board. Gonioscopy, Dr. Sunil.
Yes, sir. I'll share my screen.
So Dr. Sunil Jain needs no introduction. He is a very scientific and mathematic in his academic. He is a gem of a person. He has so many presentations on his names, so many publications. We have heard a lot of time to him in conferences, and he is always eager to answer all the questions on the dais and off the dais also. So it gives me pleasure to introduce Dr. Sunil Jain, sir.
Yeah, good morning, everybody. Can you hear me, sir? Can you see my screen?
Yes, yes, sir.
Okay. Thank you, the organizers, the BOA, and the scientific committee for having me at this session. With the permission of the chair, I'll be talking on gonioscopy. So the importance of gonioscopy, it is always essential because almost 50% of population of glaucoma are angle closure glaucomas, and unless you do gonioscopy, you won't be able to detect angle closure glaucomas. Once a gonioscopy is put over the patient's eye, the best part is not only you can see the site of impedance of the aqueous outflow, but also whether any additional mechanisms are responsible for the glaucoma can also be seen clearly. The important part which I would like to convey, it has to be repeated periodically to detect any additional mechanisms which might come forth in later part of the patient's life. So two types of gonioscopy. There's a direct gonioscopy and the indirect gonioscopy. These are the direct gonioscopy lenses. The advantage is that you get a straight on natural view of the angle, and it allows the comparison of both eyes simultaneously. The disadvantage is it has to be performed only in supine position. Hence, its practicality, it is used only during pediatric glaucoma surgery or the near angle surgeries. This is the view which one gets using a direct gonioscope of the angle structures. The indirect gonioscopy, which normally all of us use in the OPD, the advantage is it gives the additional advantage of the slit lamp that you can magnify the image, you can have a controlled illumination, and hence it's more convenient. There are two types of lenses in these. The one which need coupling agents, these are the normal Goldman lenses. The one which do not need a coupling agents, these are the 4-mirror lenses. And this is how you would insert a gonioscopy after putting topical proparacaine in the eye of the patient and examine the angle structures. Now, the routine lens, what everybody uses is a single mirror or a 3-mirror Goldman lens. The advantage, because of the suction effect, you are much more in a comfortable position examining the eye, especially for the first-time users. That's the ideal way to start learning gonioscopy. The lens is very well centered, and you can comfortably examine each structure. Also, it can be useful in the laser procedures when you have to do an SLT for these patients. The disadvantage is many times because of scleral indentation, it might distort the anatomy of the angle structures. Now, this is the image what you will see. The image is not an inverted image. It's the reverse image what you see. So if you are looking for the inferior angle, you will look into the superior mirror. And this is the structure. 6 o'clock will appear as this. The nasal structure will appear on the nasal side, and the temporal structures will appear on the temporal side. And as you rotate, this relation is maintained. Coming to 4-mirror lens, I think it has a big advantage that no need for any coupling agent. Plus, you can do what is known as dynamic gonioscopy, which I'll demonstrate to you. The disadvantage is there's a certain learning curve because certain excess pressure might cause corneal folds and then the visualization gets obscured. And these are the different 4-mirror lenses. This is the difference between a 3-mirror lens and a 4-mirror lens. So how do you start about learning gonioscopy? Obviously, with the help of an experienced examiner. So you need to know what the normal structures are before you detect what is abnormal. So I'll take you through a lot of gonio photographs to help you know what gonio, the angle structures look like in different conditions. This is how a normal wide open angle would appear to us. And to start off with the structures, we tend to grade them from the cornea towards the iris. So the first structure you would look at is the Schwalbe's line, followed by the pigmented trabecular meshwork, then the scleral spur, and the ciliary body band. Now, once you have put the gonioscopy, you need to answer certain questions. So first, is the angle occludable? So that's how you would differentiate whether the patient has an open angle or a closed angle. After that, the next thing, are there any additional abnormalities in the angle? And also you need to look at the curvature and the incision of the peripheral iris. Now, there are certain lighting conditions which you will have to follow to answer the first question, that is whether the angle is open or closed. Dim the room lights. Patient has to look straight ahead. And the slit beam should be a very small beam. It should not be crossing the pupil so that it can, otherwise it can cause an artificial constriction of the pupil, and a closed angle might appear as an open angle. Now, once the slit beam is basically focused into the angle structures, the slit beam gets divided into the epithelial beam and the endothelial beam, which come to a focus at Schwalbe's line. This is where the Descemet membranes ends. And this is the first structure which needs to be identified, because after that, what structures you see, that will help in grading of the angle. So this is known as the corneal wedge test. Once you have diagnosed the patient to have an open angle or closed angle, and if the patient has a closed angle, you would like to do an indentation gonioscopy. But by pressing the central cornea, the aqueous gets pushed into the peripheral angles and the entire lens iris diaphragm goes backwards. So if it's an apposition angle closure, the angles will open wide open and you won't see any goniosynechiae. But if it's a synechial angle closure, you'll see goniosynechiae, which I'll show you in my gonio photographs. Once you've determined whether angle is open or closed, you increase the illumination, let the pupil constrict, and try to look for any additional features like pseudo-exfoliation, neovascularization, which would be present in the angles. In addition, you look at the peripheral iris curvature. So a convex iris curvature usually seen in angle closures. A concave iris curvatures usually seen in aphakic glaucomas, pigmentary glaucomas. If the peripheral iris is inserted more anteriorly, this condition usually seen in juvenile open angle glaucomas. So apart from diagnostic, it has certain therapeutic applications also, and hence you need to learn your gonioscopy very well. Let's go to certain clinical examination. This is what a normal wide open angle would look like. Now this is an angle closure. When you initially see, you might feel it's an open angle because of the pigmentation, what you see here, and you might think this is a trabecular meshwork. This is actually pigmentation over the Schwalbe's line. So it's only when you do indentation, okay, the entire lens diaphragm, iris diaphragm goes backwards, and you can see the trabecular meshwork is lying here, and you'll see these goniosynechiae. So this is how you could have missed a closed angle, and the treatment would have changed. This is when it's completely zippered up, a complete synechial angle closure. In spite of indentation, the angle does not open. After you've done a YAG iridotomy, you can detect what is known as the plateau iris, and where you see the sine wave sign. This is the peripheral convexity due to the anteriorly rotated ciliary processes. Then there's a dip at the equator, and then again the next convexity of the lens equator. This is how an angle structure would appear in a anterior iris insertion, a posterior embryotoxin, an axon-field anomaly. This is how a pathological synechiae would appear, where there will be peripheral tinting of the iris, and basically the iris gets pulled up, as compared to iris processes, which are very fine fibrils, which go along the concavity of the angle. You will also see neovascularization, the arborization of the new blood vessels all over the trabecular meshwork, causing neovascular glaucoma. This is how, in the olden days, when the incision would be badly sutured, you would have a fibrovascular ingrowth. You can also have a malignant glaucoma present in the angle. On gonioscopy, you can detect a localized mass out there. This is how a pigmentary glaucoma would appear. You can see dense pigmentation of the trabecular meshwork along with Sampola-C's line. In pseudoexfoliation, you see these flaky materials lying in the angle. Post complicated cataract surgery, you can see vitreous lying into the anterior chamber along with the extensive pigment dispersion causing secondary glaucoma. These are older generation anterior chamber lenses which would cause severe inflammation and complete cynical angle closure. Sometimes epinucleus piece is left behind in the angle after a phaco, and this tends to cause intermittent spikes of intraocular pressure and uveitis. In a post-traumatic, you will see sphincter tears in the pupil along with an angle recession, sometimes a foreign body in the angle. And these are inflammatory gonioscopy, and as you can see, the angle is wide open. So this is to differentiate between a gonioscopy due to angle closure, where you have occludable angle, whereas here you'll have a wide open angle all over, along with intermittent gonioscopy. You could have silicone oil bubbles in the angle. Post-trabeculectomy also, a gonioscopy helps you, especially post-operatively if you see a sudden peaking of the pupil. And when you insert a gonioscopy, you will realize that the peripheral iris is gone and occluded your internal ostium. And that's how the failure of a trabeculectomy could happen. Rarely you can see vitreous coming and obstructing the internal ostium. And coming to therapeutic applications, well, the gonioscopy can be used for ALT or SLT. Sometimes in a patient of traumatic aniridia, you can have a direct cyclophotocoagulation of the ciliary processes. Coming to non-glaucomatous conditions, the ciliary body mass I've already explained to you. This is a patient who came to us with a bleb, and there was no history of any glaucoma in the patient. And it's only when you did a gonioscopy, you saw a fish mouthing of the small incision cataract surgery which was done. So all this required was basically a suturing of this wound, and the bleb disappeared. So gonioscopy is mandatory in a patient for diagnosis and management of glaucoma. Also in the post-trabeculectomy period to evaluate the internal ostium, and even in certain non-glaucomatous conditions like ciliary masses and inadvertent blebs. Thank you.
Thank you, Dr. Sunil sir, for your nice presentation and very beautiful photographs. Gonioscopy is a basic to start for the glaucoma. So thank you very much, sir. So I request our next faculty, Dr. Nitin Deshpande, to talk on dry eye in glaucoma.
Yeah. Is my screen visible?
Yes, yes, sir.
Yeah. Good morning, everyone. Thanks for inviting me for this talk. And I'm going to talk about a very important issue of ocular surface disorder in glaucoma patients. Hollow et al. Described it as an imbalance of ocular surface homeostasis caused by the toxic effect of chronic topical medication, which leads to tear film instability, epithelial damage, and inflammation. We know that the old age issues like glaucoma, ocular surface disorders, they coexist. And once they coexist, it creates more issues, like simple issues like doing a IL-power calculation for these people with cataract, or adding medications for glaucoma as well as ocular surface, because we know that more than 2 drops are going to create serious compliance issues in these patients. So it is very difficult to manage coexisting disorders. The drops we generally use have preservatives like BAK, which is bacteriostatic bactericidal. However, a chemical like a BAK doesn't differentiate between a cell membrane of a bacteria or our own cell walls. So it damages both at the same time. So that's why we have new preservative-free drops, which either become hydrogen peroxide once we instill it and then just becomes a water, or they just break into the normal tear film electrolytes once we instill them. So that is the way to go, because that reduces ocular surface disorder in these patients. We know that BAK is it causes harmful effects on the ocular surface, and it is time and dose dependent. A small single drop, 1 drop with some amount of BAK still is okay, but when people like glaucoma who use more than 2 drops, there is an additive effect of this BAK on the ocular surface causing more harm. Now, what is the impact on the quality of life? Now, this study said that increased number of drops caused increased percentage of dry eye symptoms, and there is a decreased emotional well-being in these patients. So it really has a lot of impact on patients' quality of life also, which is a very important issue. Now, ocular surface disorder can present in different forms like SPKs or just a tear film instability or allergic reactions, pseudopemphigoid, frank dry eye, or vortex keratopathy with newer drugs like netaracidil. So we have to be vigilant to look for these signs when we check every patient of glaucoma. This was a test called esthesiometry done, and they found that both corneal and conjunctival sensitivities were reduced in patients using hypotensive drops, and it was more affected in people using timolol, that is beta blockers. Why this is important is these patients don't come and complain to you that they have dry eye symptoms. You have to look for them yourself. And there is always this difference in signs and symptoms. So every glaucoma patient that walks into my clinic, I make sure at least I do a Shermer's for them to detect dry eye. We know goblet cells are important, and we know that goblet cell density is also important for our surgical outcomes of trabeculectomy. But these ganglion cells are damaged because of topical anti-glaucoma drops, and we know that prostaglandin analogs are the best when it's about sparing these conjunctival ganglion cells. This was another study for inflammatory mechanism where glaucoma drops were instilled only in one eye and other eye served as a control. And it was found that the treated eyes had poor tear breakup time, had a higher osmolality, had more hyperemia, had more eyelid margin abnormalities, had poorer tear meniscus. And you can see the electron microscopy photo in these patients where there is a loss of goblet cells and there are cystic changes in the conjunctival epithelium in patients using topical glaucoma drops. Now, again, meibomian glands are also badly affected. We know that the treated eyes, this study says that the treated eyes had higher scores of lid margin abnormality. Their MIBO scores were higher. The more the damaged meibomian glands, higher is the MIBO score. And you can see in the photos on the right side, there are even gradually more loss of meibomian glands. We know that significant higher MIBO scores in eyes treated with prostaglandins and beta blockers. So prostaglandins and beta blockers are more toxic to meibomian glands. So people using these drops, you have to be more vigilant. There was another paper about this cellular toxicity, and it compared toxicity among different drops, BAK and BAK free. It was found that the surface toxicity was proportional to the amount of BAK that was present in these different drops, and the newer drops with preservatives like Sofzia and Polyquad were far more gentle on the ocular surface compared to the drops which had BAK as a preservative. Again, comparing different prostaglandins, travoprost was found to be the most gentle one on the ocular surface with lowest OSDI score. Higher the score, more is the ocular surface damage. Lower the score, better is the ocular surface. This was a small study conducted by us where we wanted to assess surface characteristics, inflammation, and dry eye symptoms in patients using glaucoma medications. We took patients that were using at least drops for at least 3 months, and we did plethora of tests on these patients to evaluate their ocular surface. And we also did OSDI questionnaire, and glaucoma patients had tolerance to medication questionnaire. Now, Inflamadry is done with this simple kit, and it is very helpful. We find large number of glaucoma patients have a positive Inflamadry test, and treatments like Lipiflow help a lot or in reducing surface inflammation, along with drops like cyclosporins and mild steroids where inflammation is high. The meibomian gland score was done with a Sirius, or we also use Lipiview to do that. Then this is a very interesting finding of lid viper epitheliopathy. Now, the lid viper zone is between the mucocutaneous junction and a subtarsal fold, and when it moves on the surface, there is a staining. We use Lisamin green to stain this area, and this is the grading. And I'll just go ahead. These are the biostatistics that we use to analyze our data. We found that inflammatory, although MMP9 was equally positive in both groups, we found that positive results were associated more with dryness, increased corneal staining, and higher lid viper epitheliopathy. Then meibomian gland loss was higher in glaucoma subgroup. Tear breakup time was, although not statistically significant, but was more worse in glaucoma subgroup. Corneal staining was found to be more in glaucoma, while conjunctival staining was found more in non-glaucoma group. Schirmer's was definitely worse in glaucoma subgroup. Lid Piper epitheliopathy, the staining was higher in upper lid and both lower lid in glaucoma groups compared to the non-glaucoma group. And OSDI scores were, although they look almost similar, but again, the issue was, as I pointed out in the previous slide, that their ocular surface is sometimes affected and the sensitivity is low. So although they have ocular dry eye, they don't express it to the doctor when you just go through the questionnaire. So that is another issue while treating these patients. Many of them are diabetic also with peripheral neuropathies. So it is important to check ocular surface sensitivity also in these patients. Now, if you just take all the findings together, that in all parameters, glaucoma patients fared much poorer than the non-glaucoma subgroup. Tolerance to medication, almost 100% of glaucoma patients had at least one symptom, and redness and dry eye feeling was the most reported symptom in these patients. Patients exposed to glaucoma are likely to have worse ocular parameters. They had higher inflammatory response and greater loss of meibomian glands. So it is better to stick to the preservative-free medications while treating these patients. A lower amount of dry eye, we just start with HPMC or basic drops, and as it becomes worse, we add sodium hyaluronate or dextran or other components to the tear substitute, or even the autologous serum. Punctal plugs are controversial in glaucoma patients because with punctal plugs, the drop retention on the ocular surface might increase with worsening the effect of BAK if you're using drops with BAK. We find a lot of glaucoma patients having meibomian gland problems along with poorer meibom scores. So we do LipiFlow, and we have found that large number of patients' ocular inflammation improves after doing a LipiFlow. It is better to stick to other forms of treatments like SLT to reduce load of glaucoma medications, and MIGS, which will be launched soon, will be a real boon for us because that preserves ocular surface to the maximum. So thank you so much. And as a true Mumbaiker, I'm just waiting to get into VT station in the peak times.
Yeah. Thank you, Dr. Nitin. That is a very common problem in nowadays with the patients who are using the anti-glaucoma medication. So I request the next speaker, Dr. Paraj Dave, to talk on newer drug delivery systems in glaucoma.
Good morning, everybody. Good morning, Arup sir. Good morning, Dr. Panda sir. Good morning, everybody. Good morning.
Good morning, ma'am. Good morning.
Good morning.
Good morning, ma'am. Good morning.
Good morning, Dikshit sir.
Good morning, Ragini ma'am.
Good morning, Tushar sir.
Good morning, Ragini.
Can I start? Is everything set?
Yeah.
Okay. At the outset, I'd like to thank BOA and Dr. Manish in particular for giving me this opportunity. So my talk will be under the following heads, and we'll discuss each one by one. So my talk is on the newer drug delivery systems. What should be the ideal drug delivery system? The ideal system should have a long duration, preferably more than 6 months. It should have a 24-hour IOP lowering. The intraocular pressure lowering should be at par with the prostaglandin analog, similar to it, and with a similar adverse effect profile. The system should be bioerodible to minimize the need for invasive removal, and the installation or injection should be an in-office procedure. So let us start with the periocular inserts. One particular insert is this bimatoprost ring implant. It is a 24 to 29 millimeter ring which rests beneath the eyelid, and it has bimatoprost embedded in the silicon matrix, and it gives us a sustained release of bimatoprost up to 6 months after installation. This is how you actually put the ring inside the eye, just to show you how it is done. In a study done in this particular study, wherein a bimatoprost ring plus artificial teardrops were compared with a placebo insert with timolol, and what they found out was that the ring was in place in 88.5% of the patients at the end of 6 months, Dislodgements were there, 28 dislodgements were noted, and all were promptly noticed by the patient themselves. The side effect profiles and discontinuation rates were similar between the two groups. However, non-inferiority to timolol was not achieved. Another device is the TOD, or the topical ophthalmic drug delivery device. So this is developed by Amorphex Therapeutics. It's a flexible device which floats on the tear film, and it is concealed under the upper lid. They have completed phase 2 trials with timolol, and this has demonstrated safety, comfort, retention, efficacy for about 180 days. And this can be used for other ocular disorders as well, where chronic therapy is required. Moving on to the punctal or canalicular plugs. This particular travoprost plug is developed by Ocular Therapeutics. So it is basically travoprost encapsulated in resorbable hydrogel rod. This has to be placed in the superior or the inferior canaliculus, and it is fluorescein incorporated in order to make it easily accessible and visible. In this particular study, they used 26 plugs which were placed in 17 patients, and what they found out was that the IOP reduction was 24% on day 10, and this reduced to 15.6% on day 30 from baseline. One required removal of the plug due to epiphora as a symptom, and the retention rates were not that great. They were only 42%. Another phase 2 study, in this particular study, what they did was they compared the punctal plug plus artificial tear, which were given in the form of eye drops, versus timolol drops plus non-drug eluting plugs, and they did a 90-day follow-up. So what they found out was that, in fact, IOP lowering was better in the timolol plus no drug plugs. This was probably because of the longer drug retention in the timolol group due to the punctal occlusion. The retention rates initially were good, around 90% at the end of 60 days, but then this gradually reduced to 48% at the end of 90 days. Moving on to the anterior chamber implants. So this bimatoprost sustained release implant is now US FDA approved, and it is available under the brand name of Durista, marketed by Allergan. So this is basically based on the Novadur platform. The Novadur platform is the platform which our retina colleagues use to inject the Ozurdex implant. So this is the same platform. So this is an intracranial injection which is based on the 28 gauge applicator system. Phase 2 studies have shown that the IOP lowering of the implant is comparable to that of topical bimatoprost group, and the adverse effects documented in this study were hyperemia, foreign body sensation, eye pain, lacrimation, conjunctival hemorrhage, and punctate keratitis. So this is how this is the size of the implant. This is how small it is. This is the applicator inserter system, and this is the implant, the gonioscopic view in the inferior angle. Phase 3 multi-center studies have shown that the efficacy is comparable to timolol twice daily, and the IOP reduction is to the tune of 30% from baseline. This sustained release implant had fulfilled the non-inferiority criteria, and after this important, interesting feature which was noted was that after 3 treatments, 80% of the patients required no treatment for another 12 months. So this was thought to be because of the sustained suppression or reduction in the episcleral venous pressure. This is the iDose sustained release implant. So this is basically a titanium implant where drug elutes through a membrane cap. The insertion is similar to iStent, which is used in MIGS procedures. The anchored portion is advanced through the trabecular meshwork into the scleral tissue. Phase 2 trials are currently underway to establish non-inferiority to timolol. But when the disadvantage of this implant is when it depletes, it has to be removed and replaced. So the obvious concerns with the intracranial implants are that they are invasive. There is irritation from injection. There's difficulty with explant if complications arise. And there are obvious concerns regarding the corneal endothelium. Moving on to the subconjunctival implants. And now there are numerous subconjunctival implants of glaucoma medication which are under development. However, most have the following limitations: that they all induce a local immune response. The release is non-linear. They follow non-linear release kinetics. And our understanding of scleral permeability is less vis-a-vis the corneal permeability. And there is obviously a need for operating room requirement. Moving on to the last group, that is miscellaneous. The various drug-eluting contact lenses are currently under development. There are also microdose sprays which are being developed, wherein the medication would be released as a spray, and this would improve the head positioning and it would result in less tearing. Also, you have various bioadhesive matrices which are under development, which would stay on the ocular surface for extended period of time. Another interesting study which at least I am eagerly awaiting the results of, is this intravitreal brimonidine, which is currently under study for reducing geographical atrophy area in ARMD. So as a corollary, it may also reduce the intraocular pressure as well. So it will be interesting to see the detail of the results as to how effective this is in reducing the intraocular pressure. So to conclude, I'd like to say that basics of how to instill eye drops, spending time with the patients, telling them that punctal occlusion has to be done, keeping space between two medications, etc., is still of paramount importance. The implants have the potential to dramatically improve the compliance in glaucoma patients, which is historically very, very poor. The patient's attitude for implants, unfortunately, may not always be very forthcoming, and the search for the ideal drug delivery system is definitely still on, and novel innovations have the potential to reshape glaucoma management. So with this, I'd like to conclude. Thank you so much for your patient listening.
Thank you, Dr. Parag, for giving us a talk on the new modalities in the glaucoma management, and that is very much needed in the coming era, because looking at the compliance of the anti-glaucoma management, it will be a really boom. So thank you, Dr. Parag. So I invite our next speaker, Dr. Shefali Parekh, to talk on nanotechnology in glaucoma management.
Unmute your mic, Shefali.
Yeah, it's fine.
Yeah. Share your screen. Thanks.
Yeah. So good morning, everybody. I would like to thank BOA for giving me this opportunity, and I'm going to talk on nanotechnology in glaucoma management. Now, before I go into the details regarding it's not changing. 1 second, it's not changing. Well, 1 second. It's not able to share it.
Shefali, you need to use arrows instead of space bar.
Yeah, no, I'm doing that only. 1 sec. Yeah, so yeah, it's working. So before I go into the detail regarding its use in glaucoma management, just a little bit about what is nanotechnology. So nanoscience is the study of phenomena and on manipulation of material at atomic and the molecular and submolecular level, and any technology that deals with the design characteristic at this size, that is referred to as the nanotechnology. Now, the concept of nanotechnology is not new. Its history dates back to nearly 6th century BC. Recently, the pottery has been excavated in which the coating of the nanomaterial has been found, and it still retains its stability and adhesion. So nanotechnology is basically the convergence of science and engineering, and it has helped medicine to work with increased efficacy and better efficiency. So just to put into perspective, so I have just compared it with the micron. What is the difference between micron and nanometer scale? We are used to seeing RBCs under the microscope. We see it with the great difficulty. So when you compare the micron with the nanometer, 1 micron is equal to 1000 nanometers. So you can understand that when we deal with nanotechnology, how much smaller the size or the tiny particles we are dealing with. So what makes this nanotechnology different from macrotechnology? It is basically the difference in this particle size. Because of this minute size, the surface area of these particles, they decrease tremendously, and because of which the drug carrying capacity of these particles or of these nanoparticles, it increases drastically. And also because of the small size, it changes the physical properties. Like if you take the copper, which is when it is a macromolecule, it is a larger, it is an opaque substance. But when you convert it into the nanoparticle, then it becomes transparent. So it drastically changes the physical property. So I'm not going into detail regarding the epidemiology of glaucoma. We know it is ever-growing burden on the society, and by 2040, its projected prevalence is going to be 110 million. And the current modality of treatment at this point of time, we all know, is the topical drops. However, it has its own limitation, like reduced bioavailability. It causes tissue irritation and damage. There is a reduced shelf life. Target, it is not able to reach at the target in time. So there comes the role of nanotechnology. It provides the sustained release. It improves the bioavailability. Basically, all the limitations of the current topical anti-glaucoma medication, they can be more or less overcome by this nanotechnology. This is a short video which I have kept. This you can see, these are the shiny particles, which are basically the nanoparticles. They are such a small particles. It increases the surface area, and also it improves the penetration into the cornea, because of which the drug availability at any site increases tremendously. Now there are different nano drug delivery systems. This is list of these drug delivery systems, and we choose this delivery system depending on the drug site, target tissue, and the route of administration. Now, a little bit about the scientific evidence that we have regarding the nanotechnology. In fact, whatever Dr. Parag has talked, more or less everything uses this nanotechnology. So currently for this, we have this list of nano drug delivery system. And for this anti-glaucoma medication, we are using this nano drug delivery system. Then we have nano devices. Then we have intraocular pressure monitoring device. It has its role in protection, regeneration, gene therapy, and also regeneration of the trabecular meshwork. We cannot go into detail, but little bit about the glaucoma medication and a nano device I will be talking. Now, if you compare the commercially available xylitol with the latanoprost loaded liposome. Now, liposome is the drug delivery system. So here, if you see the red color graph, that is for the latanoprost loaded liposome. And when you give the first injection of this latanoprost loaded liposome, its effect is more or less at par with the commercially available xylitol. And when you give the second injection of this liposome at the end of 5th month, then the effect of this, it continues for another 6 months, and while its effect becomes better compared to the commercially available drops. Similarly, timolol, a lot of research is going on. There are different drug delivery systems, and very recently an enzyme-triggered release contact lens system was engineered for timolol delivery using the nanodiamonds. Brimonidine, we have drug delivery system inserts, which it is shown to have better IOP lowering compared to the commercially available drops. Similarly, we have combination of timolol and dorzolamide, where the drug delivery system is nanofiber patches, and its efficacy lasts for up to 3 days. Methazolamide, if you see here, red color graph, the IOP lowering efficacy of methazolamide is much better compared to the commercially available methazolamide or plain nanoparticles, or even the sodium chloride. So basically, this drug delivery system, it increases the efficacy, and the dosing is also reduced drastically. Duresta, already Dr. Parag has discussed, it is already launched in the USA market, and in India it may be expected soon. It is a drug-eluting polymer, and in fact lasts for 3 months. And Artemis trial have shown its efficacy to be 30%. It causes 30% intraocular pressure reduction by end of 3 weeks. Similarly, we have nano drainage devices, where you can load these devices with the mitomycin antifibrotics like mitomycin C and 5-fluorouracil, and it slowly releases the 5-fluorouracil even till the end of 28th day also. And this nano drainage devices, they operate with ferrofluidic nanoparticles, and they have supramagnetic properties. Just to that how smaller the size of these nano devices are, you can compare it with the tip of the pen, and they are able to maintain the pressure between 7 to 10 millimeters of mercury. One of the prototype is ND implant, which is being developed, and it is composed of nanoporous membrane and polymeric shaft. Similarly, we have punctal plug delivery system. Dr. Parag has already discussed. They are sustained release travoprost and latanoprost punctal plugs, which are already developed, and in the travoprost is in the market also. Similarly, we have a 24 hours IOP monitoring device like Triggerfish, which are again based on the nanotechnology. the intravitreal injection of the glial-derived neurotropic factor for the neuroprotection of retinal ganglion cell, which is being used with the microsphere. It has shown 12.6% increase in the retinal ganglion cell density in 8 months, and also increase in the cell survival. Also, it has role in gene therapy. So to conclude, the nanotechnology is definitely our future generation medicine, and it overcomes a lot of limitations of the currently available anti-glaucoma medication, as it increases the bioavailability and ensures sustained target delivery. However, this is a new medicine, and like this pandemic going on, we are not much aware of what are the drawbacks or what are the side effects. So the safety concerns, especially the nanotoxicity in the form of particle, excipient, contaminant, and inflammatory toxicity, needs to be addressed. Thank you. Thank you all.
Thank you, Dr. Shefali, for updating the newer technologies for the nano delivery systems in the drugs, in the walls. It will be a great help in the glaucoma therapy. Thank you, Shefali, ma'am. So I invite Dr. Sushma Tejwani to give her talk on trabeculectomy and its modification.
Good morning. Thanks, Dr. Nitin. And I must thank Dr. Manish, Sunil, and BOA for giving me this opportunity. So after listening to the high-tech nanotechnology talk, I'm bringing you back to the very conventional trabeculectomy technique and its various modifications. Well, so I'm going to talk about certain general principles, then surgical techniques, and how we use antifibrotics, releasable sutures, ologen, and needling in trabeculectomy. Well, different techniques have different indications, and the choice largely depends on multiple factors for choosing any surgery. So for that matter, in glaucoma, it depends on what is the target IOP for an individual, what are the previous surgeries patient has undergone, how is the risk profile, and what is the preference of the operating surgeon. In addition to definitely taking into account what is the patient's opinion about a particular surgery and what are the expectations, how do you expect the patient to come post-operatively or follow your advice post-operatively. Well, keeping in mind those things, the broad indications for trabeculectomy are usually when optic nerve function is failing and is likely to fail on maximum tolerated medical therapy. The laser treatment is not able to bring the target IOP. And this also includes patients who have poor compliance or side effect or poor accessibility or affordability to the medication, and still progression of visual field. EGS has also suggested that cases who present to you with advanced glaucoma and very high IOP at presentation can be directly taken up for the surgery or trabeculectomy as well. Interestingly, trabeculectomy still remains the most popular surgery and has lots of possibilities of customization and manipulation even after the surgery. So let's go to the techniques one by one. So I'll just show a basic conventional technique of trabeculectomy. Well, here, what I'm showing you is a limbal-based conjunctival incision. I still use it for certain patients like young patients, children, where I don't want the limbal incision to get disturbed. So once you retract the flap and cauterize the episcleral vessels, then a triangular scleral flap, partial thickness flap is taken. Some people prefer to take a rectangular flap. Any triangular or rectangular does not matter much. Based on your preferences, you can choose that. This is a partial thickness flap. The important thing is that you have to maintain the same plane. This is the marking of the trabecular meshwork block that we are going to cut, and then you can use a straight 1Rs or MBR or a blade to make it full thickness entry. You can use a Kelly's punch to remove that trabecular meshwork block, or even the straight 1R scissors. You can hold the block and cut it across. Usually 1 to 3 millimeter is what we do. And then a full thickness peripheral iridectomy is done. You can see the pupil being pulled there. And then you have to make sure that it is a full thickness iridectomy before you close the scleral flap. Scleral flap is sutured with tenonylon sutures, a single suture or 3 sutures based on your preference and the amount of leak that you see. Now, limbal-based flap, I prefer to suture with a continuous purse string suture with atovicryl. so that there is minimum amount of knots. So these flaps are particularly very comfortable for the patient because they hardly have any irritation. Well, many a times, or rather majority of the times when we talk about glaucoma, we have to take a combined surgery. That means cataract and glaucoma surgery. So when we are operating for a patient for intraocular pressure lowering and there is a visually significant cataract is when we plan, or a patient where we are taking up for cataract surgery and patient is on multiple medications for glaucoma treatment and there is advanced glaucomatous optic neuropathy, that is where we do the combined surgery. So based on the level of desired IOP control and what is the anticipated benefit for cataract with cataract extraction in a given patient is when we decide that we would do the combined surgery. Just a couple of things that there is hardly any difference between one site or a two-site approach. So you can go ahead with whatever you prefer surgically. There are not much differences in limbal and fornix-based conjunctival flap in terms of outcome. Well, mitomycin C should be used in most of the cases when you're particularly doing a combined surgery, unless there is a contraindication for its use. So when you combine a phacoemulsification with trabeculectomy, what I simply do is take a side port and make a CCC and form the chamber with viscoelastic and then create a fornix-based conjunctival flap, like we usually do in any trabeculectomy for that matter, and raise a partial thickness scleral flap. After marking the trabecular meshwork, you can enter through the same incision if you prefer a single side and complete the phacoemulsification, insert the lens in the bag, and then complete the trabeculectomy steps like removal of a trabecular meshwork block excision by whichever method you feel comfortable with, and peripheral iridectomy, and then closure of the scleral flap as earlier. The closure of conjunctival flap is a little different here. Here I'm using interrupted suture. The important thing is that you have to anchor these sutures to the episcleral tissue at the limbus so as to avoid the retraction of the conjunctival flap. If you have to combine a trabeculectomy with a small incision cataract surgery, it is very simple. The incision that you take for a small incision, you can take it a 1 millimeter anterior so that you don't have to create an additional triangular or rectangular flap. This particular case, I'm using a Blumenthal incision, and then after completing the cataract extraction, same way, remove the trabecular meshwork block and PI, and then you can use a single suture or two sutures close to where you have done the trabecular meshwork block excision, which can work as a filtration site. The closure of the conjunctiva is same as I showed you in the previous video, or the fornix-based flap. Well, the role of antimetabolites is very, very important. Mitomycin C has become almost a rule in most of the situations where we do trabeculectomy. The concentration can vary based on the amount of drop that you need in a particular patient. It can vary from 0.2 to 0.4, and it can be used for a duration of 2 to 5 minutes. Even post-operatively, injections is something that are used by some patients. So what we usually do is that according to the Moorfield safer surgery system, the mitomycin C is applied not at a single site, rather multiple sponges are used at a wider application area so that you can get a more posteriorly directed flow and a posteriorly directed blend. There are other antimetabolites which are used, 5-FU being the next more popular. The others like anti-VEGF, TGF, beta, monoclonal antibodies, etc. are not yet in the clinical use. There is not significant evidence yet. Well, 5-FU particularly is preferable in the post-operative phase is what I prefer. When you have a congested bleb or fibrosis, early fibrosis coming up, you can, in the clinic itself, you can give a subconjunctival injection of 0.1 ml or 50 milligram per ml. That is how it is available commercially, so you don't have to dilute. So just inject close to the bleb, and 3 to 7 injections like that can be given at weekly intervals. It can really work very well if used judiciously in the early phase of bleb congestion or fibrosis beginning. Well, another technique that we can use in trabeculectomy is a releasable suture. When you particularly want to avoid hypotony in the initial phase, but you need a relatively lower target pressure for future. When mitomycin C is contraindicated and you're anticipating hypotony in the initial phase, so when the surgical outcome is not very predictable and you need to keep a scope for adjusting the intraocular pressure, Post-operatively, by suture release is when these sutures come handy. You can use 1, 2, or 3 releasable suture based on amount of adjustment that you need post-operatively. However, these are not preferable in children or patients who cannot cooperate on slit lamp post-operatively. So the technique is again very simple. After you take an apical suture to close the scleral flap, you can use a partial thickness corneal tunnel here for that, keeping that end of the suture. And when you're taking a side suture, you just use 4 throws, a single knot, and use this thread's loop to tie the knot. You can release it and see whether it is releasing, and then cut the edge so that the cut edge stays in the corneal tunnel so as to avoid the windshield wiper effect. When post-operatively, you need to remove it. Again, it is very simple. You either need to cut it when you don't want to release the suture or remove it. So both I'm showing here. It's a slit lamp video where you can remove this, take this edge out of the corneal tunnel that you had created during surgery, and I'm using a needle. So hold the suture, and with the help of the needle, you can cut the edge so that the edge is no longer, the end is no longer available or making it prone for the infections. Now, if you want to release it, same way, you have to remove this or take it out from the corneal tunnel that you had created. And once the suture is out, you can pull it in the downward direction. So as you pull it out, the whole suture, the knot opens and the whole suture comes out. What is important here is when you release the suture, post that, you should do a Siegel's test to make sure that there is no leak from the area. And if at all you find a micro leak, you can use a bandage contact lens. The other options for removing the sutures are laser suturolysis when you don't put a releasable suture. However, that definitely requires use of a lens and a laser and cannot be done in all cases. The suture should be visible for you to be able to do that. So that's how releasable sutures have an advantage over laser suturolysis. Now, another important implant that is in vogue is a biodegradable collagen matrix implant called Ologen. Well, Ologen is again used like a spacer after you close the, while you're closing the scleral flap. It is used between the conjunctiva and the sclera so as to create, avoid fibrosis. So as far as the IOP lowering efficacy is concerned, it is definitely not as high as with MMC. There have been studies which have compared that when you use Ologen with MMC, so it does not improve the efficacy. However, it is being more popularly being used as to avoid that thin-walled avascular bleb that you get after MMC. I don't have much of a personal experience with Ologen, but this is what I'm talking about based on the reported literature. Now, needling is another thing where trabeculectomy, when tends to fail, it can come as a savior. But what we need to understand is it is used when the external ostium is closed due to subconjunctival fibrosis. However, the internal ostium has to be patent. It can work for as long as even 6 months later after the surgery. So in initial phase, when you have such situation that internal ostium is closed, or when you are seeing there is congestion, you can use digital massage or suturolysis, etc. But once there is organized fibrosis, these things do not help. And that is when the needling can revive the bleb. The procedure is very simple. It can be done under topical anesthesia. So what you need to use is a bent 23 gauge needle, and you can enter to a little away from the bleb and reach the external ostium where you are expecting the fibrosis. You can use the needle tip to excise or cut that or release that fibrosis around the external ostium so that you can regain the aqueous flow from the internal ostium. Once you have done enough dissection to release the fibrosis in external ostium, you need to make sure that you enter the anterior chamber through the internal ostium so that the flow is established. As you take out the needle, what you have to make sure that there is no leak from the area where the needle is exited. And if you see that, you can suture it off by a single suture. And that is how needling can be used. Usually when I do needling, I give a 5-FU injection at the adjacent site so as to avoid the further fibrosis. The possible complications with the needling can be overfiltration, hyphema, or subconjunctival hemorrhage. It can also cause hypotony. So those are the things that we need to keep in mind, but it is still a very safe and effective procedure and a low-cost procedure before you actually want to do a second trab or more interventional procedures. So just to conclude, there are lots of scopes of customization for trabeculectomy surgery. Like if you need lower IOP or based on your target IOP, you can alter the dose of mitomycin C and duration so as to have the achieved target IOP. You can use releasable sutures if you want to avoid particularly early post-op hypotony and still achieve the lower pressures long-term. Digital massage, laser suturolysis or release of suture or use of 5-FU injections if the early post-op increase in IOP or bleb congestion is what you see. Ologen can be used if you're worried about very thin, fragile MMC bleb in a given patient. And there is still possibility to revive the bleb with needling, even if the pressure increases in the late post-operative phase. Well, thank you for your kind attention.
Thank you, Dr. Sushma, for the point-to-point talk. I know it's a very vast topic, but you covered it well and a very good video presentations. Thank you, Dr. Sushma.
Thank you.
Now I request Dr. Arup Chakravarti sir for his presentation, Small Pupil in Glaucoma.
Good morning, friends, and thanks a lot, Manish and the organizing team for having me here today. The first approach in managing any small pupil situation is to achieve a maximum pharmacological mydriasis. In certain situations, the pupil size is still small or suboptimal, and we need to think about alternate strategies to have a larger pupil to make the subsequent cataract surgery safer for the patient as well as for the surgeon. Now, when I peruse the program booklets and I see topics like phaco in unmodified small pupil, phaco sans OVD, phaco sans BSS, so I feel it is just phaco sans conscience. So whenever you have a pupil which is less than 3 to 4 millimeters, or in certain situations when even it is little larger, but has associated comorbidities, for example, a shallow anterior chamber, a unhealthy cornea, very hard cataract, we must resort to a small pupil strategy. And there are a plethora of possibilities, plethora of devices available for us. And personally, these are the devices which are there in my armamentarium. But what I'm going to talk to you today is to have a strategy so that we can reduce the dependence on these devices. Because a device, after all, is an additional intervention, and that can always have associated complications. It has a learning curve and it is expensive. So I'm going to discuss with you certain pearls or certain things that I always use in my practice, and use this so that I avoid using devices in most of my cases, and only as a last resort where nothing else works, I'll be using a device. So it is important for us to know what are the exact etiology of the small pupil. From 2004 onwards, after the IFIS was published by Campbell and David Chang, so it has become a very important piece of history. So I always try to find out, am I dealing with an IFIS candidate, or is it a traditional etiology of small pupil that I'm dealing with? And we have a system where the nurses run through all the all the medications that can give rise to miosis, and then and IFIS, and those patients are segregated, and we have a separate strategy. Pupillary fatigue is something which you need to avoid, because if you are using cyclopentolate the day before the surgery, it has been shown that it reduces the pupillary dilatation by a factor of 0.73 millimeters from the situation when you have used trabeculectomy at 1%. So if you have a pupil, if you want to dilate to 6 millimeter, and then you get a 0.73 millimeter less dilatation because I've used cyclopentolate the day before, and it has resulted in pupillary fatigue, your pupillary area is going to be reduced by 23%. So if at all you have to dilate the pupil for your workup, either the fundus workup or whatever, use trabeculectomy 1%. And then another thing is, as I mentioned earlier, we'd like to pick up the IFIS candidates. So in the literature, there has been a discussion that a pupil size not dilating, maximum mydriasis, less than 6.5 or 7 millimeters or 8 millimeters, you need to be very careful about those patients because they may have intraoperative meiosis. And actually, there was now when you so these measurements are cumbersome. You have to take an anterior segment picture, and then you may have to use a caliper preoperatively and to find out what exactly the proportions. So this particular paper has described the intuitive the PL ratio, pupil to limbal diameter ratio. So you just look at the pupils, the patient's dilated pupil, and then if it is less than 60% by intuition, you feel it less than 60%, then you can think about the patient developing IFIS in the intraoperative period. So many a time I get pupils like that on the surgical table, and the nurses say that, doctor, this patient is allergic to tropic acid plus, so I have used only homide or the cyclopentolate. But what I tell my staff is, on the day of the surgery, it is still possible for us to use tropic acid plus drops. So this is what was the maximum dilatation with only tropicamate, without the plus, without the phenylephrine component. And when I added it, I got an adequate sized pupil, and if safe emulsification was done. This is the post-op picture. This is the day one picture. Because we are going to put topical steroids immediately after the surgery, and on the first day about 6 times a day. So the allergy factor really doesn't come into the consideration. In the bargain, you get a well-dilated pupil, and you can avoid pupillary devices and perform a safe surgery. So we use adrenaline in the infusion fluid, and half an ampoule of 1 in 1,000 preservative-free adrenaline. Some surgeons have used intracamerally in IFIS patients, though I'm not a big fan of any intracameral use. Recently, we had a product launch called Phenocan Plus from a company, Indian company. Actually, this is already available in the Western market, a product called Midrain, which are the same components. So this actually was looked into and was published in a JCRS article in March 2018. And it showed that there is maximum pupillary dilatation within 30 seconds. And the mydriasis is stable. Pupil doesn't come down. And you don't require really any additional pupillary dilatation devices or any additional doses intraoperatively. And the important thing is, that when they compare the decrease in the pupillary size more than 3 millimeters, in the topical group, it was seen in 20 patients, whereas in this particular group where Midrain was used, it was only in 1 patient. Now, among all the devices, I am a big fan of these iris hooks for various reasons, and these are disposable devices, very simple to use. You just need a 27 gauge needle to manipulate these iris hooks into the patient's eye. And though I have, why you prefer the iris retractors over the other ring expanders? You can use it even uveitic pupil, where there's posterior synechia, people have become ectopic. It can give selective dilatation. For example, when I'm doing a vitrectomy and there is the reverse pupillary block, the lens iris diaphragm retropertion syndrome. So I can just use an iris hook just to gently lift up the iris from the anterior lens capsule. So the tremendous deepening of the anterior chamber, which otherwise may happen, does not occur. It can be safely used in phakic and vitrectomy's eyes. If we use ring devices in these cases where the pupil post-vitrectomy, some of these high myopic patients, when the pupil comes down and becomes large, the ring devices may dislocate and it may go into the posterior chamber. So it may be difficult, additional maneuver for you to retrieve it and reapply it or take it out, whatever. And these devices, the iris hooks, can also be used once, after the capsulotomy has been done. I'll just show you a video when there is intraoperative meiosis and you feel that you're not able to manage the nucleus or the cortex adequately without a larger pupillary dilatation. And then in certain situations, like when you have not expected a significant zonulopathy, or whenever there's a zonular dialysis, you can use the same iris hook, though if a capsular hook is preferable, but in this kind of situation, you can definitely use an iris hook to stabilize the capsular bag. For example, then these hooks can also be used to stabilize the ring, the capsular tension segment, which has got this eyelet. You can pass it through the eyelets and stabilize. So you don't have to suture the capsular tension device intraoperatively. At the end of the surgery, it can be done. So let us see this video. Now, this was a intumescent cataract and a very shallow anterior chamber. And I started off surgery. There's viscomydriasis, pupil dilated extremely well. And this patient developed IFIS intraoperatively. You'll see here pupil becoming small, surgery becoming difficult. So I decided to use an iris hook in between intraoperatively. So one precaution here is when you apply the iris hook, and the same thing also holds true for any ring device, you make sure that the hook does not hook the capsular rhexis margin. In this particular case, I had a rhexis tear which went to the periphery. So you inject OVD between the iris and the anterior capsule, create a very friendly zone, and ensure that the iris hook only hooks around the pupillary margin and it doesn't take the rhexis margin. So this is an important tip to keep in your mind when you operate on these patients. It has potential problems, and of course, any device, anything will have potential problems if you don't handle it carefully. My other non-hook devices that I really enjoy using is the Malignant ring version 2, which can go in through a very small incision, and it gives rise to 6.25 or 7 millimeter pupil. It has a very thin profile. BH device, BHEX by Suven Bhattacharya is again one of my favorite devices. It has a very low vertical profile. I have used iris expanders from Beaver as well as from the OSCs. They're pretty good. And there has been a study. These are some of the devices. Gupta ring has just come into the market. I've used only trial. I've not been very comfortable using these devices. So which device is superior? Now, this particular study in JCRS, it compared the Malignant ring with the Visitec eye ring. And the results were very interesting. It showed that, with the Malignant ring, the pupillary cosmetic effect postoperatively was worse compared to the Visitec eye ring. And this is, again, a comparison between whether you should iris hooks or Malignant ring or phenylephrine. This is the largest study published in Eye recently, I think from the Moorfields group. And the results were, again, very interesting. It showed that the Malignant ring had maximum incidence of iris sphincter tear compared to iris hooks or by intracameral myotics. And the other complications seem to be little more, atonic pupil, corneal edema, cystoid macular edema, DM tear was more in the Malignant ring group. So this group, their take-home message was, though the complications were not high with any of these, but with Malignant ring, somehow the complication rate was higher. So friends, whenever I'm dealing with an IFIS pupil, make sure that, you follow the general surgical principles. So wound is properly constructed, hydrodissection is done more in a slower manner, in a gentle manner, lower all irrigation aspiration parameters, have an appropriate OVD strategy. And if it is really a very small pupil to start with, you don't hesitate in using a mechanical expansion device. So in conclusion, you need to know what exactly is the etiology classification. Is it an IFIS candidate that you're dealing with? Pharmacologic modulation is extremely important. Use a sphincter sparing non-device option to start with, because postoperatively cosmesis will be much better, particularly if you're using a advanced technology intraocular lens. And a device use has to be considered when a patient has significant comorbidities, a hard cataract, a shallow anterior chamber, questionable zonular status, and if the pupil is very small. Thank you so much for your kind attention.
Thank you, Dr. Arup sir, for such a wonderful demonstration, how to maximize your pupil during the surgery with the help of the pharmacological agents, with the devices. Thank you very much, sir. It was a very good and informative presentation as usual, sir. So next, I invite Dr. S.S. Pandav, sir, to speak on the Ahmed wall globby.
Do we have time?
Yes, sir. We have time. You can go ahead. I mean, it's an important topic.
I'll make it as short as possible. So, Ahmed glaucoma value implant, my technique. So I'll basically show you a few videos of my technique, how I do it. And this Ahmed AGV is actually a valve device. You all know it, and this is used to control intraocular pressure in refractory glaucoma, where other things have failed. So that means when the drugs are not working, the laser is not working, and you've already done a couple of surgeries, at least one trab with MMC has already been done, and then you tend to switch to a glaucoma drainage device. So this is a valve device, so there are less problem with the hypertonic postoperative, and you have less complications to deal with. AGV is also used as a primary surgery in certain situations where glaucoma surgery is unlikely to fail. Something like, if you have a neovascular disease which is not well controlled, or uveitis. So I'll just straight away go to the steps. And the first and the most important step is that once you have prepared the patient for surgery, draped, and you have put the speculum to expose, then the first thing is to make a peritomy. And the way I make it, I expose the superior-temporal quadrant unless for some reason it's not available. So make a small radial incision and cut the tendons capsule as well as the conjunctiva in one go at the limbus. And you just need to expose one quadrant, but it's better to be a little generous with the incision so that you don't end up stretching and manipulating tissue. So once it is done, so you can see this, the quadrant is exposed very neatly, and you can clearly see the demarcation between the anterior and the posterior part of the sclera. The posterior part of the sclera is actually a little avascular than the anterior part, and this demarcation is by the line of insertion of the muscles. So this is important to identify this, because I'll place my implant entirely in the avascular part and not in the vascular part anteriorly. That means I'll push it behind the line of insertion of the muscles. So once that is done, we are ready for the second step. And the second step is to prime the tube. So it's very important the valve AGV must be primed, because this has a membrane valve somewhere here, and initial opening pressure is quite high. It could be 50-60 millimeters of mercury pressure. So if you have not primed the valve, it's not going to open in the post-operative period, and this is going to be a primary failure. So this step is very important to establish a communication, the fluid communication through this system. And once that is done, you are ready to put this implant basically into the scleral, the pocket that you created. So I like to put the implant a little far away, at least 9 or 10 millimeters from the limbus. So that is clearly in the posterior, behind the line of insertion of the muscles. And this is a part of the sclera which is a little less vascular as well. So I use pre-placed suture, about 6 millimeters apart. So that's roughly the size of the eyelets on the implant. And I use a spatulated needle on a 6 or 5 dacron suture, but you could use any suture. I prefer this needle because these needles are specifically designed for retina, retinal buckles, and basically to pass suture the sclera. So they are much safer than other needles, and for that reason, I basically use this needle. So once I have put the pre-placed suture, just insert the implant, gently into the pocket. It should go very easily. Actually, you don't have to use any force. If you have to use any force, that means your dissection is not good, and then you should go back, look at the scleral pocket, the pocket that you have created, subtendinous pocket that you have created, and then if there's any problem there, sort it out before you put the implant. And once the implant is actually put into the place, you could do a little bit of cautery if required. You don't need much cautery, but if there's too much vascularization, then you can do a gentle cautery. And after that, you are ready to put the implant basically into the tube into the anterior chamber. Now, what I am here doing is I have cut the tube to the desired size, so that is about 2 millimeters in the anterior chamber, after insertion. And I have to figure out where would the tube enter. And the entry of the tube would be at the point where the scleral spur is there. So I figure out where the scleral spur would be, and I would go about a wivel length behind. So I'll go about a wivel length behind the expected point of entry, and that will give me at least 2 millimeters of tunnel, or you can go a little behind to have 3 millimeters or tunnel. So ideally you should have about 2.5 to 3 millimeters or scleral tunnel through which you would push this needle. So I'm pushing the needle intrasclerally, and when I reach that point, I'm going to turn this a little to the side and also into the anterior chamber. So this is, I like to make a curved track actually, just to get a little more length, and also is more so that it fits in snugly. And if you put the tube straight in the anterior chamber and if it's longer, then it's more likely to have endothelial touch and also endothelial loss. Now, why I'm exiting from this tunnel, I like to make a small side cut, which you see here. Now, this makes a funnel-like opening in the beginning so that you can insert your tube easily. So the beginning of the insertion is easy. Because it's a very tight tunnel, so it takes a little effort to thread it through it, but I think you have to be gentle and persistent, and invariably it'll go into the anterior chamber. And now you can see the tube should start appearing somewhere here. So because I made a little curved tunnel, so it should be somewhere there, the tube should come here. You can see now tube is becoming visible there, and this is about the desired length, about 2 millimeters in the anterior chamber, and that is, I think, nicely. So the tube has to be away from the cornea, and not touching the iris. But if it's closer to the iris, that is preferable, but it should not be away from the cornea. If the anterior chamber depth is not good enough, then one can go posteriorly into the sulcus for the sulcal placement of the tube as well. And in that case, you might do a little peephole iridotomy here to facilitate the insertion. And the final step, of course, is the closures. And I like to close it with the, I always put a scleral patch graft. This is a full thickness scleral patch graft, but you can use it, you can thin it out or shave it off if you're not comfortable. But the more the support there, the less likely would be the erosion of the tube in the post-operative period. And some people nowadays recommend that if you don't want to put a scleral patch graft, you could make a longer tunnel with the needle. So make it like 3 millimeters or 3.5 millimeters, then maybe you need not put this patch graft there. But I like to put it in all my cases because that gives me a extra safety. Because the most important thing is to prevent erosion of the tube in this area, because if that erodes, then your implant would fail, and there would be endophthalmitis and other things. And finally, you wrap the conjunctiva and Tenon's capsule over the implant and over the patch graft either side. So it's important to bring both the layers, the conjunctiva as well as the Tenon's capsule together, and don't leave behind the Tenon's capsule, because if you leave behind the Tenon's capsule, it's going to scar differently, and then it might extrude the implant. So once it is wrapped around, you can put sutures on the sides, and you can see this is nicely closed, and you have a tube of adequate length in the anterior chamber. And that essentially basically completes the procedure. You could do an antibiotic drop at the end of the surgery, and so I think I will skip this video. This is just to show you that the implant is possible even in situation when there's glaucoma surgery is actually glaucoma surgery other surgery is not possible, but because of paucity of the time, this was a complete video, so I'll skip it because we are already at the end of our session. And thank you very much for giving me this opportunity, BOA, Dr. Manish, Sunil. Thank you very much for this invitation, and all those who are listening patient. Thank you.
Thank you, Pando sir, for an excellent video presentation. So where to implant the wall, how to insert the tube, how to place a scleral graft, that will be definitely useful for the new beginner, sir. Thank you very much, sir. Over to you, Dr. Sunil, sir.
Yeah. Okay. Thank you all speakers, and thank you the chair. I think we've finished right in time. Thanks to Dr. Pandav for cutting his talk short. So I think we can close this session with the permission of the chair. Dr. Arup, we can close this session.
So we have 5 to 10 minutes. I think next session will start at 10:30. Can we have a discussion of 5 minutes, or we will end the session?
I think there's a question for Dr. Pandav.
Yes.
Sir, can you take this?
Yes.
Would you prefer your preferred site is only superior-temporal or at 12 o'clock? That's the question from Dr. Deepak Vaidya.
Superior-temporal. The implant, it goes in the superior-temporal between the two muscles, like superior rectus and lateral rectus muscle. But the tube could be directed a little bit more toward the 12 o'clock position. Because if you're putting a patch graft, sometimes the patch graft is visible if you put it too temporally. So you could have a little curved course for the tube, and the tube can come a little toward the 12 o'clock position. But the implant goes in the superior-temporal quadrant. That's the preferred place. But if superior-temporal quadrant is not available, then you could go to the inferior nasal or inferior-temporal. So first preference is superior-temporal, inferior nasal.
Good morning, all of you.
Good morning. Good morning, Dr. Satyan.
Good morning. Good morning.
Hey, Satyan, how are you?
All well, all safe.
Pandav, sir, any other?
Can I just check my presentation?
Satyan, 1 second.
Yes, so there's time, sir. There's time, sir, for you. There is 1 more minute time to 5-10 minutes time, sir.
No, I have a video, so that's the reason why I just wanted to check.
Yes, sir.
Thank you, Dr. Arup. Thank you, Sunil. Thank you, Manish. It was a good session. I was listening everyone. Pandav, sir. Thank you, all the faculty.
Good morning, sir.
Good morning.
Morning, sir.
Thank you very much. Thank you. Thank you. Thank you.
Thank you. Thank you.
Thank you so much, sir. Thank you.
Thank you, Dr. Sunil. Dr. Manish.
Sorry, Dr. Satyan sir, I think now the session has ended. So can Satyan sir please check his presentation? Thank you, Arup sir. Thank you, Dikshit sir. Thank you, Pandav sir. Thank you, everybody. Thank you, Manish. Manish has put together such a beautiful glaucoma program with the help of everybody. And it is the stalwarts and the delegates who make this program. Thank you, Manish. And thank you, everybody. Thank you so much. Can Dr. Satyan sir share his screen and check his presentation, please? Manish?
Hi, Manish. Good morning.
So
Manish,
please
you
go ahead, sir. Satyan sir, please go ahead and check your presentation, sir.
Can you share your screen?
Yeah.
Hi, Dr. Purvi.
Hello, hi. Hello, everybody.
Hello, hi, Preeti. Hi, Dr.
Hi.
Mandar. Hi, Dr. Vivek.
Hello, good morning.
Good morning, Dr. Chandrima. Hi, Dr.
Oh, she's
Paramita sir.
joined.
Good morning. Preeti, good morning.
Hi, Ragini. How are you? Very busy.
No,
Yes.
Manish is busy. Manish is busy today.
Hi, Ragini. You look beautiful and busy. Both.
Good morning, ma'am. Nice to see you.
Good morning.
Sai Dada, Satyan sir is having some problem with his sharing. Can somebody, Satyan sir, are you having a problem?
Yeah, I'm just trying to see. Yeah.
Can somebody help you, Sai Dada?
Are you, Dr. Satyan, are you able to open your...
Yeah.
You can share your screen. Are you able to do that?
When I'm going to the share screen, it is the share part is not accepting.
Okay, so maybe they've blocked shares.
I think you have to go to accessibility in the settings and allow Zoom to share the screen. Dr. Satyan.
Yeah.
I take this opportunity.
Hello. Dr. Venkatesh, we can, first we are sharing Dr.
No, I was just checking.
All right, checking it. All right. Okay.
It's got an issue or it's a
Yes.
general issue.
Yeah.
So you were able to hear my audio, right?
Yes, we could.
Okay, fine. It's a recorded one, so I'll just
Yeah,
play.
I know.
Once Satyan is done.
Yes. Are you there, Dr. Satya? I don't know if he's even there now.
He's there, but he's mute.
He is?
Yeah, he is there.
Yeah, I'm there, Preeti.
Okay, all right. Hi.
Just trying to.
Oh, not able to?
Because I'm using my MacBook.
Manjula Didi, anybody can help?
Yes, doctor. Can you just, Miss Manjula, can you just help Dr. Satyam?
Yes, doctor.
Yeah.
Doctor,
Yeah, tell me, please.
actually, you're going to run a video, right?
The whole slide itself is not coming. I think.
Yeah, he's not able to share his screen. That's what it is.
டாக்டர் நீங்க டெஸ்க்டாப்ல வந்து உங்களோட ஃபைல் ஓபன் பண்ணி ட்ரை பண்ணி பாத்தீங்களா?
It's in the desktop தான். Okay.
எஸ் டாக்டர். ஓபனா இருக்கா? ஃபைல் ஓபனா இருக்குங்களா?
Yeah. File is open.
ஓகே. ஜஸ்ட் ஷேர் ஸ்கிரீன் கிளிக் பண்ணா உங்களுக்கு ஓபன் ஆகுதா?
Share screen is not. It's opening, but the share screen is not allowing me to share my presentation.
Okay, one second, doctor. One second, na check panna.
Yeah.
Satyan, can you please check the chat?
Hello.
Yeah, I'll check the chat.
It's 10:26, so we'll start at 10:30. So, Dr. Satyan, is it okay if you have this little problem? Can we take Dr. Venkatesh first? Is that all right?
Please go ahead.
Yeah?
If I can log in,
We'll wait. Yeah, we'll wait for a minute.
No, don't have to wait. If it is just goes in, then it is fine.
All right.
Doctor, before that, I'm sorry to interrupt. I'm Sai here from the technical team.
Yeah.
Doctor, can you just open the video first, then go to shared screen so that the video will be available on the thumbnail from which you can select?
I'll just try. More settings.
Yeah.
Hi, why don't you go offline and help him? See the screen.
I'll do that. I'll call you, doctor.
Yes, Sai Dada, I think.
By the time
I'll do that. I'll call you.
Yes, Sai Dada, we can do that.
I'll call you personally,
Good
doctor.
morning, Venkatesh sir. Good morning, Lingam ma'am. Good morning.
Oh.
Yeah, good
Hello,
morning.
madam. Hello, madam. Good morning.
Namaste.
So, welcome to all the speakers, and we'll start at 10:30. And in the interest of a smooth functioning, let us all restrict ourselves to the time allotted. And the proceedings, Dr. Dhamankar, has she joined? Rita, have you joined? I can't see her. All right.
Madam, I'll give a call. Dr. Rita has not joined, Preeti.
She has not joined. I will phone her, sir.
Call her.
Yes, sir.
Why she has not joined?
Dr. Chandrima madam is the co-chairman. She can.
Yeah.
Chandrima madam is there, na? Chandribai has joined. She can be. She can share if Preeta is not joining. Chandrima ma'am, you can.
Why
Yes.
are you not able to join?
You can continue.
I'll
You got 2 minutes. There is no problem. And welcome Vijaya ma'am. Vijaya ma'am has also joined. All the speakers.
Good morning, sir. Good morning.
Yeah, I tried, doctor. She is not able to join, Rita. So she said start, and we will start at 10:30. So, madam, Chandrima madam, can you just start the proceedings then at 10:30, please?
Sure. Yeah. So it's 10:29 by my
Yes.
watch.
Yes. So about a minute and we'll start.
Okay, and we start with Dr. Venkatesh, right?
Yes, we'll start with Dr. Venkatesh, yes. I'll keep the time at 7 minutes. I'll give a reminder, and at 8 minutes then please, so you have 1 minute to sum up the presentation.
Rita has joined.
Oh, great.
That's right.
Is it 10 minutes for the second talk? I'm just
Yes, second talk is 10 minutes, yes. There are 2 talks which are 10 minutes and the rest are 8 minutes.
Good morning, Rita ma'am.
Oh, she's joined. Nice.
Yeah, I've just been able to
Okay,
join.
hi Rita.
I'm actually away from town, so little problem. Sorry. Yeah, go ahead, Preeti.
Yeah. So, Chandrima madam, please start. It's 10:30.
Yeah. So good morning, everybody, and a very warm welcome to the Glaucoma 2 session of the BOA and the Maharashtra Ophthalmic Society conference. We start right away without wasting any time. The first speaker is a keynote address by Dr. R. Venkatesh, and he's going to speak to us on my experience with MIGS. Dr. Venkatesh, all yours.
I take this opportunity to thank my good friend Dr. Manisha and BOA for giving me this opportunity to share our experience in doing MIGS. So minimally invasive glaucoma surgery. It's getting popular because glaucoma surgery in the form of trabeculectomy and tube shunt surgeries are not very rewarding to general ophthalmologists because it takes longer than cataract, a lot of post-operative care, and unexpected outcomes like this, which are mostly bleb-related complications, blebitis, endophthalmitis, big cyst over the tubes, and complications related to low intraocular pressure in the form of hypotony and choroidal detachment. So we are always looking at something which is highly safe, which is less invasive, and also recovers very quickly. So MIGS is popular because they spare the conjunctiva. You have an ab interno approach in most of these procedures. Is safer and less invasive to control the intraocular pressure. It reduces the dependency on topical medication. So people with ocular surface disorders definitely benefit. And when you do cataract surgery, there is an early glaucoma, you can combine some of the MIGS. So the most important point to keep in mind, it's a surgery for open angle glaucoma, mainly mild to moderate stage, patients who are ocular hypertensive, who want to get rid of their glaucoma medications, and patients who need a glaucoma, a cataract surgery and have mild glaucoma, and of course, ocular surface disorders. At this point of time, these are some of the classification for MIGS. You have subconjunctival drainage in the form of Zen implant, which is yet to be available. The most important part is enhancing the Schlemm's canal outcome. So you have trabeculectomy in that, which is available in India. iStent is coming soon. And then you have Hydrus, and very importantly, gonio-assisted transluminal trabeculectomy. I'll share my experience with that. And of course, Kahook dual blade. If you take suprachoroidal outflow, you have iStent Supra now. CyPass, which was there, is not available because of a safety profile. Finally, you can also distract the ciliary body in the form of endoscopic photocoagulation. So when you talk about developing world context, most of these devices are yet to be available in the country. Now, even this pandemic is delaying a lot of this MIGS getting into India. Definitely, there is a cost factor. Is it going to be cost effective on the long run? We need proof in developing world. And we all understand from previous evidence and publications that it's got a modest control of intraocular pressure. So at this point of time, for mild to moderate primary open angle glaucoma, these are the options which we can definitely consider in India. One is gonioscopy assisted transluminal trabeculectomy. So what is this? Basically, it's performed with an eye track microcatheter, and also you can do a less expensive way using phyoprolin suture. And we have found that the phyoprolin suture works equally good like a catheter, if you do it in the right way. I'll quickly share the surgical video of gonioscopy assisted transluminal trabeculectomy using an eye track catheter. So the main incision and side port is very important. through the side port, you keep the catheter inside. You can see the blinking light source. And this is very important step, doing an intraoperative gonioscopy and using an MVR blade. A small opening is made in the trabecular meshwork into the Schlemm's canal. And then the catheter is inserted into the Schlemm's canal. And gently, clock hour by clock hour, we need to get this into the canal to the other side. Once you are 270 to 320 degrees, you can do a trabeculectomy like this. You remove the catheter through the side port, and finally you remove the viscoelastics and you reform the anterior chamber. You can do it separately, or you can do it with combining with cataract surgery. So for suture guard, these are important things. You need a low temperature cartridge, you need a Swan-Jacob gonioprism to do gonioscopy. Phyoprolin is very important, MVR blade, and of course good viscoelastic like Kelon GV. MST forceps is the one which helps you to insert the proline suture into the Schlemm's canal, and of course finally McPherson's forceps to remove it. So this is the first step. You can see a low temperature cartridge is brought very close to the suture, phyoprolin suture, to make a small snub here, so that it is the sharp end doesn't damage the angle. So it should not touch actually. Even at a distance, you can the heat will make a small snub. And then the steps are very similar. Now you make 2 incisions. If you're going to do a phaco, you can do a regular corneal incision and a side port incision here. Through the side port incision, place the suture inside, like how you would place the catheter before, and then do the positioning of the patient. Put the gonioprism using an MVR blade. A small nick is made, and the trabecular meshwork, and then you can see here there's a nice bleeding because there's blood in the Schlemm's canal. But if there's no bleeding, it's always good because you can see better. And then you insert the phyoprolin suture using your nice forceps. Gently, this has to go 1 clock hour by 1 clock hour. When you come 180 degree here on this side, you'll have a lot of resistance. You'll have to go beyond that resistance. Once you are beyond that resistance, again, it may run smoothly. And once you are roughly 270 or even 300 degrees, it's more than enough. You can do intraoperatively, you can put a gonio lens to again see where exactly it is. So now you can see the suture is coming on the other side. And once it's on the other side, you can you can now stop the catheterization. You can fold from the other side. And then using a McPherson's forceps through the side port, you pull the suture, and this does the trabeculectomy. So what we found that guard definitely preserves your conjunctiva and sclera for future surgery. It's a less expensive option with phyoprolin suture. In our experience, at least now we have done more than 50 patients. There are very minimal complications. There is some hyphema there which resolves, and there's minimal risk for infection because there is no bleb here. Definitely a follow-up is less. There is a lot of work done by one of our mentors, Dr. Davinder Grover, on this technique of guard. And he has published his 1 year, 3 year, and 5 year results. Seems to be very promising. And now we are working to see this whether it is has the similar effects like the eye tract catheter. The other option which we can explore at this point of time is Kahuk dual blade. So basically, it removes the trabecular meshwork, and if you take trabectome, it damages the surrounding tissue, whereas KDB completely removes the trabecular meshwork, so there is less fibrosis and looks to have better outcome. So this dual blade is designed to do the job of peeling the trabecular meshwork so that your Schlemm's canal is open to anterior chamber. So it easily penetrates the meshwork. The ramp lifts and stretches the meshwork, and then the blade does the job. The dual blade that excises the strip of meshwork. So it can very elegantly remove the meshwork, and the foot plate is on the wall of the canal. So the foot plate is smooth. It doesn't damage the wall of the canal. So the chance for fibrosis is much less. And that's how the Kahuk dual blade works. So everything, I think the intraoperative gonioscopy is very important, visualizing the angle, making sure it's open angles, and then peeling the trabecular meshwork like that. And many of the times when you have blood, you may have difficulty in seeing, but if you don't have blood in the Schlemm's canal, you can nicely visualize and do a good job. So this again you can do for 3 to 4 clock hours in both the directions till you peel off the trabecular meshwork. And the same can be done using a needle, which is called bent ab internal needle goniectomy. So this was a technique popularized by Arsham Shebani. So it's a very cost-effective way of doing. So you have to use a 26 gauge needle. You bend the tip of the needle like this, like your trabectome, without damaging the sharp end. And then you enter into the Schlemm's canal, again peeling the trabecular meshwork. Same ramp effect you can see, but it's not as good as a Kahug dual blade. We have tried this, it works. And you can see the trabecular meshwork getting peeled off. So you can do on both the directions till you achieve a good peeling. So this is another simple way of doing, and the Kahug dual blade also offers very good results. We need to see how the low cost option also works on a long term. And at this point of time, our team is also working on that. So the most important part before I finish is importance of intraoperative gonioscopy. Positioning the patient. You have to turn the patient's head away from you and tilt the microscope towards you. You should have a 45-degree tilt, and make sure you have heel-on GV with you, which is very important. And try to make your patient's head above the heart level, so that you won't have the reflex from the reflex blood in the Schlemm's canal. This really helps you. So these are some of the very important tips to keep in mind. But gonioscopy is very important. So you have to practice gonioscopy when you're doing your cataract surgery, or after removal of the cataract. You can practice doing intraoperative gonioscopy. So put viscoelastic, use the Swan-Jacob lens to visualize the angle. Practice this, and then if you have practiced, I'm sure you can do some of these techniques like that and comfortably. So MIGS at this point of time, I think you can tailor some of our.
Dr. Venkatesh, that was a lovely talk. If Dr. Satyan is ready, we can take his talk then. Dr. Satyan? No, I don't think he has joined still. I don't see him, so I think I'll take mine is the third talk, so I will take that talk. I'll start my screen sharing.
Yes, Preeti doesn't need any introduction, so yeah, Preeti, please go on.
Yes, and Rita, please keep the time for 8 minutes, yeah, and tell me. All right, so I will start my presentation now. Yeah. So I thank BOA, Dr. Lane, Dr. Ragini, and Dr. Manish for this opportunity. Investigating a scenario of progression despite well-controlled IOP requires effort from both the patient and the physician. It also creates a panic in the mind of the patient, and hence it's imperative to be very sure that there is actual progression. This was a gentleman, 67-year-old, and he showed progression between 2004 to 2010 with pressures between 13 and 18. Intervention should have been done much earlier, but what do we do now? We need to play detective and ascertain certain facts. Is the patient telling us the truth about using his medications? Is the IOP truly under control? Are there other factors at play? There are enough studies proving poor compliance to treatment in patients with glaucoma. Side effects, cost, busy schedule, and not taking the disease seriously are few of the reasons for non-compliance. But regardless of the motivation, the bigger problem is the patients do not voluntarily admit to non-compliance, even on direct questioning. It is difficult to prove and harder to remedy. In my experience, most of the times, a non-compliant patient remains non-compliant. Since treatment revolves around intraocular pressure, we need to ascertain that intraocular pressure is truly under control. Importance of a good gonioscopy is repeated ad nauseum, but it's essential because intermittent angle closure can cause undetected IOP spikes and progression. The pachymetry reading may be forgotten over a period of time, so go back to the patient's records. Make sure you are not dealing with a thin cornea and underestimating intraocular pressure. Progression is usually slow. There will be a large number of IOP readings. Check them from the beginning. Note the percentage drop in intraocular pressure. Make a note of the range. All the readings may be low, but the range of fluctuation may be higher. Sometimes patients, they fall into the habit of coming for an IOP check at the same time. His IOP may be on target at every single point, but the range may be higher, the fluctuation may be higher, and you will never discover a intraocular pressure spike which occurs at other point of the day. Checking diurnal variation can explain progression in some patients and can be done by measuring the IOP every 3 hours from morning till night, or calling the patient at different times of the day on different days. Triggerfish is a contact lens designed to detect intraocular pressure but has not become popular because it does not give measurement in millimeters and of course the cost. A positive diurnal variation has value, but a negative one does not eliminate IOP spikes. Water drinking, Shirsasan, breath holding can also cause IOP spikes and should be looked into. Investigating for non-IOP factors requires time, money and talking to other specialties. We look for oxygen and vascular deprivation. Fall in the blood pressure, particularly nocturnal dip in blood pressure, can be detected by a 24-hour ambulatory blood pressure monitoring. Talking to the physician helps because they are always worried about elevated BP and they ignore low BP, which is what we are looking for. If there is history of snoring, nocturnal apnea should be looked into. If the progression is very fast, an MRI should be done. The principle behind management of such a scenario is blame the IOP and lower it. And what do we actually do? That depends upon the intraocular pressure range, extent of glaucomator's damage, rate of progression, age of the patient. Basically, what we are trying to ascertain is, will the vision outlive the patient? If the intraocular pressure is in a higher range, you can add medications and decrease the pressure further only with medications. Higher glaucomator's damage, faster rate of progression and a younger patient are motivations for surgical management. The most effective way of slowing progression is to lower the intraocular pressure further, sometimes to single digit levels, and the most effective way of doing it is by doing a trabeculectomy. This is a lady with an intraocular pressure between 12 and 15. And if you see, this is 2008 and this is 2018. There is definite progression on maximum medical therapy, but it is very slow. The defect,
1 minute.
okay.
Last minute.
All right. The defect is also not very deep. In all probability, her vision is going to outlive her, and therefore, whether you want to operate or you want to observe is something which you can do, but observe her closely. This is a gentleman in which you are very sure that his vision is not going to outlive his life. I operated him for trabeculectomy and his vision did stabilize. His field stopped progressing. This is one gentleman, 2009, 2001, sorry. Then 2000, he has been following up for about 20 years, 2004, and he has gradually progressed despite normal IOPs. I did a trabeculectomy for him, and with the trabeculectomy, it continued progressing, but the rate of progress decreased. If you see, this is 2017, this is the time when the trab failed, and this is 2020 where the progression is very fast. So this is over a period of 20 years, He's now 90 and is not willing. I would want to do a trab, but he's not willing for any other intervention. So the take home is all these. Trabeculectomy is the most effective surgery to achieve a low IOP, but sometimes progression continues despite a low IOP. And thank you all for a very patient listening. I'll stop my screen sharing. If Dr. Satyan has joined. Dr. Satyan, can you start sharing your screen, please? Yeah, Dr. Satyan, can you share your screen?
Yeah, I'm sharing.
All right, thanks.
Oh, wow, great. Thank you. Sorry
Yes,
for the
thank
trouble,
you.
Dr. Satyan.
Yeah. I'm so sorry. A very good morning to all of you. And also, I would like to thank BOA and the team BOA. Thank you, Manish and Dr. Preeti. The topic is on the cataract surgery in glaucoma. There are two different scenarios we will be coming across. One is before doing the trabeculectomy, when the patient has a cataract in association with glaucoma, how do we really deal with? And post trabeculectomy, how do you really deal with these patients who has cataract? So the problems of cataract in glaucoma is many times the patient will have functional and visual disability. Our problem many times is that we will not be able to assess the glaucoma progression properly because of the hazy media. And also we might be missing a lot of posterior segment diseases. Not only that, we may be coming across with the trabeculectomy failures post-cataract surgery. So looking at the first scenario, that is where you have cataract, there is no trabeculectomy and glaucoma is there. So when do we really just do a cataract is there is a visually and functionally significant cataract and the patient is on a single safe medication where he has achieved the target pressure with a good compliance and the stage of the disease has to be early to moderate. So what are the challenges that we will be coming across in these patients is the poor corneal endothelial cells, shallow anterior chambers because of the angle closure disease, or there may be a larger lens. Small pupil situations are very common to be seen, and those with the subluxation of the lens in pseudoexfoliation glaucomas. The second scenario is the post-trabeculectomy, where the patient has cataract in association with the glaucoma. So this you might be coming across when you are doing your surgery like trabeculectomy. You would have just injured the lens when you are inserting your side port or main entry, or when you are doing the iridotomy, you would have just touched the lens. Or when you are trying to do some anterior chamber manipulations, you would have just touched the lens, wherein the cataract progresses much faster. Also in post-operative period, especially the younger patients, or even otherwise also, there's a shallow chambers when you have hypertony, inflammation, and also there is some kind of a natural progression also. When you do the cataract surgery, it is important for us to understand what can possibly happen for the trabeculectomy. There's always a high chance for the failure. This is the one of the study which shows that if you do the trabeculectomy within the first 6 months, then the possibility of having a trabeculectomy failure is much, much higher than when you do it at the end of 2 years or later. So this is the amount of cataract progression which can happen within the first year of trabeculectomy. About 6% of patients can have, at the end of 4 to 5 years, about 15% of the patients can have the cataract. So there are many challenges in the cataract surgery when you are doing in a post-trabeculectomy patients. So it is better we explain the patients properly, intra and post-operative complications and its related management. So where all you will have problem, one is the bleb related complications. The bleb, especially the mitomycin blebs, will be little thin, and also it's very easy to rupture when you are doing the surgery. Or the patient can go for a scar formation and a failure of the trabeculectomy. And when you are doing your manual small incision cataract surgery on the temporal side, then you may be just destroying the whole area where you will not be able to do the future trabeculectomies. And these patients always, they'll have a compromised endothelial cells. Also, you'll have the shallow chambers, as I mentioned earlier. Small people also I mentioned. There may be because of the rigid people or due to the synechiae, you will have difficulty in the rhexis and other associated lens-related associations. Also, these patients will definitely have more post-operative inflammation. So additional medications like steroids may be required, but this can cause again increase in the intraocular pressure levels. So what are the surgical tips? One, you have to be mentally prepared to think about all the possible complications and prepare all your instruments, and including the IOLs or CTRs, whatever you have. Everything needs to be prepared, well prepared prior to the surgery. If you are comfortable in doing the intracameral or topical anesthesia, that is the best of the choices. It is always advisable not to go for a massage, especially when the bleb is thinner. You might be just rupturing the bleb, so better not to go for the massage, or even the peribulbar anesthesia is not very safe. Try to avoid the manual small incision cataract surgeries to keep that space for future trabeculectomy in the temple side. And if your endothelial cells are quite poor, then it is always think about using the Helan or a viscot so that the corneal endothelium is protected. But many of the surgeons, they do use a normal saline, but in those situations, at least I would advise you to go for a BSS, or even BSS plus will be a better choice. So there is less post-operative inflammation and the cornea can be protected much better. When you may have the small people and its challenges. Small people may be of two types. One is the rigid small people, and the other one is the cynical small people. When you have the rigid small people, then you can use the hooks or whatever the available things you have, you can use it. I don't want to name a few individuals' names are also there. So you can use any of that. But when you have a cynical miosis, you can just use do a stretch pupilloplasty. I think that's more than enough for you to have the decent pupillary size. And the video, you can see that if you are able to see, this is a subluxated lens in a pseudo exfoliation where you may have to go for a CTR, and even possibly you have to think about using different lenses. You might be taking out the whole lens outside also. Sometimes the whole bag will come out. So in these cases, you will have to have either iris claw lens or a scleral fixator lens. Vitrectomy, everything has to be thought of when prior to the surgery itself, and keep it ready.
Sir, 1 more minute, please.
Yeah, sure. So if you have hydration of the wound is important, but don't try to excessively hydrate the wound, especially when you have a thin blebs. It might rupture. The wound is weak, then you have to go for a one interrupted nylon suture or a vehicle suture you can apply, and the intracameral antibiotic of your choice would be an advisable thing to avoid any post-operative infections. Thank you so much. Yeah,
Thank you, Dr. Satyan. That was a very nice presentation, very informative. And I believe you have to leave, isn't it, for another meeting?
The meeting is already started on the other side. I'm sorry.
Oh, okay.
If you have any questions, I'll be more than happy to take it up.
Right now, there are no questions, but we'll take it up at the end. But you won't be around. Okay. You're leaving just now. Will you be able to join for 5 minutes?
Yeah, sure.
All right, then we'll do that. Okay.
Sure.
So the next topic is by Dr. Rita Dhamankar, again a very prominent glaucoma specialist from Mumbai, and her talk is on role of YAG-PI in angle closure disease. Rita, if you can share your screen, please. And unmute yourself.
Good morning, everybody. And thank you, BOA, Ragini, Ganesar, and Manish for having this virtual conference on. I'm going to talk today on laser iridotomy and angle closure.
Thank you for being my teacher.
Oh, God. So when will you want to do a laser and angle closure? And what are the other various laser procedures that you can do in angle closure? You can do a laser iridotomy and iridoplasty, cyclodestructive procedures, and gonioscopy. So the aim of the treatment is to open the angle, deepen the chamber, equalize the pressures in the posterior and the anterior chamber. This is achieved depending on the cause. In case of a pupillary block, a laser iridotomy is done. A laser iridoplasty is done to flatten the anterior chamber and does open the angle. And in advanced stages, you can think of cyclodestructive procedures. Sometimes in case of a pupillary block in secondary angle closure, also you might have to do a laser iridotomy. So the first laser iridotomy was done by Mayer Schwickrecht. That was done using the incoherent light source or the xenon arc lamp. Frequent corneal lens opacities led to its rejection. The present Nd:YAG laser was first used in 1973 by Beckham and Sugar. And the reason to do the iridotomy is that it relieves a pupillary block. It is relatively safe and quick, and it acts on the primary pathology and helps treat the cause. So the lasers that are used are Nd:YAG laser, which is a photodisruptive, Q-switched or a mode-locked method, or you can use an argon laser, which acts by a photothermal effect. And how large should an iridotomy be? An iridotomy should be at least 150 to 200 microns in diameter if the acute angle closure glaucoma can be relatively prevented. Now, how is a laser iridotomy done? First and foremost, you can either do a one-sitting YAG or an argon laser iridotomy, or you can do a sequential laser argon followed by a YAG laser. So these are the way, or you can, these are the two ways in which you can actually do the YAG laser. So what are the indications for a YAG laser iridotomy? In all acute angle closures where the intraocular pressure has been reduced partly and the cornea is clear. In all the fellow eyes of patients with an acute angle closure. In primary angle closure, wherever there is a significant pupillary block. Of course, in primary angle closure glaucoma to relieve the pupillary block. And in primary angle closure suspects in special cases like patients who need a repeated pupillary dilatation, maybe because they have a posterior segment pathology, patients who have a very strong family history of angle closure glaucoma, patients who have very poor access to emergency medical care, and type A personalities who would rather have the iridotomy done with an informed consent. And all secondary angle closures where pupillary block is the significant component. You do the one headache, you notice that yes, there is a very shallow anterior chamber. Go ahead and put in your gonio lens. Now this is where you can see that this is an occludable angle. It's not open, it's not a symmetrical closure, it's an occludable angle. The angle does open out. You can have an angle closure, or you can have this plateau iris configuration, all of which will need a primary angle iridotomy. Now, this could be a secondary angle closure where you can see that there are a lot of posterior signs here, but you can definitely see an iris chamber and the laser iridotomy is definitely going to help most in these cases. What are the contraindications? That the patient is unable to sit steadily on a slit lamp, very uncooperative patient. If the angle closure is not superior, how do you go about this?
We are not able to. Yeah, there is a disturbance in the voice, Rita. We are not able to hear sometimes. No, we are not able to hear you, Rita. तने समझाए we are not able to hear you, Rita. Rita,
I can't make out what is wrong.
all right. Now we could hear you. Can you just continue? Yeah.
Okay.
Again.
Sai Dada, can you figure
I
out
think
what is going on, Sai Dada?
you want me to.
Doctor, that's a network issue on Dr. Rita's side.
Okay. Okay.
Right. So if she switches off her photo, then, normally we say that, then the presentation is more visible. You think?
Yes. Yeah, we can try that. We can
out?
try that. We can try that.
Ma'am.
Rita, just switch off your video. Don't share your video.
Then probably the voice is heard better.
Stop your video. Yeah.
Now can you hear me?
Yes.
Yes, ma'am.
Yes. Yes.
So the lenses that are used for an LPI are the Abraham lens, which is preferred as the energy delivered to the cornea and the retina is 4 times lesser than the Wise lens. Or you can use a Wise lens, which is 103 diopters. It minimizes the spot size and magnifies the size, but it is a little difficult to focus. You can also use a central part of the Goldman lens, which will help view and deliver energy in a better mode. So when you have using a lens, then the energy is concentrated and hence you have lesser damage to the rest of the tissues, like you'll have lesser corneal burns and collateral tissue damage. How is iridotomy performed? You seat the patient comfortably on the laser, look at the iris for crifts, that is a thin patch of iris where penetration will be easy. Preferably search for an area in the superior quadrant where the upper lid will cover the iridotomy. The iridotomy should be as peripheral as possible, so you'll have less dysphotopsias later. Fill the lens with a coupling fluid and place it in the eye gently, and now focus on the area to be lasered. Make sure you laser it. Your laser is set at the posterior focus, and once you are focused on the iris stroma, decide the laser power and shoot. Once you have penetrated the iris, you will see a gush of aqueous coming out. If you have hit a vessel, gently apply pressure at this site till the bleeding stops. Make sure you have a full penetration. If you have an incomplete penetration, repeat the laser, ensuring that you're aiming at the correct site. You may have to wait for the area to clear out to get a clearer view after your first shot. So the energy that you use with the YAG is 2 to 8 millijoules. The spot size is fixed for every machine. You may use a pulse per strike, which could be 1 to 3 pulses. And the shots required could not be more than 4 shots till you get an adequate penetration. In case the iris is very thick and pigmented, then you will have to use a sequential laser. You can also do a direct laser using an argon laser, which is very useful if the patient is on an anticoagulant. Here, a single area is treated with superimposed applications till a perforation is obtained and a pigment flume is found to move forward.
1 minute more.
Yeah, okay. So the difference between an ND YAG and an argon laser is that if you have a dark colored pupil, then you can use an argon laser much more than a YAG laser. And if you're on an anticoagulant, you better use an argon laser. Sequential laser is you do the argon laser first, prepare the iris, and then go on and hit with a YAG laser. Now, the complications could be bleeding, corneal burns, or temporary blurring of vision, which is very early or when you're doing the procedure. And later on, you could have an IOP spike, blurring, linear dysphotopsia, uveitis, corneal edema, localized lens opacities, retinal damage, CME, malignant glaucoma, and closure of the iridotomy. So, intra-op, you have to focus on the iris stroma so you can avoid the iris burns. If there's a bleeding, I said you can apply pressure, and everything else will go off if you treat it correctly. So post laser, please check the IOP 1 hour post laser. If the IOP is very high, give Diamox or Mannitol. Otherwise, start an anti-glaucoma medication for a week, but don't use pilocarpine at this stage. Also, please start an anti-inflammatory drug, preferably a steroid, for a week. And
Rita,
then,
can you summarize?
Yeah, I will. The only thing that you need to do is please, after a week, look at the angle, repeat gonioscopy, look at the status of the iridotomy, make sure that this pressure is under control. If it is not, this is heading towards a chronic angle closure. So henceforth, you will start treating this patient as an angle closure glaucoma, a chronic angle closure, and treat him like any other glaucoma. Thank you.
Yeah. Thank you, Rita, for a lovely talk. And the next talk is by Dr. Sunil Jain, and he'll be talking to us on management of malignant glaucoma. Can you stop sharing your screen?
Yeah, I will.
Yeah.
Good morning and thank you, BOA, Lahane sir, Ragini madam, Manish and Preeti for having me here. And
yeah.
okay, so coming to malignant glaucoma. So the definition, it's a secondary angle closure glaucoma, which is characterized by a shallow or a flat anterior chamber, elevated intraocular pressure, but it has to be in presence of a patent iridectomy and a normal posterior segment. So the classical form usually occurs post-operatively, either while performing a surgical iridectomy or following a trabeculectomy, or if you're doing a combined surgery. And in the classical form, it's usually seen in patients with chronic angle closure with extensive peripheral anterior synechiae. It may occur during surgery. It may occur immediately after surgery. It may occur in the late post-operative period when the cyclodialysis agents are discontinued. And if the pressure starts rising, and if by mistake you tend to add a miotic agent to control the pressure, it might aggravate an malignant glaucoma. There are other clinical forms. It can occur as a spontaneous form. It can occur post-CRVO. It can occur with use of miotics in eyes with no previous surgery. It can occur even after a laser iridotomy, capsulotomy, or following a CPC also. The pathophysiology is there is an abnormal vitreous and ciliary relationship, where there's misdirection of aqueous into the vitreous. There's impermeability and thickening of the anterior hyaloid. So what exactly happens? So as soon as you do a sclerotomy and a surgical iridectomy in the trabeculectomy, the anterior chamber, there's a sudden shallowing of the anterior chamber. This results in the anterior rotation of these ciliary processes. The aqueous gets misdirected posteriorly. It causes hydration of the vitreous, which pushes the entire lens diaphragm anteriorly and causes shallowing of the anterior chamber, and ultimately results in an IOP rise. So how do a patient present to you? So this is a typical case where preoperatively this patient presented to us with for a second opinion, and patient was on a medical treatment. Her visual acuity was 6/9 with a +3 diopter sphere. So she was a hyperopic patient to start off with. Pressures were uncontrolled with a 360-degree cynical angle closure. We diagnosed her to have chronic angle closure. Because our YAG iridotomy was not performed, we performed a YAG iridotomy. The pressures, however, persisted to remain high, and hence we had to perform a trabeculectomy. On post-operative day 1, the pressures continued to remain high. The slit lamp showed the bleb to be very low and diffuse because the aqueous was not egressing into the anterior chamber and into the bleb. The AC was very shallow uniformly in the center and in the periphery. The iridectomy was patent. And this is a picture. As you can see, the entire lens iris diaphragm is quite anteriorly positioned. This is the previous iridotomy, which is patent, and the present surgical iridectomy also, which is patent. If you see the bleb, it's quite low and kind of non-filtering. And when you look at the anterior chamber, this axial shallowing of the anterior chamber, you can see the glaucoma flecken, which indicates past history of angle closure attacks. So how do you know that whether it's a flat AC, what is the differential diagnosis in a flat AC? So you could have basically flat AC with low intraocular pressure, that is in presence of choroidal detachment and wound leak, but we won't be discussing that. The differential diagnosis of a flat AC with a high intraocular pressure is malignant glaucoma, a pupillary block glaucoma, or a suprachoroidal hemorrhage. So we'll discuss that. So a pupillary block glaucoma can occur post-trabeculectomy if you have not cut the peripheral iridectomy completely and the posterior pigment epithelium remains intact. Like in this patient who had aphakic glaucoma and there was vitreous in the anterior chamber with posterior synechiae, the iridectomy was not performed, and this resulted in a shallow chamber and a iris bombay. So all required was an iridotomy, which opened the overcame the pupillary block, and we could relieve the patient. Coming to the second DD is the suprachoroidal hemorrhage, usually seen in patients which are aphakic, post-trauma, vitrectomized eyes, and large pathological eyes with myopia, where the patient presents to you with a sudden severe pain post-operatively with a sudden loss of vision, usually occurs in first 4 to 5 days. When you do the B scan, you need to do a B scan because Indirect will not show any glow. And on the B scan, you'll see these kissing choroidals with a dense suprachoroidal hemorrhage out here. So once you have ruled out an imperforate iridectomy to rule out pupillary block, you have done the indirect ophthalmoscopy to rule out suprachoroidal hemorrhage. But if not confirmed, you do a B scan and rule out a suprachoroidal hemorrhage or an effusion. And if required, you will do a UBM. UBM picture of a malignant glaucoma will be this, where the ciliary processes are anteriorly rotated. The entire chamber is almost shallow to flat uniformly. So how do you manage this patient? Immediately, the medical line of treatment would be a combination of atropine with phenylephrine, because this relaxes the ciliary body and tightens the zonules, which pushes the entire lens iris diaphragm posteriorly and also stabilize the blood aqueous barrier. In addition, you will have to use aqueous suppression to reduce the aqueous production. You'll use hyperosmotics to shrink the vitreous so that the lens iris diaphragm moves backwards, and also corticosteroids to suppress the inflammation. And this is what we did in that patient. And as you can see, on post-op day 1, the chamber was shallow and gradually started deepening, and the patient, the malignant glaucoma resolved. And even the bleb started forming because the aqueous, which was posteriorly directed, started coming anteriorly and started forming the bleb. Well, in some patients, this may not help, and you might have to go to the next level of management. So if a patient is aphakic or pseudophakic, you can do a transpupillary YAG, capsulotomy, and a hylidotomy. And if the patient is phakic, through the iridotomy, you can do a hylidotomy or even shrinkage of the ciliary processes, which usually is difficult because the view is not too good in these patients. So most probably you might land up with a surgical option. In the surgical option, you will have to do a pars plana vitrectomy. The anterior hyaloid will have to be cleaned up, and the AC reformation will have to be done. That usually improves the situation, clinical situations. So how do you know whether which patients are basically prone to it? You should always do a preoperative evaluation. The predisposing factors should be identified. All myotics, that the pilocarpines, to be stopped prior to your doing a trabeculectomy. A laser PI should always be done in an angle closure. The IOP should be as controlled as possible. And prior to your trabeculectomy on the day of surgery, please administer IV mannitol. These are the risk factors you look at in the preoperative phase, where the patient very hyperopic, non-ophthalmic eye, very shallow anterior chambers, and even malignant glaucoma in the fellow eye is a predisposing factor. Intraoperatively, certain things which you can do is minimize the extent and duration of the intraoperative AC shelling by taking pre-placed sutures, using viscoelastic to deepen anterior chamber. Whenever you form the anterior chamber, do not be aggressive in pushing the BSS too fast, because it tends to go into posterior segment.
So 1 minute, 1 more minute to go.
Thank you. Relatively tight flap closure to prevent an overfiltration, because that will cause shallowing of the anterior chamber and aggravation of the malignant glaucoma. An adequate PI, a full thickness PI, and immediately start instilling cycloplegic drops on table once you have sutured the scleral flap. Post-operatively, continue monitoring these patients very closely. Avoid a laser suturelysis or a releasable suture release in the immediate post-operative period. And if you have a doubt, start carbonic anhydrase inhibitors immediately. Continue with the steroids and continue with your cycloplegic mydriatic combinations. The most important take-home message is that in such patients, most of the times the patients are on chronic atropine therapy. And also the important thing is the fellow eye also might follow the similar course of action, and hence you have to keep a watch on them. Thank you.
Thank you, Dr. Sunil Jain, for an informative talk. Our next speaker is Dr. Purvi Bhagat. She is a well-known glaucoma specialist from Ahmedabad. She is going to talk on gonioscopy versus anterior segment OCT.
Thank you so much, everybody, and especially at the leaders at the helm of BO and MOS, and Dr. Manish Bhai and Dr. Preeti. So, as just mentioned, I'll be talking on gonioscopy vis-a-vis anterior segment OCT. We all know that it is actually very, very important to diagnose glaucoma and to diagnose it correctly. But it is equally important to diagnose it early on so that we can prepare prevent all those complications and the visual handicap that is associated with glaucoma. The diagnosis is, yes, it's necessary, but it's equally difficult. We have so many parameters to monitor. We have to take the intraocular pressure against the instrument which you are going to use. We are not very certain about that. We have to see the disc. We have to monitor the fields. We do the repeated imaging techniques. And as if all this dilemma was not enough, just to see the angles, we have different instruments and equipments. We have the gonio lenses, we have the anterior segment OCT, we have the UBM, and so many newer image techniques coming up in the market. So the confusion, in fact, is endless. Talking of gonioscopy, charts of people with glaucoma were studied in a large LA practice, and it was shown that gonioscopy was documented only 50% of the time, which suggests that about half of the time, in fact, it wasn't done, unfortunately. So why people are not preferring gonioscopy or hesitating to do this technique regularly? It does require a lot of skill and experience. You need to do hundreds of normal gonioscopies to actually start finding out the abnormalities. It is a subjective investigation. It is affected by the type of lens you use and the technique that you use. It is uncomfortable not only for the patient, but for the ophthalmologist who is doing the gonioscopy as well. Because we all know after doing hundreds of gonioscopy at the end, all of us have suffered from trapezitis. It is time consuming to some extent. It cannot be done by a technician. It has to be done by the glaucoma specialist or by the ophthalmologist. And being a contact procedure, it is not advisable for mass screenings. Now, coming to its interpretation, because it is subjective, there is significant amount of inter and intra-observer variability, which is more with narrow angle glaucomas. There is inability to accurately document or compare the structures before and after treatment because it's a subjective test. Today is the era of documentation and photography, but with the gonioscopy, sometimes photographic documentation may be difficult. It is subject to different classifications, and there are indentation and light artifacts involved. And therefore came the era of digital world and technology, and the anterior segment OCT came into picture. So what are the advantages of anterior segment OCT? It provides true cross sections of the angle structures. It's an objective investigation, therefore has great reproducibility. It provides quantitative measurements of all the parameters which we want to study in the angle. Because it's a non-contact procedure, it is convenient for the patient as well as for the observer. It provides great measurement precision, and because it is digital and technology based, it provides the option of storage and data transfer. Anterior segment OCT, it allows for rapid image acquisition because it's a non-contact procedure. It eliminates all those indentation artifacts, and it has an inbuilt automated analysis software, which allows rapid measurements of all the parameters. Anterior segment OCT itself has seen significant advances. The spectral domain OCT, it provides greater resolution, both axial and transfer. A further step ahead in this direction is the swept source OCT, which provides a three-dimensional 360-degree photographic-like view, which is constructed from individual images. It provides reproducible measurement in different quadrants. So it is very useful for risk assessment of angle closure and for evaluating longitudinal changes and pre-post treatment changes. It allows for good inter and intra-observer agreement of the parameters of the angle. And because it's actually a 3D photographic image, it is very useful for patient education. There are lots of cases we see in the OPD which come with these types of corneas, corneal edema, either because of other reasons or because of increased intraocular pressure. So this is a condition where gonioscopy would not be possible. It would not reveal any findings. And these are the cases where we would rather resort to anterior segment imaging to see what is behind that cloudy cornea. Again, we have done a PI where we are very happy with its patency, a good retro illumination. We can see the lens capsule from behind. But still, subjectively, if you do the gonioscopy, you are not very sure of what is the angle status. So again, this is a condition where you would like to do an anterior segment OCT to actually see the status of the angles and how much improvement is actually there. Again, angle closure cases, they may be suspects or they may be glaucomas, any type of angle closure disease. You have done some form of an intervention. And gonioscopy, it tells you whether the angle has reasonably opened or not. But what out its measurement and its quantification? How much is the success of your surgery? Whether it has opened from 15 to 17 degrees or whether it has opened from 15 to 45 makes a lot of difference. And again, gonioscopy is something we would ourselves not, like to be inserted in our eyes. And with the patients being uncooperative, sometimes it's actually very, very difficult to actually visualize the angles and see what is in the angles, because you have to counter pressure, you create Descemet folds, and the patients are constantly squeezing their eyes. So sometimes interpretation becomes difficult. Whereas anterior segment OCT, on the other hand, is a very sophisticated, non-contact, cool technology. Now, what do the guidelines say? Almost all the guidelines say that gonioscopy is essential, but it is important to remember that it is qualitative and subjective and therefore prone to variability between examiners. Imaging devices, on the other hand, provide a more objective assessment. OCT has a greater sensitivity in identifying appositional angle closure than gonioscopy. And as I said earlier, because these are non-contact techniques, for large-scale screening, non-contact imaging is always preferable. But that is not the end of the story. After having heard all this, perhaps you might feel that, okay, let's go and buy the anterior segment OCT, but there's still more to all this. So gonioscopy, yes, it is time consuming, but if you're skilled enough, it takes less than a minute, especially if you have a 4 mirror or a 6 mirror. It hardly matters to rotate all around and see all the angle structures. Therefore, it provides a quick 360-degree assessment of the angle width with and without indentation. It is important to remember that OCT only measures a very tiny fraction of the angle at one point of time. Scanning of the superior and inferior quadrants is quite challenging due to the eyelids. What is important in glaucoma, especially in angle closures, is the presence of goniosynechia, peripheral anterior synechia, pigmentation, blotchy or patchy, and new vessels. All these will not be picked up at the anterior segment OCT, and therefore these are ones where you would definitely like to actually see with your eyes what lies in the angles. On the other hand, OCT, yes, it detects more angle closure than gonioscopy. So is it a good sign? Well, I would rather say it leads to unwarranted and inadvertent more PIs. So do we really want unnecessary PIs done in all the eyes? These are cases when in gonioscopy you see all these humps and bumps, and you really want to see what is lying there. Is it a cyst? Is it a tumor? Is it an anteriorly rotated ciliary body? So yeah, sure. So you want to see what is there behind. But please remember the anterior segment OCT will not be able to tell you the status behind the iris surface. So in these cases, again, it is just as good as gonio. It's only the UBM which will give you additional information. Quantification, yes, but for this also it requires a subjective input about the location of the scleral spur. If the spur is not well identified, all your measurements will be wrong. Longitudinal assessment, again, if you are unsure that the same region has been scanned, then it will lead to measurement variability. So again, there are lots of subjective factors which are influenced to give an objective interpretation and inference. AS-OCT is something which is technician and operator dependent. So would you want to rely on something which is dependent on the technician, or would you want to believe your own eyes? Software update is always a problem with all these technologies, and there is no way that you can compare the cost of a gonio lens with an anterior segment OCT. So finally, gonioscopy still stands as the gold standard, and anterior segment OCT is definitely a great adjunct. In many cases, when gonioscopy does lag behind, it gives you additional information, but there's absolutely no substitute for gonioscopy. Thank you so much.
Thank you, Dr. Purvi. I mean, the last slide did clarify the message which we want to send across to the audience, whereas anterior segment OCT is a good adjunct, but gonioscopy is mandatory. So we have the next talk, and the next talk is by the President of Glaucoma Society of India, and that's Dr. Chandrima Paul. So Dr. Chandrima, if you can just share your screen and start your talk on disc evaluation, the cornerstone of diagnosis.
Thank you very much. At the outset, I'd just like to make a small correction. I'm the secretary, not the president.
I'm so sorry. I'm so sorry. Yes, the secretary.
And thank you very much, BOA and Moss, and very specially Lahane sir, my good friend, Dr. Ragini, and of course, Dr. Manisha and Dr. Preeti. So I go ahead to share my screen.
Dr. Chandrima, future president, now secretary.
Well, thank you very much for the wishful thinking. Well, so disc evaluation, the cornerstone of diagnosis. High intraocular pressure is not primary open angle glaucoma. And the OATH study did show us that without optic disc assessment, you may be missing up to 55% of glaucoma patients. And disc changes precede visual field loss in most cases. But again, overestimation of glaucoma can happen with a large size disc, congenital anomalies like coloboma and hypoplasia, and peripapillary atrophies. So let us see. If you have a look at this slide, just have a look here. Measurable abnormalities primarily in structure. So here is where, before the tipping point, before we go into the main glaucoma part of it, you can actually diagnose it with the optic disc if you do a very careful optic disc evaluation. And once it goes off the tipping point, then it goes into your functional changes and the other changes when the glaucoma is full blown. And that's a beautiful slide again from Joel Showman. And that's the tipping point, as he said. And this is where you do your disc evaluation. So if you do a very careful disc evaluation, you can actually diagnose glaucoma very early. So any deviation from customary needs should be followed up. So optic disc changes in glaucoma, there are a host of changes which you all know and are available everywhere on the internet. So I'll move on to the next, is that when you have a look at a disc, it's always best to document it so that there is inter-observer variation taken care of when someone else is seeing at your clinic in your place. So recording the disc, that's the best is done with stereoscopic disc examination, but the least that you can do is just draw a disc at your clinic and, you know, remember to actually document all this, the size and shape of the optic nerve, size and shape of the cup, the neuroretinal rim, disc hemorrhage, and the rest of it. We'll come to them one by one. So observe the scleral ring to identify the limits of the optic disc and its size, identify the size of the rim, examine the retinal nerve fiber layer, examine the region of parapapillary atrophy, and then look for retinal and optic disc hemorrhages. So these, as we all know, are the 5 R's of optic disc evaluation. So let's look at them one by one. So that's the scleral ring, and that's the vertical disc diameter and the horizontal disc diameter. I'll come to that in a moment's time. So measurement of the optic disc size is very important because you could otherwise underestimate or overestimate the optic cup. We generally do it at the slit lamp with a high plus lens, and those are the manufacturer's constants for the lens type that you're using. And vertical average diameter of the disc is about 1.8 millimeter, and the average horizontal is about 1.7 millimeter. So size of the cup varies with the size of the disc. As I just told you, large discs have large cups in healthy eyes, remember that. And small discs, you might miss thinking it's a small cup. So it's very important that you actually delineate the size of the disc and then identify the small and large cups and then go ahead from there. So intrapapillary equivalent of the RNFL, so don't confound it with peripapillary scleral ring. So if you have a look at it there, just a second, what is most important here is the neuroretinal rim. The neuroretinal rim has the area that you have to look at. It's difficult to obtain in clinical practice, but you have to look at the configuration and the pallor. So next comes the isn't rule. The isn't rule is we define it by the inferior neuroretinal rim being the largest, followed by the superior, finally the nasal and the temporal. So any deviation from that isn't ruled, so should actually raise suspicion. So the neuroretinal rim, as I just told you, the cup is actually horizontally oval, and deviation from the isn't rule requires attention. Parapapillary atrophy, we are not bothered about the alpha zone. What we are bothered about here is the beta zone, which actually is a prognostic factor in glaucoma diagnosis and progression. So detection of disc hemorrhage requires careful optic disc examination, and with a careful examination, you wouldn't miss the hemorrhage. So localized rim thinning and notching, that's also very important. A notch is almost diagnostic of a glaucomatous optic atrophy impending. And then we come to the RNFL. In the RNFL, you need to notice the brightness, the visibility of the parapapillary retinal vessels, the striations out there, as you see out here, the silvery strands that you see out here. You can actually grade it from normal to grade 1, mild and moderate, and finally severe. And you also have the localized RNFL defects that you see out there. And how to define the cup disc ratio. So if you assign this whole thing as 1, and if you actually minus this, say 0.2, and minus this, it has to be in 1 meridian, and this actually adds up to 35. So you could actually define this cup as 0.65. So the cup shape and disc, as I just told you, the cup is horizontally oval, and you need to look for these localized nerve fiber loss, as you see out there, notching and acquired pit of the optic nerve. And finally, the diffuse rim loss, as you see out here. So asymmetry of cup size is a huge factor which you need to take care of in glaucoma, but it can also happen in other congenital anomalies like morning glory syndrome, coloboma, and congenital pit. So asymmetry of the cup size more than 0.2 is common in the glaucomatous population, and the cutoff is 0.2. Sensitivity of glaucoma detection is about 24%, asserting strong suspicion about glaucomatous damage, correlate with other findings and with the other disc, and can be a useful sign in patients with small discs. So if you have a look at that, the vessels that you see out there, the nasalization of vessels along the nasal margin of the cup, that is also, but it is not specific for glaucoma. What is more specific is the bayoneting of the vessels, as you see out there the bayoneting of the vessel's overhanging edge of the cup make a sharp bend as the vessel crosses over it. So these are diagnostic signs. And that's yes, that's the picture of the forum where you can see all three at a time. The OCT really does not have very much to do with the optic disc. So the errors are not delineating the scleral ring correctly, ignoring the small size of the disc, missing the rim notch, missing the hemorrhage, and missing the RNFL defect. These are cases which show that they are glaucoma, and you can actually miss, you can think this as glaucoma, but if you look at it, the large cup, the normal isn't rule, everything actually is non-glaucomatous. These are examples that I'll just cross through. So in summary, glaucoma is largely undiagnosed, about 90%. Misdiagnosis is common, about 50%. Pay attention to individuals at higher risk, adopt good clinical practice, and ONH evaluation is still the key, and it's a must learn for everybody, and be aware of the pitfalls in diagnosis. Thank you very much for your attention.
Dr. Chandrima, thank you for covering this very essential topic so beautifully. The next topic is the next speaker is Dr. L. Vijaya. She's an inspiration to all of us, and she's going to talk to us on pediatric glaucoma, 10 things all of us should know. Vijaya madam, please.
Okay, 1 minute, I think.
Sure.
Can you see my slides?
Yes, madam.
Yeah, at the outset, I would like to thank BOA, Manish and Priti for the kind invitation. And next 9 to 10 minutes, I will be talking about what I call it as pediatric glaucoma, 10 things all ophthalmologists should know. And the first thing is that there is a lot of difference between the adult and pediatric. It's a basic concept. The adults, it is silent and chronic. It is a degenerative, mainly the medical management we start. These changes are permanent, whereas in pediatric, the disease is highly symptomatic. Most of the pediatric glaucomas can be developmental, especially primary congenital glaucoma. Management is surgical management. These changes can reverse when the IOP gets normalized. Second point I would like to talk about it is we should be talking the same language. What does it mean? That means pediatric glaucoma is a huge complex. Under this, there are many varieties of glaucoma in children. So unless we classify them correctly and label them correctly, we will not be talking about the same disease. The prognosis varies quite a bit between the primary glaucomas and secondary glaucomas. Even among the primary glaucomas, whether it is a neonatal onset or late onset, the prognosis varies. In view of this, the classification has to be accurate and perfect. So what we should do? For that, we should follow a standard classification recommended by Congenital Glaucoma Research Network group, which came out with this classification maybe a decade back. And under this, the glaucoma in children are divided into primary glaucoma and secondary glaucoma. Again, with the primary glaucoma, you will have a primary congenital glaucoma manifest before 1 month of age of the child, which is called the neonatal onset. When the glaucoma happens between 1 month to 2 years, we call it as infantile glaucoma. When glaucoma is more than 2 years, we call it as a late onset primary congenital glaucoma. When the glaucoma happens between the ages of 3 to 16 years, we call it as juvenile open angle glaucoma. Coming to the secondary glaucomas can be associated with ocular anomalies, non-acquired ocular anomalies, such as anti-segment dysgenesis, axon fails, rigors, etc. Or glaucoma can be associated with the systemic diseases or syndromes, such as Sturge-Weber syndrome. And you have a third group where the glaucoma is following congenital cataract surgery. And this is post-cataract surgery with aphakia or pseudophakia. Glaucoma associated with other acquired conditions like steroid-induced traumatic and uveitic glaucomas. So please remember to classify the glaucoma precisely to under what category the child falls into. So what are the criteria to say that there is evidence of glaucoma? IOP of more than 21, optic disc change in terms of that is progressive, including cup disc ratio, asymmetry between the two eyes of more than 2, a focal thinning, evidence of HAP striae, increased corneal diameter, myopic shift or increase in the axial length, and reproducible visual field defects in bigger children. So at least there should be 2 or more of these features to call it as glaucoma. Once you have this, then you categorize them into in what group they fall into. Suppose if you have only one of them, then you call it as glaucoma suspect. If one of that happens to be intraocular pressure should be more than 21 millimeters of mercury, at least on 2 separate occasions. The third thing I like to talk about it, clinical presentation, especially the primary congenital glaucoma, is very symptomatic. The triad of symptoms are photophobia, blepharospasm, and epiphora. Why do these symptoms happen? The symptoms happen because of the raised intraocular pressure. There will be stretching of the eye, resulting in megalocornea that causes a rupture in the Descemet's membrane, which we call it as HAP striae, that results in corneal edema and severe blepharospasm and watering. And whenever you have acute onset like that, you have to keep it in mind possible differential diagnosis. Based upon the symptoms, the differential diagnosis can be conjunctivitis or NLD obstruction. It can be keratitis or epithelial defect. It can even inflammation in the eye. If you have only corneal edema or opacity, we have to keep it in mind possible birth trauma, especially the forceps delivery, which is quite rare. Or you have to rule out CHED or corneal dystrophy. Even keratitis can be differential diagnosis. And to call it a megalocornea, we should know what are the normal diameter for the cornea. At the neonate, the corneal diameter is around 10 to 10.5 millimeters. By end of 1 year, it is 11 to 12 millimeters. At 2 years is 12.5 millimeters. Anything beyond this indicates megalocornea. And once the child goes to the 3 years, that is towards the juvenile open angle glaucoma subgroup, you remember the only stretchable part of the eye in such a situation is only sclera. The rest of the eye gets stabilized. So because of stretching of the sclera, you develop a progressive myopia. Any more progressive myopia that cannot be explained as a refractive error in a child, one should rule out glaucoma. In such a situation, deep antechamber may be the first sign that makes you to suspect possibility of increased axial length. Whenever we have glaucoma in a child, we have to keep in mind certain special situations. Like if you see aniridia with glaucoma, please exclude Wilms tumor. The WAGR syndrome is caused by a mutation in the 11p13 region. And usually in familial aniridias, you don't see this mutation. So Wilms tumor is rare. So if you see a family of aniridia, you can, to large extent, you can tell parents that chances of Wilms tumor is rare. Whereas in isolated cases, we should always look for it and take a pediatrician opinion and follow it up. The second condition I like to emphasize here is beware of the associated anomalies. For example, if you see Sturge Weber's with the congenital glaucoma, a capillary hemangioma can manifest elsewhere in the body, especially in the intracranial location or in the palate. So these things has to be evaluated because they can be a risk factor for the general anesthesia whenever surgery is needed in such a situation. Again, we have to collaborate with the pediatrician and anesthetist and discuss and take into consideration possibility of the complications and manage the situation. The third is congenital ectropenia can be associated with a neurofibromatosis. If you see congenital ectropenia with the congenital glaucoma, neurofibromatosis has to be excluded. Okay, the fifth point I like to talk here is what is the end point, especially when you're dealing with a primary congenital glaucoma, when we operate or treat those eyes. The end point, ideally speaking, it should be normalization of the intraocular pressure, clearing of the cornea, reversal of the optic disc cupping, and stabilization of the axial length. we can easily, we can achieve definitely normalization of the IOP and stabilization of the axial length once the intraocular pressure gets stabilized. But the reversal of the optic disc may not happen in all cases. It depends upon when the treatment has given. If the treatment has been given early enough, that reversal can happen. Same with the clearing of the cornea depends upon what is the extent of the corneal damage and corneal changes. If the corneal changes are not very severe, the clearing can happen if it is only related to the edema. If there is a stromal scarring also, the clearing takes a long period of time, resulting in possible amblyopia as well. So treatment of amblyopia is very, very important. Especially this case, it is a unilateral case. Cycloplegic refraction is mandatory. If you treat the refractive error appropriately at appropriate time, the amblyopia can be avoided. Similarly, one may have to resort to the occlusion therapy. For example, here the child had glaucoma in one eye. So whenever we had in the right eye had the surgery. So in the follow-up, our pediatric ophthalmologist has recommended occluding the left eye so that amblyopia will not take place. Along with the appropriate cycloplegic refraction, we may have to resort to the occlusion therapy. And if the opacity is dense enough, we may have to refer to the cornea colleague for the possible corneal surgery, either PK or any of the newer methods, depending upon the location of the opacity. If the corneal opacity is thinner and smaller, we can even consider doing an optical iridotomy so that even that can stimulate and the entry of the light will be sufficient enough to avoid amblyopia. The advantage of the optical iridotomy, the problems associated with the possibility of the graft failure can be eliminated. So number 6 point I want to talk about is what I call it as optimize opportunities. What does it mean? If somebody is handling children and operating on children for any kind of surgery, it can be retinal detachment or it can be squint or a cataract, whatever it is. Whenever we subject child for any surgery, do a detailed eye exam, especially in high-risk patients like congenital cataract or ROP. Why is it so? Because detailed examination is not feasible in OPD in most of them. So we should do a detailed examination under anesthesia. In adults, before we subjecting them for any surgery, we do a detailed examination and we'll make sure that everything else is all right before we offer the surgery. For the same reasons, when we can't examine child well in OPD, we should evaluate them well under general anesthesia. This is what we follow in our routine. We do a quick external examination, tonometry, whatever method you use, refraction if it needed, corneal diameter measurement, using a handheld slit lamp anti-segment examination, gonioscopy, fundus examination, optic disc evaluation, and biometry and CCT. Gonioscopy in children, you will see a normal angle, but if there will not be any pigmentation. If in a primary congenital glaucoma, you can have one of the two pictures. One is samplesis type 1, the other is samplesis type 2. Type 1, you see dense iris processes, whereas in type 2, you see the anterior incision of the iris. And this is using the red cam. You can see the type 1 here. You can see the prominent Schwalbe's line. That is a posterior embryotaxon as well. 8 is glaucoma following pediatric cataract surgeries. So especially younger age children, we should follow them up very closely because for the possibility of the glaucoma happening with the time. And they may not manifest with the classical picture. Usually diffuse corneal haze is what is seen. Any myopic shift with increased axial length, one should suspect possibility of glaucoma. Medications are usually temporary. Whenever we give, we should always teach mother how to do the NLD occlusion. Avoid brimonidine in small children. So number 10 point is it is a team approach. We have to interact with the pediatrician, anesthetist, other subspecialties in taking care of these children. These are the 10 things I just wanted to highlight that every ophthalmologist should keep it in mind whenever they handle children. Thank you very much for your patient hearing.
Thank you, madam, for a very detailed talk on pediatric glaucoma. And Dr. Ragini, we have, our time was till 11:45. Can we take questions?
Yes, definitely, because the next session starts only at 12. There is some time for this only. Please go ahead. Thank you, Dr. Vijaya ma'am. Thank you, everybody. Thank you so much for a lovely session. Dr. Chandrima, Dr. Purvi, thank you so much.
There
Dr.
is one,
Satyan,
Dr.
Venkatesh.
question by Dr. Vaibhav Shah, that has anybody tried the DIGS Pro Gonio imaging system? So has anybody tried it? It's from the audience. It's a system to take gonio photographs without the slit lamp. So has anybody tried it? If no, then I will. Then the audience knows that yes, at least the glaucoma people have not really used it. Yeah, Dr. Purvi, you wanted to say something?
Yeah, I haven't tried it, but from what I understand and know about this, it's basically a direct imaging of the gonio mirror by a smartphone. So that is DIGS. Yeah.
Yes,
But
that's what it is. Yes.
Yeah, it's just a holder with a smartphone attached to it. So in that holder, we have to fix whatever gonio lens we are using. It could be a 3 mirror, 4 mirror, 2 mirror, whatever. So it just directly transfers the image and you can view it through the smartphone. So what I understand is basically it's limited by the camera resolution, the resolution that smartphone provides you. So again, all those subtle signs which we want to see, that small fine pigmentation and goniosynekia and all that, a fine sampolysis line maybe. So all those are not very well picked up by this system. It's basically right now just used as a screening tool and mainly for teleophthalmology.
Yeah, it's basically to take
conventional-
photographs, yes, and for teleophthalmology, particularly in this era when patients may not have access to a glaucoma specialist. Now, just one question starting from the first talk. Dr. Satyan, I think he has left because he had another talk, but we will go ahead. That after a person who has undergone glaucoma surgery, trabeculectomy, and undergoes cataract surgery, the bleb is more likely to fail. So, how do you take care of the bleb after cataract surgery? Can we start with Dr. Chandrima, please? Madam, unmute yourself, please. Yeah, Dr. Chandrima, yeah, please.
Yes, so taking care of the bleb during cataract surgery, you mean?
After cataract surgery, because the chances of failure are a little on the higher side after doing a cataract surgery.
Well, so you definitely need to, measuring the IOP is definitely one thing after cataract surgery. And apart from that, you need to estimate the bleb as well, the normal bleb grading processes which are there. But I think it's more on practical experience that you actually, see whether a bleb is failing or the bleb is functioning well. It's more, I think, a practical experience which we use.
Okay, so you just keep a closer follow-up on the bleb and the intraocular pressure. Yeah. So the follow-up will be more intense than what you would otherwise do for a cataract surgery.
Of a normal cataract patient.
Yeah. So does everybody agree, or anybody else?
Can I just make a small comment, Priti?
Yes, of course, madam, please.
See, the notion that the bleb will fail following the cataract surgery is age-old. It started maybe 20, 30 years back. And this all with the technology of the cataract has changed so much. Nowadays, I think our incision is so far away from the trap site, and it is less than 2 millimeter incision. If you are careful enough, if you can take care of the postoperative inflammation, you can avoid failure of the bleb. The second thing you can do is you can give a 5F injection on the table. So
on the table, okay.
On the table, following the cataract surgery, closer to the bleb to minimize the possibility of the scarring later on. So it is a notion that is strongly ingrained into us. I think with the modern day cataract surgery, the chances of bleb failure is not comparable to what it was when we were using larger incisions.
Yes. Madam, how often do you give 5FU, what you just mentioned, during cataract surgery? How often do you do that?
Only when I think there is a possibility. I don't hesitate even to do the needling at the time of the cataract surgery if the bleb is compromised at this stage. It could be a functioning bleb. I don't touch anything. I just stay away from that site and operate from a different site. Just take care of the postoperative inflammation.
Okay. Thank you, madam. That's a very useful tip. The next, Dr. Venkatesh, if a person wants to start MIGS. How does one do that? Dr. Venkatesh?
Yeah, like I said,
Yes.
when I was finishing the talk, it's so important to learn the technique of intraoperative gonioscopy.
Okay.
So I would strongly recommend glaucoma or even general ophthalmologists who are doing cataract to practice that. It's very easy to practice when you're doing a phaco. Basically, you need to have that 45-degree angle tilt. You tilt the head away from you and the microscope towards you, and start putting the Swan-Jacob lens, the goniosurgical lens, and start seeing the angle. Once you are seeing the angle, I think you can believe yourself that you can take the next step. So whenever you are taking the next step, I told you about the bang. It's very easy. It's possible. It's practically possible. You can try in wet lab and things like that, but it's practically possible. And we have seen many of our young surgeons doing comfortably, especially the guard and also the bang, which we are doing routinely now. I won't say it's a big practice, but at least mild to moderate with cataract, we are trying to combine. And this will take you to the next step of putting whatever comes in the future. Like iStent is going to come very quickly. So many of these are you're going through the trabecular meshwork into the Schlemm's canal. So if you start practicing intraoperative gonioscopy, I'm sure you're taking one step ahead.
All right. And what about the disposable? Yes.
Can I just come in for a minute?
Yeah, sure.
Dr. Venkatesh, that yes, you have to know how to do a good surgical gonioscopy, because that is tilting the head and getting to look at the angle is something that is really important. But together with that, maybe we should also ensure to say that a MIGS procedure is not for severe glaucomas. It is only for the early glaucomas, because the kind of pressure reduction that you get is not massive. But I'm sure that it is going to be like maybe the surgery of the future if you do it combined with cataract, A, and B, maybe you can do it as a standalone procedure, because it is conjunctiva free. So you have a lot of naive conjunctiva left for future trabeculectomies.
Yeah. I was going to ask the next question, that how is the IOP reduction, but I think Dr. Rita has sort of addressed it. What is your experience, Dr. Venkatesh? Does it give a good pressure reduction?
That's what, from all the evidence we have so far, I kept repeating the same point. It's mild to moderate glaucoma.
Mild to moderate.
It's not your severe advanced glaucoma on 2 or 3 medications. It's still not a procedure of choice. If you are 1 or 2 medications, optic nerve head does not compromise much. I'm sure to preserve your conjunctiva, when you do a cataract, you can combine. And then in case if you need to do an add-on, you can do later the other procedures.
So how much percentage IOP reduction on average do you get?
Definitely, like 1 glaucoma medication, you would definitely get 25 to 30% reduction. So somebody who's on 1 medication with pressures, if you stop that, if it is like 28 or even 30, you can definitely come to the early teens. And cataract, of course, if you combine, I'm sure that adds on to your benefit.
Okay. So for the audience, it is that it is not the surgery of choice when you have progressive glaucomas, advanced glaucomas. It's a surgery of choice, as Dr. Venkatesh said, when it's a mild to moderate glaucoma. And plus, even though it is called minimally invasive, whenever it violates the conjunctiva, you are reducing the success chances of future trabeculectomy. So that also needs to be kept in mind.
More importantly, open angle glaucoma. Even angle closure, if your angle is open, following your laser procedures, if you see an open angle, then some people do it. But it's basically, again, a procedure for open angle.
Yeah, Madam, Vijaya Madam wants to...
No. I think Ramanjit, I said hi to Ramanjit.
Okay, hello.
Two sessions are clashing.
Okay, so it's 11:57. We have to hand over the session to the hall to the next session, and I thank all the speakers for a wonderful session and the audience also. So we end the session, and thank you, Dr. Lane, Dr. Ragini, and Manish for organizing this wonderful session. Bye bye, all of you.
And doing a good job.
Thank you so much.
Bye.
Manish, I think you need to unmute your mic.
No, we cannot hear you, Manish.
Manish. You can hear a lot of background noise, but no speech.
Maybe he
decided to do. You will do all the talking.
No, not at all. Mayuri is there. We can't keep Mayuri quiet.
Now, can you hear me?
Yeah.
Okay. So sorry for that. I don't know what was going wrong, but welcome everybody. And I think I would like to invite Ramanjit Seota madam to take over as the chairman of this session. And anybody who needs to check the slides, we have a minute or two to check the slides. Anybody needs to check slides? Raju, you were.
Yeah, it's okay.
It's all right.
So we
welcome
start session on time.
Session, and we'll first lecture is going to be by Seota madam, and she is going to talk about managing progression. And still we have 1 minute, so we'll wait.
I
Good
think
afternoon,
I
ma'am. Good afternoon, ma'am.
Hi.
So this 1 minute I must take to thank Manish, who put up a beautiful galaxy of stars, and thank you everybody in these difficult times to be with us to promote science. Thank you, Dr. Seota madam. Thank you, Kaushik madam. Thank you, Kamar madam. Thank you everybody who is present here today. And thank you, Manish, for this beautiful program. Dr. Rajul Bhai, Dr. Parul madam, Dr. Chaya, Dr. Indira. Thank you so much, ma'am. Ma'am, you are a great teacher. All of you are great teachers. And we just pray that everybody's families remain safe. And
I think that's something that we all pray, and I think this gives us a little bit of a distraction from everyday sort of worries. But I'm going to start by, shall I start? Is it time?
Yes, ma'am. It's exactly 12. You can start.
Okay, now where do I go? Okay, I was just about to say that I would like to thank the organizers for giving me a grand total of 10 minutes to present a topic that nobody else ever talks about. So I'm going to sort of talk about prevent or stabilize progression. And I think we all understand that life expectancies are increasing. And with that comes our duty to make sure that within a person's life, whether they come to us as congenital glaucomas, juvenile glaucomas, POAG, whatever they come to us with, that we can actually prevent or stabilize the glaucoma at that place. And the only way we can do it if we actually pick the progression up early. The earlier we pick it up, the more likely we are to actually end up intervening and therefore preventing any visual disability. So the general management, I'm sure everybody is aware of, but I just want to reiterate that in our country, there are 3 reasons for suspecting glaucoma: a shallow anterior chamber, optic nerve head changes, and raised IOP. And please do not believe that an IOP of 21 millimeters of mercury is normal. Assess, treat all the secondary or primary angle closures with an iridotomy, assess the glaucoma severity, and then come to a target IOP. I would suggest these that are present at the bottom, but I think everybody can determine things for themselves, but these have worked very well for us over the years. Now, why are we talking about progression? It's because it's common. And the higher the intraocular pressure, you can see the intraocular pressure here was 18, and you can see an almost 80% progression rate. We can also see that there's many things that have happened, and we can actually find out that there is a age-related loss, which is never going to lead to a visual disability. Slow progressors are not going to lead to visual disability. And even with treatment, all we are doing is we are extending the lifetime of vision in those patients. However, the ones that we actually want to diagnose are these fast progressors, where if we pick the progression early, we can actually prevent morbidity. If we do it late, they will at some point get to visual morbidity. What are the reasons for this? A strong family history of blindness due to glaucoma, extremes of age. But when we look at the ocular problems, I think the ones which are sort of most talked about are the severe glaucoma at baseline. And you can take it as a very large or high vertical cup disc ratio. intervisit IOP fluctuations, which I think we should be more aware of. That today the patient comes, the pressure is 14, the next time he comes it's 17, the next time he comes it's 12, and we are sort of saying, okay, he's all right most of the time. But actually these are the fluctuations that actually cause damage. Then of course the kind of glaucoma there is, whether it's an angle closure as compared to an open angle. We know angle closures are more likely to lead to progression. Juvenile open angle glaucomas and pseudo exfoliation. There are many tests that there are for progression, but each of them should actually be able to distinguish variability from actual progression and pick up the earliest change, and ideally not after we've done 5 or 6 tests, but from test to test. Where are we going to look for these changes? I think we're all aware that this is either on the inferior temporal or superior temporal part of the optic nerve head. We're looking for a deepening of existing loss, expansion, or any new defects. And you can use anything. You can use perimetry, OCT, just your examination. But in the early stages, probably a ganglion cell analysis is good. In the moderate stage, anything will do. And in the advanced stage, it's a 10-2 and again, a ganglion cell analysis. Just looking at the optic nerve over time and taking photographs, which also show us the same thing, deepening, expansion, new areas of loss. And you can actually draw a diagram on your clinical record and record exactly the same thing. And this will be corroborated. You can see this very thin RNFL loss. You can see the wider loss 8 years later, and the same thing being shown over time with your perimetry, both as well as trend and event analysis. Perimetry can be used, and it's suggested that you concentrate on already defective locations every time you look and look for the rate of progression. So in the rate of progression, again, there's some amount of aging that takes place. And for a VFI, it's 1% per year. The progression is anything 2% or more. And for fast progressors, it's more than 5%. These are not sacrosanct. I think people are still evaluating to see what we should do. And I think the newer HFA actually flags that significant change with every test. So this is something that we could look forward to, while the Octopus actually gives us cluster trend analysis over time. Imaging has many fallacies. Please do not say that it's objective and therefore, we can take it as the gospel truth. There are problems with centration, the quality of the scan, the presence of artifacts, but still it is more objective than perimetry. And here it is said that aging causes about a 0.5 micron per year loss in RNFL, and therefore more than 10 microns per year loss should definitely be considered to be out of normal range and glaucoma. Again, we're looking for the same things, widening, new defects. Basically, it's the same thing that we look at over time. We have to be aware that there's a floor effect when we get to about moderate to severe glaucomas, and the RNFL may not be used from then onwards. So you have seen that there is a trend analysis and an event analysis on perimetry, exactly the same on OCT, a trend analysis, and showing you a localized loss by the change on RNFL profiles. All OCT machines give us this, the ganglion cell analysis. Again, we are looking at the arcuate loss, and we're looking at widening of this loss or a thinning that is 1 to 1.5 microns per year. How do we manage progression? I think the management will differ on the severity, on what you're following the patient up with, what are the risk factors the patient has, and we're then saying that there's going to be a periodic evaluation for change once you've made a diagnosis of glaucoma. So you're going to be watching out for intervisit fluctuations. You're going to be having some objective record. I think everybody can do a fundus photograph these days. You can make a diagram. Perimetry and imaging, you need at least 5 fields to do any sort of analysis, and imaging, you need at least 4 images. So you are then going to see, is the patient stable and the patient quality of life is maintained, then you're not going to worry too much. If the patient is stable but uncomfortable, you need to do some alteration in the medications. However, if there's progression, this is what we actually have to identify fast progressors, as I've said, and ask the patient the certain questions. Is the target IOP achieved or not? Is the patient compliant or not? Has a gonioscopy been done and recorded? And is there any inadvertent use of steroids? We also have to keep in mind that there are other causes of visual loss which show up as progression, either on the OCT or on the field. So if we are looking at the important ones, you actually have to look for compliance first. You then want to know what is the rate of progression, what stage of the glaucoma, And is the scotoma central or further towards the periphery? We are all aware that the higher the IOP, the more chances of progression. But if the patient himself or herself says that they're not very compliant, I think most often it's because our prescriptions are so difficult. I will talk about prescriptions a little later. So you can simplify the prescription. You can ask them to use phone alarms. You can make sure they actually can afford the medications. On the other hand, if the patient says, I am absolutely compliant, I have nothing else in life to do, I put the drops on at the right time, we have to check the efficacy of the drugs, because we know that 10% of patients are non-responders to all our glaucoma medications. And you also have to check that he hasn't used any steroids, which he has subsequently stopped. And therefore, at this point, the IOP is high and you're beginning to see progression. The last point, of course, is to make sure they know how to put the drops in, that you make a little pocket of the inferior lid and make sure the drop goes in. Close your eyes for a minute and wipe out any excess fluid. So these are target IOP ranges, which I think a lot of you may have seen. For the early defects, it was 15 to 17, 12 to 15, and 10 to 12 for the most severe. So when we are finding that despite reaching these target IOPs, there is progression, the first thing, of course, to do is to move to the higher step. So if you were doing 15 to 17, you move it to 12 to 15. And you reassess and say that if there's a very fast rate of progression, I probably don't need to go to 12 to 15. I need to get to 10 and 12. You find a lot of fluctuations, and you're probably looking at things that keep the IOP controlled for 24 hours, like prostaglandins or surgery. If the fellow eye has already gone blind from glaucoma, you want a very close review after you have reassessed and changed the target IOP. But remember, you must reset both your perimetry and imaging, and this can be done by the last two tests that actually showed you there was progression. So what do we do with the medications? I think you have to remember, and I was telling you these complicated prescriptions. This is the kind of prescription that normally comes to us. Patient has been on medications for the last 3-4 years, and we're not even sure how is he putting, once a day, twice a day, 3 times a day, 4 times a day. So the same kind of, exactly the same drugs can be given in a much more sort of organized manner, twice a day, 15-minute intervals, and 1 at night. So you have to make sure that you are making it simple for the patient. You have to keep telling yourself that both eyes behave similarly, even if asymmetrical. So you might find that one eye has greater damage, and we put all our attention to lowering the IOP there, and we forget to look after the better eye. Actually, we should be constantly treating both eyes equally. Check to see whether the beta blockers, which is one of our most effective medications, has not been used for 4 years, 5 years, 10 years, because you might find this tolerance. And if you give a gap for about 6 weeks and then restart, it definitely starts working again. You have to use medications that are working on different outflows. There's no point in having 3 medications working only on the inflow. So if you have timolol, you have dorzolamide, and you have brimonidine, the efficacy of the second and third are going to be less. On the other hand, if you use a timolol that's working on the inflow, PG on the uveoscleral outflow, and ROCK inhibitors on the trabecular outflow, you're probably going to get a much better additive action. So decrease the number of bottles the patient has to actually use by using combinations, and decrease the number of applications. Make it BD as far as possible. The caregiver, the patient, everybody will be much more compliant. But we have to think of surgery, because surgery actually has many advantages. So the indications for surgery in case of a progressive glaucoma would be if there's fast perimetric loss, if there's a central visual field loss, which has actually occurred or is threatening, and if there's a moderate to severe disease. What we have seen, now we have data over 10, 20 years, that it's a safe surgery if you use low-dose mitomycin and you use releasable sutures in patients with advanced or severe glaucomas. It reduces the IOP anything from 30 to 60%. It reduces the fluctuation, intervisit fluctuation, diurnal fluctuation. It may, over time, and what we've seen is 4 or 5 years after the trabeculectomy, may need to add additional glaucoma medications. That's not a problem. And maybe about 5% of them may require a repeat surgery in 10 years. However, with medications, 90% of them show qualified success to target IOP over 20 years. And keep in mind that the IOP fluctuations are reduced, plus you no longer have to depend on the patient for compliance, for the ability to go and buy the medications, for the medications to be available. Selective laser trabeculoplasty is something that a lot of people are talking about, and the LIGHT study has recently shown us that if you do a 360-degree selective laser trabeculoplasty, the mean effect, I mean, most of them had less, some of them had more, was 8 millimeters of mercury. So if you're starting at pressures of 26, 28, please remember that you're only going to get to 20. What they have shown as success is a 20% IOP reduction, and said this worked in a large number of ocular hypertensives and mild open-angle glaucomas. Please do not use it for moderate or severe glaucomas because it will not reduce the IOP adequately. It can be used with medications. The selective laser trabeculoplasty is thought not to work as well in patients who've been on prostaglandins. So just to take a few cases before I end, you have patients with ocular hypertension with an open angle or a PAC with ocular hypertension. And both the patient and the doctor are not convinced that, the medication is required. So we had this lady whose IOPs were 22, 24, and she was okay. I mean, we didn't give her any medications. Her CCT was about 600. So we thought, okay, let her be. So for 14 years, she came back regularly. She was stable. And then suddenly we saw that there was an increase in IOP to 26 and the visual field fell. So when we went back, we realized that she just in the last year changed the cream that she was using. And when we looked at the cream, there was steroid in it. So in normal fields, remember that, there's not a gradual sort of loss. You can get a sudden loss in vision. And imaging in these cases, here it's an HRT, but with an OCT, you'll be able to pick it up earlier. And here with a GCC, you'll be able to pick up the changes early as well. And these are highlighted in red to show you which are the areas that are changing. What about a PUAG suspect? Now you can see the disc is showing us a certain amount of cupping. There's thinning inferior temporally. So this gentleman was told, you have a suspicion of glaucoma. You don't have any visual field loss yet, but you have a family history, come back regularly for a follow-up. And he did. So we had a baseline IOP of 20 to 24. We gave him timolol alone, and for 2 years, he was fine. At the end of 2 years, his IOP started again reaching 20. So we thought, okay, let's add a prostaglandin. Sorry, we switched to a prostaglandin. And after switching to a prostaglandin, what we noticed was that there was a gradual decrease over here, and the rate of progression was now minus 1.5, telling us that we're getting to a point where progression is likely to occur. So we quickly changed the patient to 4 medications, and we found the pressure was still hovering around 18, 19. And because we could now begin to see changes on the perimetry, we actually had to go in and do a trabeculectomy. So PUAG suspects, especially when you can see that there's a significant thinning, please be aware that, again, they're not going to gradually change. You can see here the change is very, very gradual. Here we changed to prostaglandins. Again, it was stable. And then suddenly you can see the loss here again. And therefore, we had to do a trabeculectomy. This gentleman, on the other hand, had angle closure glaucoma. And you can see that he was absolutely stable. All these years, he was stable. Pressures were 14 to 16 on prostaglandin and timolol. He moved out of Delhi, and somebody outside did a phacoemulsification and said, you don't require 2 medications. You're absolutely stable. So why don't we just make it a beta blocker? So they changed to a beta blocker. And he came back to us again with this kind of a steep drop. And here you can see the octopus is actually showing us where to look for changes on the optic nerve head. This is the polar trend analysis. So we thought maybe he's been on beta blockers for a very long time, for almost 7 to 8 years. So we took them off for 6 weeks, gave a stopgap brimonidine, then switched back again to dorzolamide, timolol, and prostaglandins. The IOP is now 12, and you can again see that it is becoming stable. And it's been stable over the last 4 years. So whether open angle or angle closure, please consider that, beta blockers do show waning over time. And people who have absolutely normal fields of very slight paracentral defects will tend to progress if you're not careful with the intraocular pressure. This gentleman had a open angle glaucoma. And what has been said is the first 5 fields can generally predict further changes. So we didn't have time to do 5 fields. He did 1 field and then decided that RP center was too difficult to come to. So he went to his local ophthalmologist. At the center, we had asked him to use a PG analog, and his IOPs were 15 to 17. He had very early glaucoma, so we didn't really bother very much further. He then was lost to follow-up for 7 to 8 years, and he came back to us with an IOP of 22, saying he was using on and off prostaglandins, but not very regularly. So when we explained to him the problem, we told him that your visual field is actually showing us very significant changes. We need to change your medication and get your target IOP now with a moderate glaucoma to about 12 to 15. He was willing to do it, and therefore we added dorzolamide and timolol. Again, you can see that once we added that, the progression seemed to sort of stabilize for a little while and then started again. So at this point, we did a trabeculectomy to make sure that no further changes occur. And for the last few years, he has been exactly there. What about the diagnosis of chronic simple glaucoma that we all see in our clinics? The patient will come saying, I have records over the last 5 years. The diagnosis is chronic simple glaucoma. And you look at the records, the pressure is 14 to 22 on Lumigan and timolol. There are intervision fluctuations which are 6-8 millimeters. The patient has progressed from an absolutely normal field to biarcuate scotoma. So you must look carefully at the patient. You can see the shallow AC. You don't have to do anything more than that. You can see the Van Herrick. So when we did a gonioscopy, this was the picture that we got. And we therefore immediately did an iridotomy and changed her medication. Sometimes you can change from one prostaglandin to another and get some extra efficacy if the other one has been used for a long time. We also added a combination of timolol and pilocarpine because we've seen this in PACG eyes that they actually work very well. And we tried the use of ROCK inhibitors. The pressure is now 12 to 14 and the patient has been stable for the last 10 years. To end, I would like to say that there are cases where the IOP off treatment is never more than 18 millimeters of mercury. But because of the look on the optic nerve head, the fact that this showed us collaterals, we put the patient on medications. That was a prostaglandin because prostaglandins can lower IOPs that are even within the normal range. We gave them brimonidine for the possibility that it has some neuroprotective effect. But we also went ahead and did a carotid Doppler and an MRI. And what we found was that there was an 80% block on both sides with on the carotid Doppler, and the MRI showed us multiple microinfarcts. So in these normal tension glaucoma patients, please lower the IOP, but remember that they almost always have some other problems which need to be taken care of as well. Now, we did sort of think that we could try Repacidil because they're saying again, Repacidil lowers IOP even in the normal range. We do give antioxidants and we do give vasodilators in these patients if they tend to show.
Madam, you can sum up.
Yeah, this is the last slide. Sorry, home monitoring is a possibility. This is the last slide. So the idea is that you stop the glaucoma wherever you see it. And this can be done if you diagnose progression early. So concentrate on already defective locations which are going to show deepening or widening. And the management is lower the IOP and most often lower it to less than 12. Do not miss angle closure. Check for steroid use. And even a cream put on the feet can cause problems as far as the IOP is concerned. And think about early surgery if you find the progression continues despite 3 or 4 medications. Thank you.
Thank you, madam, for an excellent coverage of a very difficult topic and a lot of insight. Thank you very much. And I would like to start with my next talk, which is I'm going to talk on raised intraocular pressure after very commonly observed after the cataract surgery. Am I audible and visible?
Yeah, yeah.
Yes, yes.
So good morning. and I will be talking on this subject of raised intraocular pressure after cataract surgery. It is a very common to observe this, and studies have shown that up to 24 hours, you have up to 18 to 45% patients who have had cataract surgery showing a spike. But in only 1 to 10% is the spike over 30 millimeters of mercury, and a large percentage of these patients, the pressures come back spontaneously within the normal range. However, these are the situations where the risk is there that this pressure spike can cause serious problems. The first, as we all know, is a pre-existing glaucoma and ocular hypertension group, where they already have pressure problems, and cataract surgery can precipitate a spike in them. Moderate myopia and patients with pseudo-exfoliation who still don't have glaucoma are more prone to get these kind of pressure spikes. The second clinical situation is where you have a posterior capsular disruption during the surgery, and we know that this increases the risks in cataract surgery of so many things, including a pressure spike. The retained viscoelastics have been researched extensively and have been reported to be a cause for the pressure spike, especially the dispersive type of viscoelastics, because they cannot be completely removed from the eye very easily. The factor that trainee surgeons or surgeons with less surgical experience, incidence of the pressure spike has been higher in this subgroup, probably because of the prolonged surgical time, excessive tissue handling, etc., and probably the higher incidence of complications such as the posterior capsule problems. IOLs which are placed in locations other than the capsular bag, such as anterior chamber IOLs, are associated with 38% of pressure spikes, and sutured posterior chamber IOLs also about a similar percentage of pressure spikes. So if you know these situations where you are likely to face the problem more commonly than normal, then you can be more careful. So what are the mechanisms which play a role in this? As we know, inflammation and hemorrhages, even small hemorrhages, can block the trabecular meshworks temporarily and cause the pressure spikes. Viscosurgical devices also are known to cause the blockage of the trabecular meshwork, especially, as I mentioned, the dispersive types. Release of iris pigments by the IOL haptics and handling during surgery can also result in this. And of course, we have to remember that we all are using steroids in post-surgery after cataract surgery, and steroid response is known to occur, again, more likely in glaucoma patients and ocular hypertension. So when you have a scenario where you are anticipating that the pressure spike is more likely because of risk factors, you can do preoperative prevention. Acetylsalamide 250 milligram tablet 1 hour prior, or brimonidine 0.2% twice a day, 24 hours prior to the surgery, have been reported to be very effective in blunting these spikes and almost eliminating them. Intraoperatively, obviously, as we have mentioned, very good washout of the viscosurgical material and a short surgical time and placing the IOL most appropriately would definitely help. Also, intracameral injections of acetylcholine and carbachol are known to blunt these pressure spikes. However, once you have already had the pressure spike, how are you going to manage? Naturally, in most of these patients, majority of the patients, you are going to opt for medical management, and oral acetazolamide given for a short duration, extremely effective medications unless it is contraindicated. Topically, timolol by itself or in combination with brimonidine or dorzolamide, also very effective. And the new kid on the block, the Rho kinase inhibitors, because they are known to inhibit inflammation, especially repasudil, and some beneficial effect on the cornea. So you may use it in the post-operative scenario. However, drugs which fall into the category of prostaglandin analogs and pilocarpine, because they are known or likely to increase inflammation and can cause cystoid macular edema in cataract operated eyes, we would not generally like to use them in this scenario. Then there is an incidence, I already talked about the IOP spike which occurs in the early post-operative period. This is the IOP spike, which is called a late IOP spike, which occurs more than 10 to 15 days after the surgery. Very commonly either presents with pain, lacrimation, reduced vision, and sometimes redness. The possible causes are many in this scenario. As I mentioned right in the beginning, steroid response is likely to occur, and you have commonly missed secondary glaucoma scenarios, while some amount of small neovascularizations and angle recessions may be missed in your preoperative evaluation. Retained lens matter, sometimes you can, while doing the surgery, you have noted that some lens matter may have been retained because there was a posterior capsule rupture, but you have scenarios where lens matter can be retained in the absence of capsular disruptions and often missed by the surgeon. So when you have a late spike, you have to go back and examine the patient very carefully, and dilated examination also see the fundus, and sometimes you need to do additional UBM and B scans. The treatment will definitely depend on what you see. So as you can see here in this example, fine blood vessels are seen with a corneal haze due to the raised pressure. Sometimes the blood vessels are so subtle that you don't see them very easily, but they can result in the pressure going completely out of control. So management, as I mentioned, is going to be on the cause. So you have to look for the cause and determine what is disrupting the situation and treat accordingly. So if you have retained viscomatter or you have lens matter, then you would definitely like to do a surgery, repeat, and wash out the material. In secondary pupillary block scenarios, you would like to do a laser PI. If the IOL malposition is the cause because of low-grade inflammation and release of pigments, you will have to reposition the lens. And in some cases, because of neovascular glaucoma and angle recession, you have to manage appropriately to that. So this is a few examples of these late spikes. Patient suddenly who was doing very well with 6S vision comes one day with redness, pain, watering, and IOP spike. Is managed medically but recurs. That is the time. Gonioscopy is sometimes very valuable because a small retained matter of lens which is not visible on slit lamp is going to be seen on the gonioscopy. Non-diabetic patient presenting 1 month after the phacoemulsification with pain and reduced vision and a pressure spike. And you can see here florid neovascularization on the iris, which was obviously not there when you operated the patient. It was not there when you had seen the post-operatively, and has suddenly appeared afterwards because of retinal pathology, which was pre-existing but was missed. Again, a similar patient coming with recurrent complaints of pain and blurred vision. Almost a month after surgery, anterior segment is totally quiet, but when you do the B scan, you can see definite high refractivity points in the vitreous cavity. This is lens matter, which is displaced down, resulting in some amount of inflammation and pressure spikes. And to solve the problem, you will have to go in. This is an early post-operative patient who had a small incision cataract surgery, not a phacoemulsification. And patient had severe pain and raised pressure very early post-op. And this is a UBM picture which shows you that there is an occlusal pupil because of inflammatory material, and there is a lot of material which is collected between the iris and the lens, even though the lens is placed in the bag, but this is causing shallowing of the anterior chamber and raised pressure. So you have to look at these things, and appropriate management would be an iridotomy and anti-inflammatories, and you can solve this problem. This is a malpositioned lens. The one haptic is in the bag and one haptic is in the sulcus, and the IOL is touching the iris, causing rubbing of the pigment, release of pigment. Naturally, it is over time going to lead to pressure problems. And this is a patient who did very well, a very quiet eye. Patient had very good vision immediately after surgery. And in a few weeks, patient presented with some amount of corneal haze and pressure spike, and a gonioscopy showed an angle recession. As we know, angle recession occurs due to trauma, but it can present with glaucoma anytime afterwards, even years later. And if you have it that way, it can happen after a cataract surgery. So looking at your patients very carefully when you have pressure spikes and managing appropriately goes a long way in preventing further damage to the patient's eye and getting good vision recovery. Thank you very much.
Thank you, Manish. That was very comprehensively covered. I think these are common things which we don't really look for. We now have Parul, who's going to talk to us about contrast sensitivity and glaucoma.
Dr. Parul, you want me to put on your sheet the presentation, and I can do it. So Parul had some problem regarding her.
Yeah, we all saw her message.
Yes, yes. So I will be playing her video for her.
We can't hear you.
Arun, you can start commentary.
Manish, is
Dr.
there
Manish? Sound is not there.
Is there a sound? I think that sound is not coming.
Sound is not coming.
No.
I'll probably redo it.
Such high contrast is not usually seen. Very soft.
Ma'am, I'll do it like this. Dr. Manish, if we can just play it from the beginning, then I'll speak over this only.
Yeah.
Well, I'm so sorry for the technical glitch that I'm facing today. I'll be sharing my views about contrast sensitivity and glaucoma. So in our day-to-day practice, we usually focus on intraocular pressure, visual fields, and optic nerve head, but we usually fail to ask our patients what they are symptomatically feeling when the disease is progressing or when they are facing a moderate to severe stage of disease. So in real life scenarios, the contrast is not as bright as you see on a Snellen visual acuity chart. During dawn and dusk-like situations, the driving can become very difficult for such patients, and they take a while to adjust from coming from outdoors into the rooms when the light has to adjust. So this study showed that when the patients were asked what they saw in real life situations, they found that they needed more light, and blurry vision was one of the most common complaints that they had, in contrast to the traditional teaching of peripheral constriction of vision. So definitely contrast plays a very pivotal role in the life of patients with moderate to advanced disease. Next slide, please. So this is something that we really need to look at, because even in early glaucoma and in patients with ocular hypertension and pre-perimetric glaucoma, the quality of vision may be well retained, but the contrast gets compromised. And therefore, it's, I think, essential that we focus on this element too, because it's so important in target identification, wherein the day-to-day activities like driving, walking, and even facial recognition can get affected. And both central as well as peripheral contrast sensitivity gets affected. Till now, most of the tools had been looking at only the central contrast sensitivity, and a lot of tools were based on alphabet recognition. But the problem is that the alphabet charts, they fade over time, and the patients can remember the charts, and for illiterate patients, those cannot be used. But with newer computer-based techniques, tests like Aston test or the Spaeth-Richmond contrast sensitivity test, they are grading based, and they have taken care of the drawbacks of the previous test. And SPARCS is one of the tests which looks at both central and contrast sensitivity. So I'll be talking about a couple of studies from this test. I've been using it since past 3-4 years for my glaucoma patients. And this test actually checks both central as well as peripheral contrast. It's based on gratings. And there are 4 quadrants in the periphery. So each quadrant gets a score of 20. The central quadrant also gets a score of 20. So out of total score of 100, we get a comprehensive SPARCS score. So we can monitor our patients based on the changes in a particular quadrant or in the center or total score. So this study from the group that made SPARCS found that SPARCS score of less than 70 has been shown to have about 80% sensitivity and 93% specificity for glaucoma. So it definitely can act as a good tool in monitoring our glaucoma patients. So for the average patients, the score was around 60. The evolution of contrast sensitivity studies has shown that it was only lately that contrast sensitivity has been recognized as a predictor for rapid progression of glaucoma. So now with the newer pixel dithering techniques that are available for online contrast sensitivity tools, we are able to use contrast sensitivity as a better tool. So before we started using SPARCS in our practice, we thought, why not compare it with Pelley-Robson test, which has been there since very long. And we found that SPARCS has a potential to differentiate between different grades of glaucoma patients much better than Pelley-Robson sensitivity. It had a better sensitivity as well as specificity for detecting glaucoma.
It has also been recently used in a study wherein SPARCS was used to stage advanced glaucoma, and it was found that the total SPARCS score, accumulative of the 5 quadrants, of less than 45 and less than 38 predicted severe glaucoma, and that corroborated with the mean deviation on the perimetry of less than -20 decibels and -30 decibels. So at the point when your OCT becomes redundant, the PSD is not available on the visual field printout, SPARCS in conjunction with mean deviation can definitely add an insight to what's happening at the center of the visual fields. Yet another study where Pelli-Robson test and FRACT were used as 2 contrast sensitivity tools in patients with advanced glaucoma, and the results reiterated the fact that despite near normal visual acuity, these patients have profound deficits in contrast sensitivity, and therefore contrast sensitivity assessment can definitely provide additional information on the central visual function for these patients. So whichever tool you have, it's a good idea to start using it, at least for your moderate to advanced patients. This study, which looked at visual field progression and contrast sensitivity, they found that SPARCS was able to predict rapid progressors vis-a-vis the Pelli-Robson test. So it highlights the fact that we really need to look at peripheral contrast sensitivity, which has often been overlooked till now. And even the parameters which required contrast sensitivity in rapid progressors were all subdued in patients with advanced glaucoma. So SPARCS definitely provided a hint to catch these patients well in time and provide a necessary therapy. So we also studied moderate to advanced glaucoma patients and followed them up for 2 years using SPARCS. And we found that the correlation between SPARCS and the mean deviation was non-linear, but the SPARCS scores correlated better with each other than mean deviation and pattern standard deviation, thereby suggesting that they are more robust indicators at the end stage disease and therefore can be used as a reliable marker to detect progressive changes. Now, in COVID times, a lot of our patients have not been able to attend our clinics for their regular visual field or OCT testing. So there is a new function with SPARCS which can detect 10, 20 or 30% change in a particular quadrant, or and the patient can take up the test at their home. So an email is sent to the primary physician if there is any change, so that they can modulate the therapy accordingly. So since the patient can take the test free of cost from the comfort of their home, I think this is a good idea to at least have some sort of a marker. Does intervention improve the contrast sensitivity? And the answer to this is yes. So 60 to 70% patients have noted improvement in their contrast after institution of both medical as well as surgical reduction of intraocular pressure. So yes, a proper monitoring of contrast can give us an insight to what's happening. This paper is under review. So we gave treatment naive patients with no other history of contrast sensitivity, reducing conditions, travoprost, and we found that at all time points after giving the treatment, the contrast improved. So we should ask our patients if they are having problem with adjustment in light when they come from outside to the room, and we can suggest some measures like a higher contrast background to make their life better, watches which have high contrast, telling them to put pour milk in a darker mug so that they don't spill over. So light crockery can be avoided in places of dark crockery. And to cut the glare that is associated, yellow or amber tinted glasses can be suggested, and smartphones or tablets, whatever they use, have specific apps to make the contrast much better and make their life much easier. So with this, I would like to conclude that yes, contrast sensitivity is something which we really need to start looking at. Different contrast sensitivity tests exist. So whatever you are comfortable with, I think we can take a pick and start using that test. And extra focus on patients with moderate to advanced glaucoma should be given. And if we are seeing it, I think it's a good idea to pay a little bit of attention to the peripheral contrast as well, when you sometimes feel that the target pressure has been attained and the patient is still deteriorating. So maybe peripheral contrast can give us an idea. So with this, I wish everybody good health And I wish everybody and their family remains COVID safe. So thank you so much.
Thank you, Parul. I think that was something that we don't actually look for. And I think none of us have this spark, but we should sort of definitely start listening to our patients when they complain about, I'm having more and more difficulty despite a 6x6 vision. We now have Dr. Mayuri talking to us about trabeculectomy blebs and hopefully telling us how to get good success out of them. Mayuri, we can't hear you.
I've already unmuted my. Can you hear me now?
Yes, but very soft.
At the outset, I would like to thank BOA and MA. Mumbai.
Could you increase the volume a little bit more, Mayuri? Am I the only one or Manish?
No, all of us can hear her softly.
It is soft.
So just...
I will try to be louder.
Okay, all right.
Yeah, Mayuri, talk as loud as you can.
I can shout, Rita. Okay, I will be talking in vivo evolution of post-trabeculectomy bleb. And we know that trabeculectomy is still most effective in filtering surgery, even though more and more new options are available now to us. The long-term data shows efficient control of IOP up to...
You stop sharing.
Not.
Start share again. Yes.
Can you see now?
It is showing the other screen. It's not showing your presentation.
Let me do it again.
Manjula, can you help?
Yes, doctor.
Can you see me now?
No, we can see you, yes, but not your screen.
Okay.
Hello. Doctor, can you open your file in desktop, doctor? Hello?
Yes, yes, I have already opened it.
Okay.
Is it okay?
Yes. Yes.
Can you see now?
Yes.
Okay. So in next 8 minutes, I will try to show you some of the pulse, how you can have a success. You can monitor your bleb, which is the only data that you can use. The long-term success is already been shown by the Ramanji that at 20 years also you have a successful trab. But this graph is showing you that in initial phase, it was highly successful, but then there is a steep downfall and then it becomes steady over a period of time. Up to 60 to 67% of the patients are successful. Now we have to find out what is happening at this level so that we can prevent the failure. Various classifications are available, clinical classification like Moorfield, which includes the bleb area, height, and vascular. But these are all subjectives. It may not be same for you and same for me. The Indian bleb morphological IBEX classification is better than Moorfield in a way that it has included the CEDALs also. And the new one which is available is the MIGS classification, which has included the height, vascularity, and also the height of the transparency of the bleb. It is transparent or non-transparent, but it also includes the micro assist, appearance, conjunctival mobility, and the CEDALs. So whatever the comparison is shown here, everything is same with all the three, but the last one, the newer one, has the bleb transparency and microcyst in addition to the conjunctival mobility, which is also a sign of a good bleb, functioning bleb. So, but what is happening in vivo actually will give you more guideline, and with the help of the imaging technique, you can look what is there inside the bleb and decide on the functionality. So this is how we take the cross section from the bleb area. It should go with the center of the bleb and the horizontally at the exactly on the top of the elevation. And then once the scan is taken, various things that you can visualize here is the subconjunctival fluid space or suprascleral fluid space and multiple small anoic area which are showing you the aqueous drainage and the root behind underneath the scleral flap and the sclerostomy site. Various studies are there which has also shown that the AS-OCT or the UBM can be a promising tool to know the filtering bleb functionality, and once you can know the features of this morphology, you can predict the outcome and you can manipulate accordingly. The ideal bleb should have a numerous microcyst, diffuse bleb and the moderate elevation, but it can be better evaluated. You see in this photograph with the AS-OCT compared to the slit lamp examination. It gives you so many details, the microcysts, the separations and the multiple layers, and these are the identification of the ideal bleb. Sometimes the clinical picture, the transparent bleb with a good elevation could be a deceptive picture. Good looking bleb may not be always a good functioning bleb. As shown here, the thick fibrous membrane is giving you the elevation in this area and it's not a very good functioning bleb. So can we predict the failure by utilizing the modality? If we can we recognize it early? And if we can prevent, can we manage it in a better way? So the cause of the bleb failure by and large is the vascularization and the fibroplasia subconjunctivally and or in the episcleral space. First, rule out the occlusion which is of the internal ostium and then look at the suprascleral and subconjunctival space. But the most important step first is the recognizing its presence of the failing bleb. So what I can say is you can predict the long-term success at 1 month after doing examination with this imaging technique. The bleb wall with the multiform reflectivity showed increased chance of success of functioning of filtering bleb at 6 months. Same thing, the bleb pattern with the multiple internal layers and microcyst is also a highly successful bleb for the future. These are some of the examples. The bleb wall reflectivity is divided into uniform reflectivity. Here you can see the dense white area, which is the hyperreflective area. And many a time these bleb shows the failure in the future. While the multiform reflectivity, where you can see the multiple these black areas or tiny cavities of the aqueous drainage, and these wall type of a bleb carries high success rate. Again, the multiform bleb wall reflectivity is divided into the multiple internal layer as shown here, or the subconjunctival separation. Usually it is seen in the initial part, and the multiple microcysts like this. So the third one is the ideal one, and the other two are the suboptimal. Root beneath the scleral flap can also be identified in a case where you cannot see the internal ostium due to some reason, but it doesn't carry any significance as far as the functionality prediction is concerned. Again, we should know that both eyes of the same patient may behave differently as shown in this slide. So we have also published one study to correlate where we correlated the morphological features of the bleb on AS-OCT at 1 month with the bleb function, which is surgical success. IOP was compared at 6 months. And this is what we found out, that if the wall is having multiform reflectivity with the microcyst and subconjunctival separation, it is going to be 100% successful bleb at the long-term follow-up. This is the recent study, Japanese study, which has also shown one additional finding, that if the width of the filtering opening is larger or wider, then it is a good predictor. So they have used the 3-dimensional AS-OCT. We know the dreaded complications, some of them are shown here of the MMC, and that's why the people have started using safer alternative, that is Ologen bleb, which gives you thick wall bleb. Now what is happening with this implant and bleb is, I'm going to show in a couple of slides. The Ologen implant is a biodegradable implant. It absorbed by 90 days and leaving behind its place of fibrous sponge, a negative copy of the. So the absorption of this will leave the microcystic space underneath it on suprascleral space, and at the end it completely absorbs. So there is a shrinkage of that material, the fibrous tissue, leaving the larger anoic area on the suprascleral space, which is not like mitomycin bleb. And then subsequently you can see the microcystic area in the periphery. So this is day 1, first week appearance, homogeneous implant is seen. Only small area of the cyst is seen here. At 3 months, you can see that something is coming up here, translucent area of the aqueous, and few aqueous separations is also seen, in aqueous cyst as there. And at the end of 12 months, you can see a clear-cut aqueous pocket here, one more here. So basically, there is a shrinkage
We
of
need to wrap up.
membrane. So last slide is to show you the tenant cyst, what happens after the completion, needling. There is a flattening, and at the end of 6 months, it was a functioning small space here. So implication is you can have a better understanding of bleb morphology, you can predict this outcome, and you can manipulate accordingly. Thank you.
Thank you very much, Dr. Mayuri. I think what we'd also like to know is, if they're failing, what should we do? So maybe that's a question that you can answer at the end if we have time. We now have Dr. Indira Durai talking to us about a complicated sort of glaucoma, which is difficult to treat in most cases, Aniridia.
Good afternoon, everyone. At the outset, I'd like to thank all the organizers of BOA and Dr. Manish Shah for giving me this opportunity. So today I'll be talking about glaucoma in congenital Aniridia. So a 17-year-old male was referred to us with bilateral congenital Aniridia and refractory glaucoma on maximum medical therapy with no history of any prior ocular surgeries for further management. The patient was found to be monoocular with no perception of light at the right eye and having a best corrected visual acuity of 20/200 at the left eye. Anterior segment examination of both the eyes revealed conjunctival xerosis with pannus, total Aniridia, a clear lens with pendular nystagmus. Fundus evaluation revealed a glaucomatous optic atrophy in the right eye and a cup disc ratio of 0.8 in the left eye, along with foveal hyperplasia. The intraocular pressures were found to be 40 mm of mercury in the right eye and 30 mm of mercury in the left eye, recorded by Goldman's applanation tonometer, and central corneal thickness was found to be 600 microns in both the eyes. Gonioscopy revealed rudimentary iris stump with extensive synovial angle closure in both the eyes. Systemic examination of the patient was unremarkable. On further evaluation, the younger sibling was also found to have bilateral Aniridia with secondary glaucoma. Since intraocular pressure was uncontrolled on maximum medical therapy and the patient being monoocular, we decided to proceed with an Orolab aqueous drainage implant surgery. A fornix-based conjunctival flap was raised in the superior-temporal quadrant of the left eye. The episcleral plate of the RD implant was then placed beneath the lateral rectus and the superior rectus muscle. The episcleral plate was then sutured to the sclera using a 9-0 nylon suture on both the sides, ensuring that the knot is properly buried beneath the plate. A box suture using a 9-0 nylon was then placed to stabilize the tube. The tube was then ligated using 260 vicryl sutures proximal to the end plate. Occlusion was then confirmed with the 27 gauge cannula. The tube was then cut in a bevel fashion, keeping a length of 2 mm from the limbus. The scleral bed was then cauterized. A 23 gauge needle track entry was then placed at an incision which was 4 mm from the limbus and 2 mm lateral to the tube. The anterior chamber was then entered with the 26 gauge needle. The tube was then inserted through the scleral track into the anterior chamber, ensuring that the tube is placed over the periphery, over the lens zonule, so as to avoid injury to the lens capsule. The conjunctiva is then sutured with a 6-0 Vicryl suture. Ocular hypotony was noted at 1 month follow-up visit due to autolysis of the ligature and was managed conservatively with cycloplegics and steroid eye drops. The intraocular pressure was found to be 14 mm of mercury at the 2nd month post-operative visit. The IOP was then maintained in low to mid-teens till the last follow-up visit on topical monotherapy. Aniridia is a rare hereditary bilateral congenital anomaly characterized by profound hypoplasia of the iris, frequently associated with ocular anomalies such as corneal pannus, keratopathy, cataract, ectopia lentis, and foveal hypoplasia. It is inherited in an autosomal dominant fashion in 2/3 of cases, or in a sporadic manner in 1/3 of the cases, and associated with a mutation in the PAX6 gene on chromosome 11. About 20% of patients with sporadic form of aniridia have been found to have Wilms tumor. The incidence of glaucoma in Aniridia ranges from 6 to 75%. It is uncommon in infants and newborns and typically presents in late childhood or early adulthood. In patients presenting with infantile glaucoma in Aniridia, the mechanism of glaucoma is usually due to cleavage abnormalities of the anterior chamber angle or dysgenesis of the Slem's canal, whereas patients presenting with early adulthood, the glaucoma usually occurs due to progressive opposition of the stump of the iris to the trabecular meshwork. The severity of glaucoma in these cases is related to the extent of synechial angle closure due to the residual iris stump. Rarely, secondary angle closure from ectopia lentis, intermittent lens, or following surgery for cataracts or glaucoma has also been reported in these cases. The treatment of aniridic glaucoma consists of medical therapy, laser treatment, and surgery. The initial treatment is usually with medical therapy directed towards control of intraocular pressure, consisting of aqueous suppressants and miotics. Organ laser trabeculoplasty has been found to be ineffective when performed in these eyes with open angles. Eventually, a majority of patients with aniridia will require surgical intervention for uncontrolled glaucoma. There are several options available in the surgical armamentarium for the management of aniridic glaucoma, but goniotomy is usually indicated in young children without glaucoma, but having extensive synechial iris extensions across the scleral spur or showing evidence of worsening of angle abnormality on gonioscopy. Chen and Walton reported a success rate of 89% following prophylactic goniotomy in 55 eyes over a follow-up period of 9 years. In infantile aniridic glaucoma, trabeculectomy is the procedure of choice. So previous studies have reported a surgical success of 83% in 10 out of 12 eyes over a mean follow-up period of 9.5 years after 1 or 2 trabeculectomy procedures. However, in young adults, these results are not promising. Trabeculectomy with mitomycin C is usually performed in eyes which is refractory to medical treatment. Nelson et al. Reported successful outcomes after trabeculectomy in 11 of 14 eyes at 1 year follow-up period. However, Wiggins and Tommy reported a surgical success rate of only 7% after trabeculectomy and a need for additional surgery, especially in young patients or Uveitic patients. Glaucoma drainage devices have been shown to be effective for aniridic glaucoma. Previous studies have reported a success rate ranging from 83% to 88% at 1 year follow-up period. I would like to share the results of a recent publication from our team at Arvind comparing the outcomes of RD implantation and trabeculectomy with mitomycin C in patients with glaucoma along with seen in aniridia. So ours was a retrospective case series comprising of 30 eyes in 30 patients. In our study, the surgical failure was defined as an intraocular pressure of more than 21 mm of mercury or reduced less than 20% from baseline, or an IOP less than or equal to 5 mm of mercury at 2 consecutive visits after 3 months following surgery, or those requiring reoperation for glaucoma or presenting with a complication or presenting with the loss of perception of vision, light perception following surgery. So in our study, 12 patients underwent trabeculectomy with mitomycin C and 18 patients underwent RD implant surgery. Our study reported a cumulative probability failure rate of 58% in the trabeculectomy group and 11% of failure in the RD group, and a success rate of 42% in the trabeculectomy group and a success rate of 89% in the RD group. The mean intraocular pressure at 2 years follow-up was found to be significantly lower in the RD group compared to the trabeculectomy group. There was no significant difference in the complications between the two groups. However, a significant number of re-operations was observed in the trabeculectomy group, with patients requiring 5 re-operations for glaucoma and 5 for cataract, whereas no re-operations was observed in the RD group. So our study concluded that a placement of an RD resulted in lower intraocular pressure and a higher rate of surgical success compared to trabeculectomy with mitomycin C in eyes with glaucoma associated with aniridia, and cataract extraction was more frequently required after trabeculectomy with mitomycin C than with RD implantation. Cyclodestructive procedures are performed only in cases refractory to medical and surgical therapy, and it is usually not recommended as a primary intervention due to higher rate of complications such as cataract or thisis bulbi. Wiggins and Tommy reported a success rate of 120% after cyclocryotherapy.
Your presentation.
Hello?
Will you please sum up?
Yes, ma'am. So last slide. So to summarize, glaucoma and aniridia is difficult to control both medically and surgically. Routine gonioscopy is critical to guide appropriate prophylactic or therapeutic intervention. Gonios surgery, either trabeculectomy or goniotomy, may benefit young aniridic patients with glaucoma who exhibit open angles. In general, GDD may be more successful than gonios surgery, glaucoma filtration surgery, and aniridic glaucoma. Cyclodestructive procedures are usually reserved for refractory cases, given the high rate of complication. And the best approach may be to prevent or delay aniridic glaucoma by prophylactic goniotomy in eyes that demonstrate progressive anatomical changes in the drainage angle. Thank you.
Thank you for that elaborative lecture. Now I invite Dr. Shushmita. She doesn't need any introduction. She's going to talk on congenital glaucoma. It is her passion, I believe.
Are my slides visible? I think you'll have to. They are? Okay.
But it's not full screen.
Yeah, I will. Okay, is that better now?
Yes.
Yeah.
Good morning, everybody. Thank you, Manish, and thank you, BOA, for the opportunity. So yes, as Dr. Mayuri said, these babies would be anybody's passion once we start working with them. I've taken informed consent from all parents to share their pictures freely for academic purposes. So what we look at today is one surgery is done. I presume congenital glaucoma would have undergone surgery. So one surgery is done, what next? When to call back, what to look for, how to evaluate them. Do you do UA? Is sedation enough? What are disease progressors despite so-called controlled intraocular pressure? Now that's another problem in children. How do you look at cornea? How do you look at axial length? And even if disease stabilizes beyond the IOP, I can't emphasize enough on how much we need to look at vision, and vision. So the first question is, when is the eye patch opened? Among the things that COVID has taught us, one is to do bilateral surgery and do it a little more fearlessly than we did it before, simply because we know we're going to reduce the admissions, reduce the travel, and it's worked out very well. So for instance, this baby with garden variety infantile glaucoma, and when we do bilateral surgery, the child, by the time it gets out of GA, is so annoyed at the world. So we just take out the patch in maybe 4 hours after that when they're accepting orally. And to our surprise, when we started doing that, most of them have actually cleared as early as 3 to 4 hours after surgery. And the children actually are less photophobic and they have less blepharospasm and they seem to be quite all right. And whether there is hyphema, whether there is inflammation and all that will direct the next steps. But usually it's a combination of steroids and antibiotics for the next 3 to 4 weeks. And then what next? So we've learned that the most important thing to look for is the child's comfort. So if you have an irritable kid like this who came to you and 6 weeks later wants to sit on the slit lamp and show herself, you know that that probably the kid is better. And the mother's feedback is important. The first thing to ask the mother is, what do you think? What is your child like now? Of course, corneal clarity, intraocular pressure if possible, now that the eye care is available. But something that we really, really have found useful is the axial length. So the cornea and the axial length are actually surrogates for the intraocular pressure. I know the eye care has been touted as the greatest thing to have come in, but it's important to understand that Goldmann applanation tonometry in awake children is the most accurate method. Whether you can do it or not is another matter, but that is the most accurate method for intraocular pressure assessment, even in children. Rebound tonometry does overestimate the intraocular pressure, and this overestimation increases with increasing CCT as well as increasing IOP. So the higher the IOP, the more chance that the rebound is going to overestimate it even more. Now, sometimes intraocular pressure might be normal because these are elastic eyes. And if the eye is going to expand under a raised pressure, you're not going to be able to measure it. So for instance, this preterm baby with ROP who undergone both eyes LIO and then LSV, and 4 weeks later actually came with this large cornea. So the IOP remained okay when we put her on medical treatment, just holding on to what is the next best thing to do, because we were so scared that the retina might detach if the pressure went too low. And yet the axial length kept increasing beyond. So what we use is the Sampaulosis graph, which is a graph of the normal growth of the eye up till about 5 years of age, because we know that the normal eye is going to grow as well. So the change is important, but it's very difficult to assess in the clinic whether this change is part of the normal growth of the baby or is it more than that. So this is a routine. This is from a clinic file. And finally, we did do a CTT, waited at least about 6 weeks to do the CTT because we wanted the retina to be settled. And after that, you can see the axial length growth has actually plateaued and is parallel to the normal. So the axial length is something that we've started using very often. Similarly, this baby, you can see the red is the right and the blue is the left. So it started off beyond the normal, and then they actually do come down. And then with the growth of the eye, it is exactly parallel to what you expect it to be. So now, even if everything is fine, so at this stage, something that we are really concerned about is sutures, because we don't really look at them so much, these children, but then everything was fine, the cornea is clear, the pressure is fine, the axial length is fine. But then if you have a suture which is accumulating mucus, that's another pointer to take for an EUA, because it can be very, very dangerous. So the follow-up examination would be about 6 to 8 weeks after surgery. Usually, if any intervention is planned, you have to schedule your examinations. And if the examination is satisfactory, the subsequent ones, we do it only about 4 monthly in the first year and then 6 monthly thereafter. So what do we look for? We compare with the pre-op status, of course, intraocular pressure, but corneal clarity, corneal diameters, sutures, if you've done a trabeculectomy, the bleb, if you've done a tube, the tube position, because remember, they have a tendency to go towards the cornea. The disc status and retina every time, that's something that is often overlooked, and the axial length. We compare with the pre-op status, of course, intraocular pressure, but somebody is recording this. So anyway, so the bleb, if you've done a tube, the tube position, because remember, they have a tendency to go towards the cornea. Manish, is status and retina every time. That is often overlooked. I can hear you. Can you all hear? Compare with the pre-op status, of course, intraocular pressure.
Yeah, I think it's
Is it being recorded? I mean, Manjula, can you stop the live recording or whatever?
I'm checking, doctor.
Please. You're the oldest.
I face the same problem.
Okay. So sometimes we even have to do a secondary intervention.
We can't hear.
Sorry? Is it being recorded? I mean,
yes,
Manjula,
it is being recorded.
Live recording, but I can hear the echo again.
Hello?
Hello? Is that okay, or should I carry on?
Yes, carry on.
Yeah, okay.
You can carry on.
So sometimes there is a secondary goniotomy, and this is a combined trab with trab, and you see the cornea is not as good as you would expect it to be, though it's better. We did the OI in the left eye, And then because the cornea kept getting hazy, so sometimes the IOP could be all right because there's persistent corneal edema and your intraocular pressure is falsely low recorded. So look at other things. The point is that in children, intraocular pressure cannot direct your further management. So for this baby, even though the pressure was fine, the corneal haze made us intervene, and then a secondary goniotomy, which means we just do a goniotomy of the nasal angle, and then this cornea cleared. So you need to recognize the risks of repeated general anesthesia. We've published this on dexmedetomidine, and it actually came about because we simply didn't have enough GA time to do our EUAs. And I can share with you a short clip, and this is what is usually done. So they're in the preoperative room, the child is fasting, the anesthetists monitor, but at least GA is not given. And this is the atomizer with which it's just given intranasally. And once we have that, I acknowledge my senior resident, Dr. Deepika, for making this video for me. So it takes about 2 minutes, and the child is then nicely sedated in the mother's lap, being monitored both by SpO2 as well as the ECG monitoring. And the entire EUA can be done without general anesthesia in the preoperative room while I can carry on with doing surgeries of the babies that I have to. So this has worked out very well for us. And it's a caveat that you can use sedation as well. So after successful surgery, the intraocular pressure okay. This is acute eye drops. You see the cornea is completely cleared. He's 4 years old now. Is your job done? So the question is, beyond the IOP, retinoscopy, spectacle prescription, visual acuity assessment, visual access assessment, amblyopia, visual fields later. We can't get rid of all this. There's so much beyond the intraocular pressure. You have a residual scar like this, probably requires an OI. You have Peters in one eye, PCG in the other. Your UBM tells you that this is going to be a very, very difficult thing to do. So you might as well just do an OI for this. This girl now goes to school and is 618 with just this OI, while the cornea guys are wondering whether to tackle this other eye or not. Unilateral ophthalmos have other problems. They have very, very high myopia. Their contact lenses just fall off on their cheeks. So I acknowledge Kulbhushan, our optom, who's made this and said, Madam, I can't fit a contact lens on your ophthalmos babies with blebs. So this boy was actually minus 22 in one eye by the time we got to him, and we did a refractive lens exchange, much as I hate admitting that, but he actually had a -4 diopter lens in this eye, which actually has treated the amblyopia very well, but my fingers are crossed for future retinal detachments and God forbid anything else. So to summarize, childhood glaucoma is a lifelong disease as all others, except that the lives of these children are so much more. And they can manifest in myriad forms. There are multiple etiologies which we need to talk about. So much is unknown, but at the end of the day, ensuring vision is our goal and not IOP control. But remember, we need to hold these children's hands with us for a long, long time to come. Thank you for having me. And I acknowledge all the residents and senior residents who help put this together. Thank you.
Sushmita. The next is Dr. Rajul Bhai. He is going to talk on how to fix up the most difficult aspect of the management of glaucoma, that is adherence.
Good afternoon, everyone. My voice clear?
Yes.
Audible? So thanks BO, MOS, Manish Bhai, Nane sir and Ragini madam. I will be talking about the adherence issue in medical management. Now, we know that glaucoma is a big issue. I'm not going to talk about epidemiology. We know that the awareness of glaucoma is poor in India. And because of that, we get lots of patients in the moderate and advanced stage. And though glaucoma does not cause the high mortality, it causes severe hampering in the quality of life, not only the physical activity, also in the psychological aspect. So glaucoma is dangerous, and we have to take care properly. Now, when we talk about medical management, along with all the criteria, one of the things we talk about that the drug, the dosage should be such that it should be the patient compliant. So when we talk about the compliance, there are two issues which comes in picture. One is adherence and one is persistency. So I just define them. That adherence means the degree to which the patient follows the treatment instruction during the finite period of the time, and persistency means the time until which the patient first discontinue use of medication. And we must remember that both are not the same thing. The patient can be persistent and can be poorly adherent to the medication. So maybe he's putting drops like every day, but the time can vary, and that is a poor adherence. So like, for example, we have given prostaglandin once a day at night time. If he is putting one day 10 p.m., other day 6 p.m., other day next day early morning 5 p.m., he's putting the drops. But the adherence is very poor, and that also is a problem with, as far as the management is concerned. Now both, and if you look the Indian data, the nearly 75% of the patient fail to attend to the at least one follow-up visit. This is, I have taken data, I have given the publication below. Only 10% continuously refill their prescription over a period of 1 year. 50% patients stop taking medication within 6 months. So the adherence and persistency both are poor as far as the medical management is concerned. And this is not only India, this problem is universal. Now what happens that if the patient is poorly adherent or poorly compliant, what happens that the IOP control would not be great, which would lead to the high complication, and in glaucoma basically a poor outcome in terms of the blindness. So the adherence is a big issue. We have to look in carefully in every patient. Just because patients say that I'm putting drops properly doesn't mean that he's adherent to the medication. And this is the data, more or less, if you look across the world, the common cause of the poor adherence remains more or less same. The difficulty in drop administration, the number of drops, if the scheduling is a big issue, poor knowledge, and the beliefs. Now belief can vary according to the region, but the poor knowledge, wrong beliefs, and along with the difficult schedule, the difficulty in administration, the side effects. These are the common cause of the poor adherence of the medications. Now, what we can do to improve, the first, I have not written here, but the most important thing is the chair time. You give proper time to the patient, explain the patients in every visit, that is very important. Along with that, reduction in number of medication, fixed molecule over the unfixed molecules, then less preservative. So if you can give preservative free, which comes in the cost which patient can afford, then perfect. Otherwise, the fixed molecule will have a less preservative exposure to the patient because the number of bottle would reduce. And the fourth, you choose the molecule which is close to the neutral pH, so patient doesn't have side effect. As far as the drops going in the acidic, away from the neutral pH, the side effect increases in terms of the burning, irritation, and all this eventually leads to the ocular surface disorder and poor adherence. So the comfort of drops is very important, and which leads to because patients should not have any side effects of putting drops. Anyway, patient is having problem of his disease, and you don't want to give extra problem. So the drop should be such that it doesn't cause side effects or discomfort to the patients, because the discomfort would increase to the poor adherence. Now, second issue, we must remember that even in ocular hypertension, old study, at the end of 45 years, 40% patient required more than one medication. And collaborative initial glaucoma treatment study, which was based on the target IOP, which we follow in clinical practice, more than 75% of the patients required more than 2 molecules within 2 years. So the high number of molecules is a norm in day-to-day practice. What happens that when you give multiple drops, the adherence reduces. So if you look at the data, at only one drop, the adherence is 81%, reduces to 50% when you give 4 molecules. So that is the one big aspect we have to remember in clinical practice. Now, other way around, this study what they did, they shifted from the unfixed to the fixed combination. And what happened, that unfixed, the adherence was only 60%, which increased to 80% when we went to the fixed molecules. So the fixed molecule, because the number of drops, the reminder they have to keep for themselves is less, the adherence improves. Also, second thing we must remember that when the number of drops,
Rajul, we will have to wrap up a bit earlier.
But you have to give me at least 1-2 minutes, Manish.
Yeah.
I will finish on time. Don't worry about it. So we have
1 minute. 1 minute.
We have, ma'am, please. Everybody took so much of time. You give me enough time. We have combinations which is beta blocker and non-beta blocker. In day-to-day practice, the beta blocker combination is most commonly used. Now, when we talk about the combination, we have to remember three issues: efficacy, adherence, and tolerability. Now, I will give some data of the fixed combination of the brinzolamide timolol, which the brand molecules, which is recently launched. Now, they had lots of publications. I'm not going to talk about it, but when they compare with the isolated molecule of brinzolamide timolol, the fixed combination had a much better IOP reduction of at least 2 to 3 millimeter. When they compared along with the equivalent dorzolamide timolol, because that is the older molecule, and we must compare the older molecule, and they found that IOP reduction was same. So the non-inferiority, so that means both molecules are same. Now, when both molecular efficacy is same, the newer molecule has to be better than the older molecule in some way. The only benefit was that the brinzolamide timolol combination, the ocular side effect was significantly less, and there is various publications. This was a crossover study to see the objective was looking the side effects, and they found that majority of the patient, 80%, were preferred the brinzolamide combination because of the less side effect. So in general, took the same thing. So to conclude, we know that glaucoma is irreversibly blinding disease. We know that poor adherence is a big issue as far as the glaucoma management is concerned. Adherence is we have to deal with it in making the patient more adherent. There is no science. It is more of a logic and common sense. We have to deal with the individual patient in a different way. The fixed combination is beneficial because it reduces the number of drops. It is much better for the patients. And when we are giving the fixed combination, we have to give the drop which causes the less side effects and has a better tolerability. These are the main points when we deal with the medical management of glaucoma. Thank you.
Thank you, Rajul. And I think we'll have to wrap up quickly because we are already behind time. I would like to pass Dr. Sushil to give his talk on SLT.
Hello, everybody. Is my screen visible?
Dr. Sushil?
Yes, sir. Is my screen visible, sir?
No, no. Share your screen.
Okay. Now?
Yes.
Okay. Can I proceed?
Yes.
Okay, so I'll try and make it concise. I'm going to speak on SLT in glaucoma. At the offset, I would like to thank BOA, Dr. Lahane sir, Ragini madam, Manisha sir for this opportunity. We are already covered with the persistence and the adherence issue. That makes my job a little simpler. So this is my outline: why SLT, what is SLT, and how different is it. I have available literature evidence on it and points to ponder while performing SLT. So if we see the timeline, we have evolved over a century with just pilocarpine and later on timolol available to a gamut of 6 classes of anti-glaucoma medications. Out of those, still around majority of the drugs which are used now are the prostaglandins. And all these medications do come with potential side effects. The triple H side effect of prostaglandin is very commonly seen: the hyperemia, hypertrichosis, hypopigmentation. This is well covered by Dr. Rajul Parekh sir, and makes it easier to understand that only around 20% of the patient persist with anti-glaucoma medication at the end of 1 year. Surgeries also are quite often seen with long-term complications, and quite often they are dreadful with blebitis and bleb leaks. So if we see the surgical trends, we can see the surgeries have remained more or less stagnant in the lowermost yellow and the green chart. The light blue chart shows the ALT numbers decreasing, but from 2001-2002 year, that is the time when it was approved by American US FDA for use in treatment of primary glaucoma, the numbers of laser trabeculectomy have significantly kept increasing. So what exactly is SLT? It's a Q-switched frequency doubled NdR laser of 532 nanometer wavelength. It's a single pulse, 3 nanosecond pulse duration, has a broad 400 micron spot size. It's air cooled and it permits selective targeting of the pigmented trabecular network without causing structural or coagulative damage to the trabecular network. So if you see comparison of the parameters of SLT and ALT, energy is very, very minimal. It's around 0.6.
Continue, please continue. Dr. Deshmukh, please continue.
We can't hear him. Can somebody call and
He's
tell
got
him?
muted. Sushil, you are muted. Unmute, please. Technical team, please unmute Dr. Sushil.
Yes, Dr. Unmuted.
Hello?
Yeah, you were muted for some time. Now we can hear you.
I think someone else spoke and then it automatically went into unmute. Is my screen visible, ma'am?
No.
Yes, yes.
Yes. Yes.
Okay. So if we see the trends of SLT have increased consistently from 2001 onwards when it was US FDA approved. These are the parameters of SLT. It's a 532 nanometer QSH double frequency NdR laser with a 3 nanosecond pulse duration and 400 micron spot size. It's air cooled and this permits selective targeting of pigmented trabecular meshwork cell without causing any collateral damage to the trabecular meshwork. So if we compare ALT and SLT, the energy used is very, very minimal, around 0.6 to 1.4 millijoules, 6 millijoules per mm square of fluence, and exposure time is fixed at 3 nanoseconds. So this short pulse duration and low energy allows targeting only the pigment cells, causing less of a collateral damage. How does an SLT work? The cellular photoactivation causes the release of cytokines and interleukins. Cytokines then in turn activates the macrophages to cause cell trabecular meshwork debris to be cleared out. And the interleukins over a period of time act as a growth factors and cause tissue remodeling of the trabecular meshwork, giving us the long-term control of IOP. This vitality study slide shows us the minimal collateral damage caused by the selective laser trabeculoplasty. On the right side, we have the picture of the SLT vitality study showing most of the cells are stained green and indicating viable trabecular meshwork cells. This shows the coagulative necrosis in the left picture of the ALT, whereas non-coagulative changes in the SLT. So coming to the treatment protocol per se, we now usually cover 360 degrees in the initial setting itself, and we give around 100 adjacent spots non-overlapping fashion. Spot size is fixed at 400 microns and the duration is also fixed at 3 nanoseconds. We start with a power of say 0.6 millijoules in each quadrant, slowly titrating based upon the appearance of the cavitation bubble, or commonly called as the champagne bubble appearance. Energy is slightly reduced by 0.1 millijoules from this threshold and used to irradiate that particular quadrant. It can be increased or decreased depending upon the response. So this is a small clip showing the similar thing. The 400 nitron helium aiming beam is focused on the posterior trabecular meshwork. Try and avoid overriding it on the iris root, which could cause pus formation in the later period. Also, do not confuse pigmented Schwalbe's line for a pigmented trabecular meshwork. That would also give you suboptimal result. So this has to be titrated in each quadrant, and we proceed to all the 4 quadrants by rotating of the SLT Latina lens. The post-operative care, we observe the patient after 1 hour for IOP measurement and the slit lamp examination. If the IOP spike is more than 5 millimeters of mercury, then we give a stat 1 tablet of Diamox 250 milligrams. And post-laser medication, usually we don't give them any NSAIDs or steroids. If there is inflammation, AC reaction seen, then we can give topical ketorolac for 3 days, TID. And in very rare cases, if we have severe inflammation, then we can give topical dexamethasone only 3 times a day. Using steroids in the post-operative period could decrease the IOP reducing effect of the SLT. So indications are primary treatment of glaucoma, OHT, and mild to moderate POAGs could also be used in PXF glaucoma and PACG in post-PI or cataract surgery once you have an open angle. Financial constraint for medicine use, non-compliance, drug side effects like ocular surface diseases, drug allergies, and tachyphylaxis, and as an add-on to anti-glaucoma medications. We definitely tend to avoid in neovascular glaucoma, angle recession glaucomas. In normal tension or low tension glaucomas, the response is poor. And in secondary or inflammatory glaucomas, like post-keratoplasty or VIA surgery, you could have a suboptimal response. IOP spike is seen in around 10% of the patients and expect in hyperpigmented trabecular meshwork and in young patients. It could also mean that you are over-treating, so you need to titrate your energy to a lower level. And usually you need to have patients and the IOPs normalized with a few medications. So SLT has been advocated as the primary therapy. We can see if used as a primary therapy, the success was as high as 82% at the end of 5 years. As against to a secondary SLT, the success rate was only 30 to 40% at the end of 5 years. So this papers also justify the same. So they have concluded that IOP reduction was similar in primary therapy equivalent to a latanoprost group. These are some of the other studies which validate use of SLT in primary open angle glaucoma, especially in the early mild to moderate glaucomas. Advanced glaucomas, there were additional need for interventions in terms of the surgeries. If you go to the other group of subset of glaucomas like the PXF glaucomas, the success rates were moderate, but in normal tension and the low tension glaucomas, the success rate was hardly around 10 to 20%. Steroid glaucomas and silicone glaucomas showed a success rate of around 46 to 59%. So to summarize, SLT is effective as initial or a replacement and adjunctive therapy in open angle glaucoma and could be used in angle closure also post iridotomy or cataract surgery. It is useful in addressing compliance issues with medication. It is effective in flattening the diurnal IOP curve and decreasing the nocturnal IOP spike. It also decreases the cost and side effect of the medications for the patient. Lastly, tip to avoid disappointment could be to do not overpromise the patient. Primary treatment works best. Choose retreatment in patients who were responsive and treating 360 degrees at first sitting and avoid areas of synechiae or ostium for the SLT. Thank you again to the BOA and Manisha.
I think I'd like to thank all the speakers, and I think most of them kept to time except Rajul. And I didn't say thank you to BOA earlier because I only had 10 minutes time. So I'm thanking BOA now for allowing me to speak. And I think this was a very interesting session. Thank you all the speakers and thank you for the organizers.
Thank you all speakers, and thank you madam and all the chairman, co-chairman, moderators. And I think we have to end this session now. We are already over short time. Thank you.
Thank you.
Thank you. Thank you. Bye-bye.
Hello.
Yes, doctors.
Yeah, Dr. Abhijit, who's it?
I am Sai here from the technical team.
Yeah, I want to try to share my screen and see. I think somebody else is sharing right now. Hello.
So go ahead.
Can I share?
Please go ahead.
Okay.
Hi, Sachin.
Hello, sir. How are you?
I'm fine.
Nice to see you.
I'm not able to get that background.
Just a minute.
Hi, Manish. Hi, Sachin.
Hello, sir. Good afternoon.
Very good afternoon. Abhijit, how are you?
Hello, Dr.
Manish.
Pratik.
Manish, unmute.
Hello, good afternoon, Dr. Pratik.
Hi, Abhijit. Good afternoon. Jagdish, good afternoon.
This is Dr.
How are you?
Jagdish Shah.
Hello.
Screen is seen?
Yes, Sachin. Screen is seen.
Okay, fine.
You want me to share the screen and see?
Yeah.
Manish, you unmute, please.
Who all are there?
Visible now?
Yes, visible, sir. Latinoprostine B node is what we are seeing.
Yeah, that is the first slide.
Correct.
Okay.
I think everybody should be online in 3 minutes.
Okay. Hi, Manish. You are so quiet.
I'm wondering whether you can hear me now.
Yes,
I can
we
hear
can
you.
hear you
I
now.
can hear you.
Loud and clear.
Okay. Because I had to do some audio setting, then only I can hear me.
Manish, afternoon nap time.
अरे सब खराब कर दिया ना आफ्टरनून नैप क्या पूरे दिन को इधर बैठना पड़ेगा
एक दिन का ले ले यार.
अभिजीत you are where are you are not
Manish, one day is okay यार. Manish, एक दिवस चाले भाई.
ચાલે બધું ચાલે તમારો શું આ ન્યુ લુક શું છે what new look
it is called a lockdown look. It's a lockdown look છે ભાઈ. And then I have learned this, harmonica in 1 year.
Wow, that's great.
I wanted to learn one musical instrument. I learned in this 1 year. Of course, in between there was a lockdown had gone away, but my dream came true, This was a golden period to learn.
Oh.
Wow.
Okay.
Yeah, play some song, yes.
બધાની ઊંઘ ઉડાડી દીધી.
Very good. And you have tested your lungs as well. Lungs are functioning well. The lungs function
This
test.
is a gain. At the age of 65 to learn some musical instrument is an achievement.
But who says
This
you
was
are
my
65?
dream,
You color your hair and the beard, you will not look 65.
No, I'm going to change it. I'm going to change everything after I grow completely white. I want to have that. I want to have that picture, and then I remove everything, the beard, and then I make a color hair. I'll become 25 years younger.
Yes, like Abhijit.
And Manish, I'll give you a competition.
Wow.
Yes, Manish and Abhijit both.
I have done little work, and there are many topics which are overlapping than what happened in glaucoma 7, like maximum medical therapy.
Well,
very
the
nicely
speaker, I have communicated with the speaker about this thing, that this is overlapping, and both the speakers said that we are okay with it because we are talking different things. Dr. Vinay Agarwal told me, so that is why this is a, so same topic is there, I am aware, and I have made them also aware. Then they want to share something different, then let us hear them.
No, it should be really nice, because even MMT was wonderful talk was it. Even the that talk on how to handle the failing bleb, very nice depiction of videos also. Interesting about the how to go about the glaucomatous optic disc. Yeah, that also very OCT was very good. All the topics very well controlled, and within 8 minutes they really give a good justice. Very nice. Will be interesting to hear, Sachin, your case today. How you tackle the filtering bleb, leaking bleb rather.
How many attendees were there?
We don't know.
Don't know.
Only the do we come to know how many attending?
Yes.
I think in the YouTube person
going on two channels. You can directly log in, or you can go on to the YouTube. There are two ways to watch. So
on the YouTube, you can find out the number of people are logged in.
YouTube, I saw in our hall there were some 83 people in the hall, this same hall last session. But the direct login, I don't have the statistics. That these people can give the statistics. The technical team of this Urban Edge company who is organizing this platform.
That I know. I will tell you that they will give figure of 4,000. All the hall together.
We are living in a world of figures, and very little is told to us how the figures are derived.
Yes.
True.
It's all jugglery of figures and the fudging of figures. Whether it's a corona or a webinar. Do a webinar for a company and ask him that how many people logged in, he will say 1,000, 2,000, 3,000. Always it goes in multiple of 1,000.
So I have got very simple statistics to know what is going on. Depends on how many questions are coming in.
Yeah,
if you have 1,000 login, you should at least get 15-20 questions, at least.
Yeah, it's a good indicator, yes.
But questions now, I am tracking questions from all. Jagdish had raised a query where the questions are. I had also followed up. So I am tracking questions everywhere. People are saying good morning, good night, good talk, everything very nice, but nobody is asking questions.
No, I asked, so many questions in that session, Glaucoma 7. They didn't see, the faculty didn't even say. They said there are no questions. And then there is
a shortage of time. The question, even though I had seen one question on the YouTube chat, I put it on the chat in the platform, but then time short, and people are talking on the topic they want to talk. That question is not addressed. I don't know.
Yeah.
Dr. Devin is joining in half an hour. That is the update.
How the things are in Indore, Dr. Prateep?
It was very bad. Now it is little under control. Till a couple of days before, no beds were available. Neither HDU nor ICU nor a simple bed.
Yeah.
But slightly better, So we have come down from 120 corona deaths every day to somewhere around 30 to 35.
That's really nice to hear. Yeah.
Yeah. Slightly
Let's
better.
hope so we come out of it. Yeah.
Yeah, but still the number of positive cases reported are much more than you are reporting in Mumbai.
Yeah.
I think you have reported 1,500 yesterday.
That's right. Yeah. No, if you see, like I'm in an area which is full of life in the night time. There's total lockdown. I mean, you
Yeah,
can see
yeah,
after 7 p.m. I mean, in the area which is, throbbing with people around in the evening time, Lokhandwala area.
yeah.
You
Okay.
see total quiet down. Quiet down means unbelievable.
So this time the
Smashan
fear
jaisi
factor is
shanti
very
hai.
high. Hi, Dr.
Yeah.
Subhash.
Yeah, good afternoon, sir, and good afternoon,
Afternoon.
everyone.
How are you?
Fine, thank you. Fine, thank
How
you.
is Patna?
Patna, now the cases are actually coming down. About a week back, it was very terrible.
Nice to hear.
Yeah. Good. So your
You
practice has picked up.
No, sir. Right now, just got up after this managing committee meeting. अभी तुरंत खत्म हुई 1 मिनट पहले.
Okay.
AS का.
अच्छा है. AIU इसका.
That was regarding the conference also, 2022, 23 and all those.
Okay. So what decision have you taken?
Decision ultimately, it has been decided that till this virtual conference is held, it will be hosted by the headquarter, and then it will start from Mumbai, then we'll go to South, then it will come to Kolkata again, just because this year it could not be held in Kolkata, so that's why.
Oh. Okay.
So next year will be in Mumbai or not?
So
next year it will be in Mumbai, sir. But suppose by any chance the physical conference is not possible, then it will be hosted by the headquarters.
Okay.
But this has to go to the GBM again.
Year.
Is it right?
Sorry?
It has to go to the GBM again.
Yeah. It has
will
to
pass
be.
it.
These are just by managing.
That is a proposal
proposal.
by GCMC.
Yes.
There was a lot of preparation done at Calcutta for the conference, and suddenly everything is virtual.
Not much, sir. Actually, only venue was booked, and it started last year itself. No, the preparation, which generally more preparation is done in last 1 year, but for last 1 year it is already.
Good afternoon, sir.
Good afternoon, Manish. Good afternoon, Jagdish Saha. Good afternoon, Pradeep. Good afternoon, Sachin.
Good afternoon, sir.
So we attended CM's meeting.
First, ठीक है, sir, एकदम.
Yes. Acha, Abhijit is also there. Good afternoon, everybody.
Good afternoon, sir.
Subhash is also there.
Subhash, sir.
Welcome.
Thank you.
How are you, Subhash?
Fine, thank you, sir.
Chala, काळजी take care. Okay.
Manish, I couldn't get the background of our BOA. I tried to get the BOA background. I'm on an iPad. Somehow it's not coming,
Yeah, sometimes there's problem.
I got it, but Sumit has not done for me. He has done for himself. Pradeep, how are you?
All well, sir.
Everybody is well?
Yeah.
How is Indore?
Indore is improving, slightly better.
Okay, like Bombay is also increasing. Bombay is also the same.
Yeah.
It is coming down.
Yeah, it is coming down.
Yeah. So how was the meeting with the CM?
Meeting with the CM was very good. It was for near about 1 hour 45 minutes. We gave this was the targeted all the can say the practitioners all over Maharashtra was the target.
Right.
I think more than 14,000 people joined.
Oh,
yeah, I was there on the first half an hour. Yeah.
1 minute. Huh? So I think you continue this session.
On mute.
So you're muted. Huh?
Hello, everyone.
Hi, Rupali. Good afternoon.
Good afternoon.
Rupali, your background is a mirror image. You go to the setting and Rupali, you have to correct your background. It's a mirror image. No, you have to unmute. We can't hear.
Mirror image? Is it showing a mirror image?
Yeah, it's a mirror
Yeah, it is showing reverse.
Okay, I'll just check.
Okay.
Is this better?
Done.
Yeah,
correct.
Yeah, okay, fine. Just change it to mirror on my video. Fine.
Good. How is Medha?
Hi, I'm fine.
Hi, good afternoon.
Not able to, actually, I had done in the morning virtual background, but now it's pixelating. I'm all yellow. So I stopped that.
Madam, it's because the light is there behind, patchy light. That's
Yeah, it's all, I cannot find a dark background in my house anywhere.
So how is everything in Pune? Nitin is all right? Your daughter?
The
Huh?
numbers are now less actually.
Okay.
And things look, they are looking better. Like what it was like almost 6 weeks back, the numbers are like that now. Pune city numbers are very less. Main now this thing is from rural.
Okay. So you also have lots of patients of mucor?
I go to Bharati. So there I see last Wednesday there were 3 cases.
Okay.
So not in my clinic. My clinic, all those operated, they are coming. But we had seen mucor-like thing which we referred. Like few calls I got in at night also that something is wrong. My old patients who were like recovering from COVID. So we told them to go to an ENT person ASAP.
Pradeep sir, 2.5 minutes to go.
Yeah.
Okay, Pradeep, did you also see mucormycosis in your practice?
No, I'm not seeing, sir. But you know, I got a call from around 10-12 patients.
Okay.
I saw on a video consultation. I don't do video consultation, but yes, it was a complimentary. But yes, in Indore, there are lot many. Probably we might be having around 100 odd patients in Indore.
It's Bombay, people are seeing many.
Yeah, yesterday I was reading a statement of your health minister, and he says that there are total 2,000 cases in
270.
Maharashtra.
So many, it's too bad.
Yeah, 2,000 is a big number.
Now it is a notifiable disease now.
Yeah, it is a notifiable disease. Yeah,
So-
yesterday, yes, health ministry has announced it.
Sad situation. Somewhere in our relations in Surat,
Yes.
they had to both acceleration required. It's very bad. And then the treatment modality, treatment itself is so expensive. So it becomes very difficult.
Treatment is
for
very
them.
bad and it's so invasive. It spreads so fast.
It doesn't leave anything.
Yeah,
Doesn't
and
leave
antifungals
anything.
are not effective, and you are not getting also. Amphotericin B is not available.
But now the
It will become
false
like
calls are
remdesivir.
coming. You know, people are
Recently,
just for
I
something.
attended a
They give a call,
webinar
okay, doctor,
from
may I have
ENT
any
people.
problem like this?
So I saw the exenteration, how they do. Like they just preserve the optic nerve and the eyeball. Everything else was removed from the
Everything else. Yes, yes, periosteum and everything. Yes.
And you can see all those arteries, like thrombosed, black.
Yeah, actually, it's a disease of blood vessels, right? It goes along the blood vessels and causes necrosis.
They say osteomyelitis
Pradeep
also
sir.
sitting in. So
Pradeep sir, sorry to
Yeah.
interrupt. I think we should go. We are
Can we start now? Yeah.
live now. Yeah. I
Yes.
think you can take over, Chairman sir. Pradeep sir.
Good afternoon, sir. Good afternoon, Pradeep sir.
Good afternoon.
Sir, I'm Dr. Sarang Garade, President, Nashik Ophthalmic Association.
Good afternoon.
Yes, good afternoon, everybody. Sir, should we start?
Yeah.
Yeah. First of all, I thank BOA and MOS for giving me this job. I welcome panelists, speakers, our chairperson, Dr. Pradeep sir, co-chairman, Veda ma'am, coach Jagdish Shah sir, moderator and co-moderator. I think we should start the session. Today's first topic is by Sachin Dharwadkar sir. He's a director of glaucoma services at Aditya Jyot Eye Hospital and director of Samath Clinic, Andheri. He has published so many articles, but normally he has automated perimetry and OCT in glaucoma is a peculiar, and he authored some chapters in various books. He is a faculty at GSI, BOA, MOS, and AIOS, and he has given several presentations all over India. Now, his main area of focus is on modulation of wound healing in glaucoma surgery. With this, I hand over to Dr. Sachin sir. His topic is leaking trabeculectomy bleb.
Thank you so much, sir, for the kind introduction. I'll share my screen right now. Is the screen visible?
Yeah.
Yes.
Okay, thank you. So, I would at the outset thank our own BOA and MOS and Lane sir, Ragini madam, and Manish sir for the opportunity. In this short time, I would try to cover a few snippets about managing trabeculectomy blebs. The presentation is seen, right? So, as we know, we are living in challenging times. You can see these prototype patients that we get in end-stage glaucoma and moderate glaucoma with multiple medications, and maximum medical therapy and medicamentosa become the Achilles heel of glaucoma surgery. So, causes that predispose to bleb leak, we see in short, they are tissue remodeling post-exposure to aqueous, antimetabolite effects like mitomycin C and 5-fluorouracil, medication-related side effects and its effect on wound healing, and loose suturing, low suture memory, early elution due to friable conjunctiva, cut through, and small unnoticed buttonholes. So all these things have become more and more important in the backdrop of the two photographs that I showed you. And these have become progressively more severe and worse problems as time passes by. So we have to remember that any bleb can leak. Only the timing can differ. So you see the case on the left, it is a 15 years post-op where no MMC was used. Still it has become thin and leaking because of the effect of aqueous. Here is a limbus-based surgery where thinning of the overlying conjunctiva and ischemic bleb. And on the right side, one thing which you would think that would never leak is an ologen bleb, which has thinned out the superficial conjunctiva. So in all scenarios, you can have a leak and you have to be alert. Unpredictable dose response curve of mitomycin C doesn't help. Here you have both eyes fornix-based surgery, same age approximately of the patient, same technique, same MMC concentration. Here one eye you have almost loss of blood vessels on the surface, and here you have almost normal blood vessels on the surface. So anything can happen, and wound healing is a very, very strange thing. A lot is left to nature. So what are risks associated with the leaking bleb? These are very important for us to understand. In early bleb leaks, your main is the bleb failure, which we don't want at any cost, and infection, which is always there, like endophthalmitis, which can be very dangerous in the setting of trabeculectomy. In late bleb leaks, you have infection and fluctuating vision and maculopathy you can get. And management differs due to the presence of mature septae in old blebs with late leakage. They can be much more forgiving as far as the management is concerned. Now, aims of management of leaking bleb are: one is you need to stop the leak, and second is to prevent the loss of bleb function. Stoppage of the leak is mandatory because you want to prevent dangerous complication of endophthalmitis. Now, identification of bleb leak is very, very important. First of all, you have to anticipate, and then you have to localize. The symptoms are usually teary and wet eyes with intermittent blurred vision. You have to ask for these symptoms proactively when you take the history of patient in every post-operative visit. And otherwise, the patient will definitely tell you that the eyes appear more wet and you have an occasional tear flowing down the cheek. Now, the signs obviously are positivity of the Seedles test. You have to do a Seedles test at every follow-up visit and look, especially post-blink in eyes, especially with single-digit IOPs, because what happens, especially in fornix-based surgeries, is if there is a very slow leak, the IOP will be low. When you see it just like that by applying the fluorescein, you will not get any leak, but the moment the patient blinks, just after a blink, there will be a purge of aqueous from the leakage side. So it's very, very important for you to see after an active blink. And you can have low IOP with a sudden inter-visit lowering that should alert you, and Descemet fold, shallow AC, and maculopathy are the obvious signs that you'll find out. So locations that are prone for leakage are apex of thin and blebs, cystic vascular areas, which are the most elevated areas usually. Areas that are most predisposed to friction of the lids and drying. and junction of vascular and avascular areas as pointed out on the photographs that are attached. Now let us see a few cases in point. This is the first case. It's a patient presented with a watery eye 5 years post trabeculectomy with expression elsewhere. CDLs was slow. Now this is very important. Slow CDLs is usually very forgiving, and which was present on blink. IOP was 8 and best corrected visual acuity was 6/9. So all factors were in favor of us doing a conservative management. Now what was important was at the most elevated part of the lesion there was a filament-like structure which was moving like a viper, and the base of which there was CDLs positivity. So here you know that during the friction of the lid something is moving and dislodging a certain structure causing a leak. So what I did was excise the tag, gave him the traditional aqueous suppression, topical antibiotics for 2 weeks, and we achieved a complete healing of the leak in 1 week. It holds well for 2 years till date. So just aggressively going in and managing by excising the bleb and all is reserved only for very few cases in where there is diffuse leakage or the leak is too big and brisk. So most slow, the tip is that most slow leaks heal well and conservatively, and look at the leakage side for treatable changes. Now, this is the second case. You have intraoperative leak with multiple buttonholes, not very often setting of an old patient with thin conjunctiva and multiple medications. So management depends on the location. Bursting sutures, although recommended, no longer are good enough because they will itself produce buttonholes. In such cases, it's easier to manage with fornix-based flaps and but more issues with thin tenons and limbus-based surgery because sometimes the entire wound can cut through. So in this, the entire posterior suture line had cut through. So what I had to do, in fact, I had an AMG with me. So I did an interrupted suture closure of the limbal incision, and then I rather the limbus-based flap, and then I put an AMG. So this is a picture after 4 weeks, and then when the AMG peeled off, by that time defect had healed, and the patient is doing well till today, almost for around 5 to 5.5 years with a very, very thin bleb, but there is no CDLs positivity. So the tip is, in any cases where you're dealing with thin conjunctiva, very old patient with long history of medicines, keep 10090 Vicryl on atraumatic needle at hand. BCL is always the invaluable backup. If you have something like amniotic membrane, it will be very, very helpful. Now, this is early post-operative bleb leak. Presentation with ischemic change on day 14. You can see the ischemic change in the bleb here. Suddenly it appears out of nowhere. Initially you have a nice bleb and suddenly ischemia starts appearing. Now this is the anomalous behavior of mitomycin C. So IOP was 4, there was shallow AC and no iridocorneal touch, but the flow was brisk. Conservative management with pressure patch aqueous suppression was tried. It failed. BCL improved the condition for 5 days, deepened the AC, but the CDLs persisted on the removal of the bandage contact lens, and you can see that the ischemic area just increased and the sutures just went on melting progressively very fast. So then we did a conjunctival-free autograft with T-cell glue with large diameter bandage contact lens for 12 days, continued the patient on oral doxycycline, tapered the local steroids, and by the end of around 3 weeks, we got a nice healthy bleb which was functional. And although the graft had sloughed off, but the glue and the substantia propria did some magic, and we got a good seal and a nice diffuse posterior bleb. Now this is fourth case where you have a conjunctival melt. Here also a graft was tried, but in this case the graft did not work, it just melted away. So then what we did was around 6 months after the primary surgery. So we did conjunctival relaxing incisions posteriorly, undermined the conjunctiva, and then pulled it and sutured it at the limbus. This is the suturing at the limbus, and this is the undermining at the release incision at the posterior conjunctiva, which was around 90 to 120 degrees. In such cases, though, when you're doing revision of such cases after a period of 4 to 6 months, always advisable to have occlusion and scleral patch on standby for that kind of bleb repairs. In the other scenarios, you may need to do bleb excisions, scleral patch grafts, and conjunctival advancements, but be prepared for a concomitant second procedure and talk to the patient about the same. Fistula closure with ceton at an adjacent site may be a reality, so it's very important to discuss with the patient about a need of second surgery in the same setting. Mucous membrane grafts instead of AMG are usually tougher and better, and they also can be used if you have the capability to do so. So all the above methods, though effective, can run the risk of bleb failure, that is filtration failure or tenon cyst formation because of inflammation. So the best is prevention for the bleb leak. So this is my last slide. Yeah, okay. Identification of predisposed eyes, restricted use of anti-metabolite in thin conjunctiva or absent tenons, occlusion and tubes can be better used. Stoppage of anti-glaucoma medications with minimal usage in the pre-op period if controlled with Diamox is satisfactory and without side effects. Use of round body needles for conjunctival suturing. Ensure tight scleral flap in the immediate post-operative period, especially in fornix-based surgery, and titrate the increase in flow so that the wounds don't get pressurized. Prevent intra-op desiccation of the conjunctiva. Use collagenollytic medications like doxycycline in the post-op period preemptively in predisposed eyes, and do meticulous observation of bleb-related changes for early signs of thinning. Thank you for your patient hearing.
Thank you, sir. Nice presentation. Our next speaker, Tagre sir. Yes, sir. Dr. Abhijit Tagre, he did his graduation and post-graduation from VM Medical College, Solapur. After that, he was a lecturer in Cataract and Lions Eye Hospital, Miraj. He did his fellowship in glaucoma and general ophthalmology at Arvind Eye Care System and Moorfield Eye Hospital, London. So he published 13 scientific papers in various journals. He delivered talks as a faculty at various national, regional, and state conferences. Now he is associated with the drug trials in India. He awarded the best scientific presentation, the conference held at Aurangabad. His topic is raised IOP after Ahmed ball implant. Over to Abhijit sir.
Abhijit, you are unmute. Please unmute.
Hello.
Yeah.
Yes, sound 80. Yes, sir. Okay. I will give you a line. Okay, sir. Yeah. Yes, sir. Yes. Okay. Thank you. Okay. Yes. Yeah. Okay.
Oh, Abhijit, we can't hear you.
Oh, Tagare sir?
Yes.
Hello.
Hello. Yes.
Abhijit sir, we can't hear you. You can start.
No. No, Sachin, I can't hear him.
I also can't hear him. Can we just, who's next in line? Just a minute. Can we start?
Next is Meda.
Meda madam, can you start? We can have Abhijit sir later on once.
Maximum medical therapy practical approach. Rupali is the next speaker.
Dr. Rupali.
Dr. Rupali?
I can start if you want.
Yeah, Meda madam, start.
Meda's topic is glaucoma optic disc.
No, I've got mine on share now.
Yeah, madam, share.
Okay, fine.
Acha, no, Rupali madam has started. Yeah, fine, no problem. Darade sir, you can introduce Rupali madam. She'll start.
Okay. Dr. Rupali ma'am, she's a glaucoma consultant at Dinanath Mangeshkar Hospital. She did her DNB and glaucoma fellowship from SNFRCS Edinburgh. She has a special interest in angle closure glaucoma and role of lens in its pathology and non-myopic adjacent glaucoma. Her topic is maximal medical therapy, practical approach. May I go to Rupali ma'am? Please start the session.
Thank you, BOA, for the invite to join in this glaucoma session. I'm going to be talking about a practical approach to maximum medical therapy.
Madam, you have to unmute yourself.
I am unmuted. Hello?
Yeah, you are audible. No problem.
Audible, right?
Yeah, we request everybody else to mute their mics, please.
Yeah. Am I audible?
You are audible.
Yeah.
Yes, you're audible.
Yeah, the goal of glaucoma therapy is to maintain the vision-related quality of life throughout the patient's lifetime. So, achieving a consistent target IOP is the main way to achieve this, but it is not synonymous.
Others, can you please mute your speakers?
What is maximum medical therapy? So usually it will include only topical therapy because it is very difficult in the long term to have oral anti-glaucoma medication. It is traditionally defined as the use of 3 or more different classes of anti-glaucoma agents to achieve the maximum possible therapeutic outcome while minimizing the adverse effects and compliance challenges to the patient. So each of these are equally important. It is important to remember that every medicine that you add produces reduced gains. It is definitely not additive and certainly not more than additive. In real life, 2 to 3 drops is the limit for effective adherent treatment. When we add medicines, escalating therapy to achieve the target IOP, it is often seen that the risk of side effects increases and the potential benefit to the patient decreases. So it's always important to keep it in mind. When deciding about adding medicines or deciding how much is maximal for that particular patient, it is important to remember it is customized for patient. Type of glaucoma, stage of disease at diagnosis, and the starting IOP are 3 factors which will decide how much is maximal for that patient. In patients with angle closure glaucoma with advanced disease and a low starting IOP, you are more likely to move to a surgical management earlier rather than adding 3, 4, 5 drops. While in an early disease, but is early in disease and is open angle, you might be willing to try with 3 or even 4 drops at a time. Associated comorbidities, economic status, rate of progression of disease, and how likely is the patient to notice his vision loss during the course of his lifetime are other factors which are going to decide how maximal our maximal therapy is going to be. It is important to not get fixated on the concept of target IOP. So while target IOP is a good guideline for us to manage, it should be revisited episodically during the course of the disease to decide whether what we had initially judged or guesstimated is the correct one, or do we need to move it up or down. To try and rigidly adhere to the target level can do more harm potentially than good in many circumstances. Every time you're going to add a drop, ask yourself, is the expected benefit greater than the potential risk in the final goal of maintaining vision and preventing progression? So some guidelines: every medicine you add, there is going to be diminishing returns. And while the first medicine, especially if it's a prostaglandin, would have probably given you 5 or 6 millimeters of lowering, every added medicine is going to give you 2-3 millimeters at most. There are about 10 to 12% non-responders. And therefore, whenever you're adding medicine or switching medicine, keep that in mind. There is a variability in response of each patient to the medication, especially the IOP lowering by inflow drugs. And therefore, you have to give it adequate time. Don't add a drop, recheck after 1 week or 2 weeks, say not effective, switch or add more. Also keep in mind tachyphylaxis. So if a patient was adequately controlled for a while on a medication, and now the control seems to be going, rather than assuming that it is because the patient is progressing because the effectiveness is lowered, it might be that one of the drops has actually stopped working, and to try and isolate that drug and switch it. Anytime you make a change, whether it is adding or removing, give it at least a month from the time of change before taking any further decisions. When you select a medicine and you add, to start and add, that can also affect the amount of drugs that you include in MTMT. So for various reasons mentioned on the slide, wherever it is not contraindicated, a prostaglandin analog is a preferred first agent, gives you the maximum lowering in a single drop with 24-hour control and best profile of systemic safety. If that is working but not adequate, then you might consider adding medication. It is difficult to get more than 2 to 3 millimeters of mercury lowering when you add any other medication to the prostaglandin. And whenever you're selecting which drug to add, consider the type of disease and why you think that the patient is progressing on whatever IOP has been achieved. For patients with moderate to advanced glaucoma who are progressing and are already receiving 2 or 3 medications, it might be worthwhile to take a non-medical approach, either surgery or as a terrorizing measure, a top-up with laser. I'll give you a few examples. So if you take this 78-year-old gentleman who has no systemic illness, has a low risk profile, he was diagnosed glaucoma elsewhere on a routine examination 3 years earlier and had been started on a beta blocker. Patient seemed to be fairly compliant. His IOP recorded in his notes was as mentioned, and his target IOP also mentioned in the notes was 18 or less. His current IOP was 20 and varied between 18 and 21, 22. However, on the 3 successive fields done since, there was no progression of the disease, while the OCT showed a minimum progression. Now, if you consider that he's 78, otherwise healthy and compliant, with stable fields, you can actually continue to maintain with the similar therapy instead of trying to go for his 18 by adding medicines. If despite this, the OCT continues to progress, you might consider switching to a prostaglandin analog, which will give you a better lowering. And if in spite of that, there is further progression, then add a second medicine.
Madam, 1 minute to go.
For the second case, it's a young patient who has a lot of risk contributory factors, a starting IOP which is relatively lower, and his intraocular pressure on a single medicine is not as well controlled in the worse eye, that is 18 in the left eye, which is the worse eye. He's obviously progressing, and at this, it could be either because there is a daytime fluctuation or could be because of some other factors. Once you've ruled those out, it might be worthwhile adding a medicine for his left eye. And here you would consider choosing a CAI or a carbonic anhydrase inhibitor instead of a beta blocker, because his oral beta blocker will not give you additional advantage topically. And he's probably having nighttime peaks where the beta blocker is going to have almost no effect, while the carbonic anhydrase will have whatever effect at night also. And therefore that additional 1 or 2 millimeters which you might get might be the advantage that he needs at this point. In the final case,
can we have concluding remarks? We are already short of time.
So choose drugs to start and add depending on the expected benefit. Consider switching before adding where possible, and where the disease is advanced or rapidly progressing with more than 3 drugs, it is better to consider earlier surgery. Don't lose main objective sight, that is quality of vision and visual field, and therefore tailor your medical therapy to that. Don't stick to 5, 6 or 7 medications because they're available. Thank you.
Thank you, ma'am, for your nice presentation. Should we go for
Abhijit sir is ready?
presentation?
Yeah. Abhijit sir is ready, so I think you can finish.
Yeah.
Sir, you can share your screen, please.
Yes. Hello, good afternoon, everybody. Am I audible? No?
Yes, loud and clear. You can start.
Okay, thank you. So, thank you. So, friends, thanks for inviting me to this summer session of our MOS and BOA. So, all of us now, we are doing a lot of Ahmed glaucoma valve surgeries in advanced glaucomas, secondary glaucomas, traumatic glaucomas. And so, results of Ahmed glaucoma valve are very good. Post-operatively, the intraocular pressure control is found to be very nice with Ahmed glaucoma valve. And the most important thing is there is very less chance of immediate post-operative hypotony as compared to the valve devices. So basically, what is Ahmed glaucoma valve? It's a plastic plate at the distal end of the tube, which establishes an enlarged space for the aqueous humor drainage with a unique feature of opening the valve when the intraocular pressure is more than 10 millimeters of mercury. And as I said, because of the valve, post-hypotony is avoided. And the inner diameter of the tube is 300 microns, so it doesn't provide any resistance to the aqueous outflow. So long-term intraocular pressure control for any glaucoma surgery, it requires two things, both plate size and the tissue response to the implant. So the thickness and porosity of the capsule which forms around the implant plate is important for the post-operative control in the long run. So tissues around the plate provide passive resistance just like a wall of trabeculectomy bleb. So there are different studies in the literature. The most important is the Ahmed ABC study, that is Ahmed valve versus bar valve comparison study. Then the old one was a tube versus trabeculectomy study and other randomized control studies, which I will just enlighten here. So as I said, because of this flow restricting mechanism, the intraocular pressure control is about 8 to 15 millimeters of mercury post-operatively, but a hypertensive phase may develop after 4 to 16 weeks, in which the intraocular pressure may go up to high 20s or even 30s also. So why does it happen? So in early cases, if you find the intraocular pressure is high, then most of the times it is because of the obstruction of the tube by fibrin, blood clots, iris tissue, or the vitreous membranes and silicone in some patients. About 7% of the patients we see this kind of elevation. Most commonly, iris and fibrin membrane are the causes, and other causes are the neovascular membrane and rarely iridocorneal endothelial touch. So here you can see the post-operative picture. So you can see a membrane over the lens which is blocking the tube, and after treatment you can see the tube is now open, and then you will get nice control of the intraocular pressure. So most of the time what happens, the ostium of the tube will get blocked by the iris. So some surgeons, they do iridotomy at the site of the tube so as to avoid the iris tissue plugging the ostium. But you have to be very careful in neovascular glaucomas here, which is not to be done. Then another treatment is go for Nd:YAG laser membranectomy to reopen the blocked tube, which will help almost 85% of the patients. But recurrence is seen in 50% of these patients post laser treatment. There are other complications like moderate AC reaction, hyphema, corneal edema, intraocular pressure spikes, and shallow AC after laser treatment also. As I said, you can see this iris tissue is going and blocking the tube. And after treatment, you can see the tube is separated from the iris tissue. So how you manage this occluded tube? It's a very simple technique. You have already done paracentesis intraoperatively. Just open that paracentesis, pass a 30 gauge cannula using BSS, and just flush the tube opening. And sometimes with a severe membranous reaction, you can give injection of tissue plasminogen activator intracamerally. Then you see some kind of picture like this in some cases post-operatively. This is a hypertensive phase, that is a tenon cyst, or you can see it's a failing bleb. You can see highly vascularized, localized bleb. So this tenon cyst may be seen when the intraocular, as I said, will be about 20 to 30, and usually 3 to 5 weeks post-operatively. In one study, it was found that if you use post-operatively corticosteroids like Dexa and NSAIDs, then with corticosteroids, there is higher chance of high intraocular pressure and congenital retraction of almost 62%. As against NSAIDs, we have only 13% chance of these post-operative complications. Of course, this was done in older models when there was no silicon plate available. Nowadays, we are using silicon plate, so we can use steroids in a safer way. Then hypertensive phase, as I said, almost 40% of the cases in one study showed this hypertensive phase. This lasted about for 3 months. In one study, they found that if you find the intraocular pressure about more than 10 millimeters of mercury, then immediately start aqueous suppression so that intraocular pressure will have very good control and you will not have incidence of hypertensive phase. Why this hypertensive phase is important? Because these patients, they are prone to develop failure. Another study indicated that if you give a subconjunctival, subtenon triacetyl injection, it will definitely lower the hypertensive phase. And bleb encapsulation was found only in 4% of such patients. So coming to the late IOP elevation. So after 3 or 6 months, if you find that the tube is patent, but still the intraocular pressure is high, then it is because of the excessively thick fibrous capsule. Some surgeons, they advocate using mitomycin C at the time of surgery, but it is not going to help in long run. So you can see this fibro membrane, you can see in neovascular glaucomas because of the inflammation in a long day. So the treatment is needling. Needling revision will improve the functions of the encapsulated drainage implant, but needling has got a risk of endophthalmitis. If after needling the results are not there, then you remove the portion of the encapsulated bleb beneath the conjunctiva. And in another study, it was found that for 2.5 years, the patients were followed up after doing this capsular excision, and the mean of intraocular pressure was well controlled in almost 75% of the patients. Then coming to the late IOP elevation after 6 months or 9 months. So it is seen that topical corticosteroids, if they are given for a long duration, just like steroid-induced glaucoma, you can
sir,
have,
1 minute to go.
Yeah, sure. So another thing is a tube obstruction by kinking, which is seen in pars plana thing. So the treatment is very simple: reinsert the tube in a different scleral entry or use a pars plana tube. Another important reason is tube migration. If you are not anchoring the amyloid wall properly to the sclera, then the tube may move, and it will lead to obstruction of the tube and retraction, and it may touch cornea also. So the treatment is very simple. Tube extender can be used to lengthen the tube. So in nutshell, amyloid glaucoma valve, if you follow up the patient very carefully and check the pressure very thoroughly for every visit, then you can definitely have a well control of the intraocular pressure throughout his life. Thank you.
Thank you, sir, for your nice presentation. Medha madam, are you ready with your presentation?
Yeah, I'm ready. I'll start sharing my screen.
Yes, please.
Yeah, can you see?
Medha.
Yeah.
Yeah, ma'am. Short introduction.
Right.
Hello.
Sir, Darade sir, you can go ahead.
Yes. Yeah. Dr. Medha ma'am, she did her graduation from BJ Medical College, Pune, and she did her fellowship of glaucoma and anti-segment from Shankar Nethralaya, Chennai, and medical retina from Shankar Nethralaya, Chennai. She was a consultant at Ganpati Nethralaya also. She wrote a book, Atlas of Optic Nerve Head Evaluation in Glaucoma. She had been invited as a guest speaker at various state and national conferences and in live webinars. Now, currently, she is a glaucoma consultant at Prabhu Desai Eye Clinic and director Insight Vision Foundation. She's going to talk on glaucomatous optic disc pitfalls. Over to you, ma'am.
Thank you, Dr. Sarang. Thank you for a nice introduction. I would like to thank BOA also for inviting me for this particular webinar. We will straight away go to the pitfalls. So high CD is a pitfall which may be misdiagnosed as having glaucoma, but most important thing is all these patients have large discs and then large cups. So we should not label them as having glaucoma, and we should obviously document and evaluate them. So variation in normal disc size is very common. We have small, moderate as well as large discs, and this affects the apparent neuroretinal rim. So if patient, now this particular disc, whether this patient is a normal disc or as an inferiorly thin NRR as seen by kinking over here. So it is very difficult to say whether this patient has glaucoma, but if you look at the RNFL, it shows a wide wedge-shaped defects inferotemporally. So this is definitely a glaucomatous disc. So diffuse difficulty to see neuroretinal rim, always observe retinal nerve fiber layer. So myopia is again a pitfall where we are not sure whether it is glaucoma or not. And all these discs should be documented because it is a diagnostic dilemma and should be followed up properly. Tilted disc again is a difficulty whether it is glaucoma or not. Patient might be harboring glaucoma also. So again, you need to document and investigate these patients, and can be mistaken as a thin NRR because we know that this is a temporal disc is typical of myopia. Now this is a PP is there inferotemporally. So whether that is normal or patient is has glaucomatous optic neuropathy. So again, you need to investigate here. Even if the OCT is showing thinning, that is mainly because of the PPA in both the eyes, and even the enlargement of the blind spot is because of the PPA, which is there in the inferior temporal and inferior quadrant. So this patient can be a totally normal patient and not a glaucoma patient. So now these are a typical tilted discs of tilted disc syndrome, and we should not consider them as having glaucoma. The next is vertical enlargement of the cup. So these two examples are there on the left and right. So which you think as glaucoma? So definitely left eye is a vertical oval disc and looks like NRR is totally normal. But right eye, if you see, there is a thinning of neuroretinal rim, probably temporarily. So for this patient, we need to see what is the RNFL. So you can see the bipolar RNFL defect, superior temporal and inferior temporally. So this is a patient of glaucoma. So pallar and cupping, we need to differentiate between pallar and cupping. So if the patient has large cups and less pallar, then definitely it is glaucoma. But if the patient has small cup and pallar is much more, then it is definitely not glaucoma and something else is going on. So rim pallar in glaucoma is very rare, and these cases you have to investigate neurologically. Don't label them as having glaucoma, though you can see that there is a pale disc, and sometimes with direct ophthalmoscopy it is very difficult. So you have to take photographs and study them in detail. Now this left-sided disc, you can see that there is a rim pallar, which we had seen in earlier examples, and this patient was going on around by labeling, someone has labeled him as NTG, and he was on multiple medications and still worsening. If you see, his perimetry and OCT pictures are not matching. They are not suggestive of glaucoma, even though pallar is totally different. So when we investigated this patient, you can see that he has multiple abnormalities, but the main focus was on chronic microvascular ischemic changes. Even the larger cerebellar arteries were not normal, and this is pre-COVID. So we cannot label this as having COVID. Again, a patient with pallar, whether it is normal or not, if you see the whole fundus stricture, this is a patient of CRO. You can see multiple embolia there, and the left side is a patient of tributary vein arterial occlusion, again with multiple emboli there. So this is not normal. Pallar more than cupping, again, can be many different things, can be primary optic atrophy or a patient of retinitis pigmentosa sine pigmento. So you have to see the whole pictures. Coming to vascular size, both on your left side is NVD, but this is a NVD of a vascular disorder, and this is glaucomatous. Bare netting, this is a totally normal because of the deep cups, but the down one is a glaucoma. And circumlinear vessel, top is normal, and the down one is definitely a bare circumlinear vessel, so it is glaucoma. Coming to beta atrophy, again, you can see various types of beta atrophy in multiple patients, but on the left side is typical of myopic beta atrophy. Middle one is a moderate GON, and the left one is an advanced GON. Coming to other parameters, so if you see the patient has glaucoma along with other comorbid situations, patient has a CRVO in this left eye. So all these conditions should be kept into mind, that other coexisting morbidities would be there. Another interesting case, if you see patient has multiple drusen, there are RP irregularities. If you see fundus, because he was on medical treatment for glaucoma, you can see certain perimetry defects in both his right and left eye also. And if you see the left eye 10-2, you can see that patient has a patch of RP inferonasally here, which is reflected as a inferotemporal paracentral defect over here. But the GPA is normal of this patient, even if the patient has variable field defects. So you have to consider these patients accordingly and treat them accordingly. Now coming to another interesting case, patient had a disc hemorrhage here. So whether this is glaucoma or not, if you see the RNFL, that RNFL is very thick. Patient has a typical altitudinal defect here. There is no cupping over here. So if you see now, there is a loss of structure and function correlation. So this is a patient of AIN and not glaucoma. Incidentally, this patient came to us after 2 years, and now you can see how the optic disc of the right eye is. But if you don't see the opticness, you might label this patient as having glaucoma, depending upon the OCT and the field defects. But this is a late AIN presentation of the same patient. So I cannot finish my topic before coming to an optic pit. So optic pits are also misdiagnosed as having glaucoma. If you don't see the whole picture, you can see the fluid in the color photo over here, and the same you can connection to the optic disc margin, along with a separation of the retinal layers and accumulation of fluid. So this is a classic case of optic pit and should not be labeled as having glaucoma. So there are various optic nerve conditions which we have to keep into mind, label them accordingly, and follow up them regularly. So
Madam, 1 minute to go.
Yeah, thank you. Pallor in excess of cupping is something other than glaucoma. When the rim tissue is pale, suspect some other causes along with probably glaucoma. Rim pallor in glaucoma is very rare, and disc pallor can only be accepted as part of glaucoma when other potential causes have been eliminated. Disc notching, nothing notches a nerve like glaucoma. If there is a focal damage to a nerve, it is very specific, but tumors don't match a notch a nerve, nor inflammations, infections, or ischemia. Coming to structural function correlation, if there is no correlation, obviously you have to look for other abnormalities, other problems like media opacities, neurological causes, and retinal diseases. To avoid pitfalls, you have to evaluate carefully. Note the disc size. NRR is important and not CD. Check for pallor cup discrepancy. Find and observe vascular signs. Evaluate and correlate RNFL defects. Keep a high level of suspicion when the findings are atypical. Remember that a patient may have more than one disease. If discs are anomalous, monitor frequently. So keep into mind that everything that looks like glaucoma may not be a glaucoma. Thank you for your kind.
Thank you, madam.
Thank you, ma'am, for your presentation. A very nice presentation and up to the point. I think next topic is by Dr. Subhas Prasad. Dr. Subhas Prasad. He's a currently director and chief consultant of Divya Drashti Eye Center, Patna, and he participated in various conferences as a chairperson and faculty. And sir, I hand over to this topic, steroid-induced glaucoma, Subhas Prasad sir.
Thank you.
Good afternoon, Dr. Prasad sir. Good afternoon, everyone.
Good afternoon, everyone.
Good afternoon, madam.
And thanks for inviting me. I would be speaking on steroid-induced glaucoma. Steroid-induced glaucoma is a form of secondary open-angle glaucoma that results from the use of steroid, and this is one of the important causes of secondary glaucoma, considering the fact that so many ocular conditions actually require steroid for a longer period of time. This can usually happen with anyone, but any form of the steroid, but most commonly topical uses are known to cause a rise in intraocular pressure. The connection between steroid and glaucoma was first demonstrated in early 1950s, but the actual role of or actual effect of the topical steroid leading to rise in intraocular pressure was by the two landmark studies by Baker and Armley. We all are aware of that. They have established that the topical use of steroid can lead to rise in intraocular pressure, and based on the observation, they have classified into steroid responders. So approximately 1/3 of the individual can experience rise in intraocular pressure after the use of the steroid, any age, but younger age group is more commonly involved because most of the patients, they have VKC. We all know that this is time during summer, many patients, they come with VKC, and many of them go, they take the steroid injudiciously without any knowledge that it can lead to rise in intraocular pressure. Any sex or racial predilection can be involved. Normally 5 to 6% of the population do develop marked rise in the intraocular pressure, and these are called steroid responder. The rise in intraocular pressure is basically due to the restriction of the reducing the outflow facility, and the most accepted theory is that there is less release of the hyaluronidase enzyme, which is responsible for the catabolism of glycosaminoglycans, because there is a stabilization of the lysosome membranes once you use steroid, and since there is less catabolism, it gets accumulated into the trabecular meshes, leading to the outflow obstruction. And other theories are that there is less phagocytosis of the foreign material which can accumulate in the trabecular meshes. There is inhibition of the synthesis of prostaglandin, and there is increased expression of the trabecular mesh tight junction proteins. Basically, there is basement membrane accumulation in the membrane of the trabecular meshes, which is seen on microscopy. And these all can lead to increase in the resistance to the outflow of the aqueous, leading to the rise in intraocular pressure. There are who all are the patients who undergo more rise in intraocular pressure. There are certain risk factors that could be patient related or the drug related. In the patient related, patients with primary open glaucoma are more known to have rise in intraocular pressure of the steroid or the first degree relatives, very young patients, patients with myopia, adaptive mellitus, patients with connective disorders, and patient who has undergone trauma and developed angle recession, pigment dispersion syndrome. But not all of these patients do develop rise in intraocular pressure. So some element of genetic predisposition is also there. All the routes are known to lead rise in intraocular pressure, but it's the local use of the drops in form of drops or ointments or the periocular injection which are more likely to lead to rise in intraocular pressure. So topical preparation, which is most frequently advised or prescribed to our patients in various ocular conditions, are notorious to lead to rise in intraocular pressures, and which is again related to duration. Among the periocular injections, subtenon injection or subconjunctival injections of the steroid, particularly the triamcinolone acetonide, which is given in some patients of iridocyclitis not responding to topical steroid or posterior uveitis. These patients, or sometimes even in the diabetic macular edema, can lead to rise in intraocular pressures, and sometimes the pressure rise can be so high that you have to excise the subtenon steroids. Intravitreal injection use, there are many conditions where intravitreal injections of steroids are given, like in vascular occlusion or diabetic macular edema. Most commonly used drug used to be triamcinolone acetonide before the advent of the anti-VEGF. And during that time, a lot of patients used to have rise in intraocular pressure in those patients. So nowadays, with the advent of the intravitreal injections of the anti-VEGFs, many patients are not receiving those. So the incidence of glaucoma has actually gone down. And even though it is used in some places, the dose which used to be 4 milligram intravitreal, now it has been reduced to 2 milligram. Ojudex has come as a substitute for this triamcinolone acetonide, but it is costly. And one steroid which was there in vogue few years back was fluocinolone acetonide. In those patients, almost 25% of the patients do develop. This is one of the patients who presented to me, was implanted this reticent implant somewhere else, developed cataract. Then there was spontaneous dislocation which came into the AC, which was removed by me in my center. If you apply ointment for various blepharitis, also that can also lead to rise in intraocular pressure. Systemic steroid are known to lead to rise in intraocular pressure, but cataract is more common than compared to the glaucoma in those patients. So the other risk factor is the steroid formulation. More potent the drug is, more there is chance that it will lead to rise in intraocular pressure. And duration, again, one of the most important factor. If you use it for longer period, it is going to lead to rise in intraocular pressure. So longer use, there is more chance of rise in intraocular pressure. So greater risk with the strong steroid, lesser risk with the weak steroid, greater risk with the ocular route, less risk with the extraocular route. Most of the patients, they do have the slower rise in intraocular pressure. So most of them present like open angle glaucoma. So there's no need to go into that detail. But very important is to know that whenever any patient of inflammation comes, one has to ask about the use of steroid. One has to differentiate this with the primary open angle glaucoma. Sometimes normal tension glaucoma could actually be a case of steroid induced, which in previous year had taken steroid, now it has stopped, but there are changes, so it can mimic.
Subhash sir, 1 minute to go.
Yeah, okay. So the management starts with at the time you see the patient, any patient who are known to go for longer use of steroid, they must be warned. They must be used a drug which is actually less likely to lead to rise in intraocular pressure. And the first and foremost thing is discontinue the steroid if you can. If not, then a steroid sparing agent should be used. Chronic form usually resolves by 1 to 4 weeks, and few of the patients, nearly 3% of the patient, their pressure is rise in pressure is persistent. These patients actually require trabeculectomy also. So the treatment, one has to particularly avoid the prostaglandin, because many of the patients, they do have VKC, so it will increase the hyperemia. And patients of uveitis, if they are taking steroid, if you give prostaglandin to start with, there can be actually recurrence, or there is chances that inflammation may increase. So better to give other drugs. Sometimes laser trabeculoplasty can be done just to postpone the surgery, or just to postpone till that the pressure starts lowering down. And in some resistant cases, you have to do filtering surgery. So just to summarize, steroid is one of the important causes of secondary glaucoma, and those steroid responder has to be actually identified, And in those patients, judicious use of steroid is advisable. These patients should always be told that they need strict monitoring, and if possible, substitute the steroid with some sparing agents and treat it like a open angle glaucoma. Thank you very much.
Thank you,
Thank
sir.
you. Yes. Thank you, Subhash sir. Our next speaker is Dr. Devin Tuli.
Yeah.
Good afternoon. Good afternoon, Dr. Tuli. Good afternoon, Dr. Deepak Bhai. Can I just intervene and just say that I really thank Manish from the bottom of my heart for putting up together such a beautiful galaxy of stars. Dr. Sarang, sorry for interrupting, but these things have to be said. Good afternoon, everybody, and thank you for being with us today and for sparing your time.
Thank you, Ragini.
Good afternoon, ma'am. Thank you.
Wonderful show, Dr. Ragini.
So good afternoon, Medha ma'am. Thank you. Good afternoon, Sachin. So this show is all Preetham's baby brainchild, Swapnesh Sumit's hard work, and this glaucoma show is completely Manish's baby and his hard work.
Good.
Devin sir, can you start?
Yeah. Thank you, Ragini ma'am, and thank you, Manish, for the opportunity, BOA. So initiation is the topic which has been given to me, and we have to look at.
Tuli, sir.
Yeah, thank you. So we have to start by setting out target pressure, and there are so many ways to do that, but for everyday practice, this is the easiest way to remember. So for ocular hypertension and early glaucoma, you aim to lower the pressure by 20% for starters. Normal tension glaucoma, reduce it by 30% straight away. Moderate to advanced glaucoma, aim for 30 to 40% reduction respectively, and then adjust over the course of the treatment that the patient teaches you. So this is IOP is the main one. Then we also look at family history of glaucoma, increasing age, brown rays that Indians are. So we are at an intermediate risk for glaucoma, thin cornea and increased CD ratio. So these are the important ones, but not the only ones which determine or help us to determine target pressure. So once you have decided to treat open angle glaucoma, then the question often asked in CMEs like today's is which drug to start, and that is the topic that Manish has allotted me. So what to initiate the treatment with. So remember, this first slide is for ocular hypertension or early glaucoma. And the question was which drug to start, and my answer is you can choose any of the drugs mentioned here. Why? Because most of these or all of these should give us 20 to 25% reduction in pressure when used as single drugs or monotherapy. And I'll remind all of you that for ocular hypertension and early glaucoma, you need 20% reduction. And all these drugs are giving you that much. So when pressure lowering is the only criterion, you can choose any of the drugs mentioned here. But then we have to further refine our choice by looking at the adverse effects. So I'll come back to that. So look at the side effects or the adverse effect or the precautions. So timolol, in my opinion, is an excellent drug to use, especially for India, with the cost factor involved and the vast experience. I think umpteen number of years we have experience with this. So don't discount this for Indian patients. But it's a good drug to use provided we follow these or we ask these or follow these precautions in the patient. So the first two are well known, the bradyarrhythmia, heart failure, the asthma and the COPD. But also look at these. It's the drug known to worsen depression and hallucination in psychiatric patients. Also known to worsen hyperlipidemias. And this is the drug which is known to produce dry eye as the commonest ocular side effect of beta blockers. So keep these in mind. If your patient is outside the ambit of these, then timolol could be a drug to use to begin with at least. Then look at this. A lot of our open angle glaucoma patients are old age, they are geriatric age. And they're anyway prone to falls, falling down. And brimonidine is a drug which is known to produce drowsiness and lethargy. So if an old age patient has reported a fall after starting this, or is saying that I feel drowsy, please, you have so many other drugs you can choose with. It's better to substitute this in the interest of their orthopedic condition. Then 0.2% of this is especially notorious to cause allergic conjunctivitis and dermatitis. Dorzolamide, brinzolamide, yes, dorzolamide is the one which is known to produce stinging. because the pH of this is away from the pH of tears. And pilocarpine, I use it a lot in my practice, and it's to be avoided in patients with central serine cataract and produces headache or brow ache in the young because of induced myopia. So we were doing that situation, which drug to start, and I'll take you back there, that you have chosen any of these, keeping the side effects now in mind. And now you have two situations. In the first situation is that the target IOP, though you expect 20% lowering with any of these, but for some reason in that patient, the target IOP is not met. So in that regard, I come from Delhi and North India. A lot of our colleagues have a habit of doing this. They would add a brimonidine timolol or a dorzolamide timolol combination. That means they're giving one bottle, but they're using two meds. Now, this is not the correct approach to use, because I would like all of you to follow the last line of the slide. The golden rule in medical management of glaucoma is, please try to use single drugs or monotherapy for the same IOP reduction. Now, this is not a bad choice, because this will also give you 30 to 35% IOP reduction. And you have a drug like a prostaglandin, which is giving you that much reduction with a single drug only. So if in my situation, if the target IOP is not met with a single drug like timolol, for example, I would rather switch to a prostaglandin, because 30 to 35% IOP reduction is unsurpassed by any other drug available to us in medical treatment in India today. And then bimatoprost, travoprost, latanoprost, and tafluprost, for the most part, will give you similar IOP reduction, 30 to 35%. Bimatoprost, especially the 0.03, may give you slightly more compared to the others. So remember this never do two drugs at a time when your IOP could be met with a single drug like prostaglandin that way. Now, the second situation is that you've started a drug like timolol or brimonidine as a first line. IOP was lowered. You are happy with the lowering of the IOP, but there were adverse effects, which I've already said. So you can always, in this condition, you can switch to any other class of drugs, say from timolol to brimonidine or otherwise. Now, also there is a concern about which prostaglandin to use. When the IOP lowering is same between the prostaglandins, you look at these criteria. So hyperemia and allergy, if the patient reports that, then the likely drug is to be bimatoprost or travoprost. In that regard, we can switch to latanoprost or use a BAK-free version of that.
Even sir, 1 minute to go.
Yeah, BAK-free version of travoprost, or now we have the tafluprost unims also. If cold chain is a problem, latanoprost, where 6 months in India are usually warm enough, most parts of India. So if that is a concern, you can switch to other drugs, travoprost, bimatoprost, or tafluprost, which are more sturdy molecules. Now, sometimes our patients come with a situation where you, with the target pressure, say moderate glaucoma, you are supposed to use two meds straight away. So in that regard, you have to use a combination. I advocate using combination therapy because of two reasons. Because using two drugs separately versus a combination gives a reduced overall preservative exposure, and patient is still using only one bottle, so the compliance is good. We are lucky.
Concluding remarks, please.
Sorry?
Concluding remarks, the time is overshooting.
There we go. So I think Rupali's already covered all this. So this is what I said. You can use prostaglandin as first line or a timolol. Second line, if you have to use, we can use a prostaglandin and a timolol combination. And then with this, I think that's been covered. So again, thank you so much for the opportunity. I would request admin, just admin, stop the stop share. I find it difficult to do this on this. You can stop my share, please.
Stop you. I think you will have to do it from your end. You
okay,
can,
I'll do it.
Switch off the app. That's it. Yeah, I think so. You've almost done it.
Yeah.
Okay.
It's done
thank
now.
you, Devin sir, for an excellent presentation. Darade sir, can you introduce the next speaker in short?
Yeah, Dr. Deepak Mishra. He'll be talking on tonometers, what we expect and where are we. Dr. Deepak Mishra, sir, please.
Thank you, sir. Good afternoon to all of you.
Can you be a bit louder, Mishra ji?
Thank you, sir. Good afternoon to all of you. Now I'm
audible. Good afternoon. Good afternoon. Yeah.
Good
Audible,
afternoon,
sir?
Dr. Deepak.
You can start. You are audible.
Yeah,
Yes,
he's
sir.
my brother and he was one of the recipients of the gold medal at Bombay Ophthalmic Association.
Thank you, ma'am. Thank you.
Great.
So, there is no financial disclosure. As a glaucoma expert, what we expected from the various tonometers are most important that it should not be affected by the corneal conditions. When we are going to take the parameters or the things, then it should not be affected by any corneal condition. We wish to have a accurate and effective tonometer. Apart from that, if any device, because glaucoma is one thing in which patient usually reported to the clinic for most of the time for the IOP monitoring. So if it is possible, then the self-monitoring device, if any tonometer is having, just like we have BP instrument or the blood sugar. Then another thing, which is the smaller demand or expectation, is the learning curve and the cost. I am going to one by one and find out which of the following things we achieve and how. Apart from these, the ancestral or the tonometer devices, now we have a huge list of the various types of devices. Either they are the indentation based or applanation based, combined, rebound, and every type of tonometer is available in the market today. This is a prototype which is most commonly used Seward's tonometer. It is simple to use and mostly used in the camps. Better advantage is it is not required by the any power supply and the price is reasonably low. So these are some of our expectation is covered by this tonometer. And next one is the Goldman applanation tonometer. It works, I'm leaving these things. But in Goldman applanation tonometer 2, we have the various conditions in which we find out the falsely low IOP and the condition where we have falsely high IOP. Although it is still considered as the gold standard tonometer among the all tonometers, but it also has some problem in it. Next one is the Perkin. Perkin is again a handheld Goldman tonometer, just like Goldman tonometer, and it has removed some of the drawbacks in the applanation tonometer, like it doesn't require any slit lamp and very useful for you are seeing here for the seeing children or bedridden patient or in operating room. You can take some IOP by this. Next one is McCamark tonometer. The biggest advantage of this tonometer is we can use it in the scarred, irregular, and the edematous cornea. This is the important finding. And even we can use it in the soft contact lenses also. Tonopen is a handheld device of the same McCamark tonometer, and it has almost the same advantages as of the previous one. Next one is the ocular response analyzer. The duty of this instrument is that it measures IOP twice, once when the cornea is flattened inward and again when it rebounds back. Based on this difference, they have created corneal hysteresis, and we get the 4 types of corrected things: Goldman corrected IOP, compensated IOP, resistance factor, and CH. But we have to note that since the corneal hysteresis is deeply correlated with the CCT, so it is useful in measuring the things which is associated. It seems to be unassociated with the refractive error and axial length. So in cases where we have different kinds of refractive error and axial length, this kind of tonometer is useful for us. Then we have a rebound tonometer. It is again a very portable and useful tonometer. Here you can use that the plunger is going and touch the cornea and taken back. Advantage is that it is light and the strip is disposable. So in cases of the condition where we have corneal ulcers are smaller, we can take it as a choice for your tonometer. DCT is a 3rd generation tonometer where it works on the principles of the contour matching, and since it matches throughout the cornea, so the problems of corneal thickness and rigidity which influences in the another tonometer is slightly less in this as compared to another. And I'm leaving it the various advantages it is having, that it is not affected by the central corneal thickness, which is the main problem in the Goldman applanation tonometer. Again, it has numeric display. Here you can see it can display here. So whatever the calibration error, mechanical error is seen is not there. And it is useful in the keratoconus, corneal edema, or the LASIK patient.
Dr.
Next
need to go.
Next is the phosgene tonometer. It is a self-monitoring devices and doesn't require anesthesia. It is just like what we expect as a autotonometer. And this is a IOP telemetry. It's a device for the continuous monitoring of the IOP. It is for the doing DB, just like we are doing diurnal variation for 24 hours. This is the chart, which is a comparison of all the tonometers apart along with the Goldman applanation tonometer, which is having what. Now I'm concluding my slide that yes, despite of all tonometers, Goldman is the gold standard for the irregular corneas, contact lenses, intraocular gases. For each and every one, we have a tonometer. So we have tonometer which is not affected by corneal condition, accuracy, efficacy, self-monitoring, DB, cost, everything is there. But the major problem is that they fulfill our expectations, but not as a single tonometer. They have a different kind of tonometer, and still we are searching a single tonometer which is having the features of all. With this concluding remark, I would like to thank BOA, Lahane sir, Ragini ma'am, Sachin sir, and Manish sir for including me. Thank you.
Thank you, Mishra sir. That was an excellent presentation. And now we come to the icing on the cake for a man who needs no introduction. Pradeep Vyas sir. Sir, ready with the topic?
Thank you, Deepak.
Thank you, ma'am.
Good afternoon, Vyas sir. Namaskar, pranam.
Sir, you are not audible. Kindly unmute yourself. Pradeep sir.
Namaste, Ragini. How are you?
Muted himself.
Fine, thank you, sir.
Good
Thank
afternoon,
you,
sir.
everybody.
Wonderful. All of us are enjoying this meeting.
Thank you, sir. Thank you for being with us, all of you, and for sparing your time.
It's our duty. When you order, you have to do that.
Deepak, it was good, huh? Deepak.
Thank you, sir.
Presentation was good. Huh?
Thank you, sir. Thank you.
Good evening, sir.
Good afternoon,
Pradeep
sir.
sir is going to talk.
Good afternoon. Good afternoon, everybody. Good afternoon.
Sir, प्रदीप सर ने अभी कहा कि हमको तो ऑर्डर किया जाता है, so we have to come only.
नहीं ऐसा नहीं, मैं उनका ऑर्डर सुनता हूँ, बाद में ऑर्डर कर सकता हूँ. इट इज नॉट दैट इट इज यूनिलैटरल. जो प्रत्येक बायलैटरल है ना,
वो तो आपका अधिकार है ऑर्डर करने का.
थैंक यू. गो अहेड.
So, good afternoon, friends. Thank you, Padma Shri, Professor Lahane sir, beloved Ragini, dearest friend Manish, Sachin, and all other friends. Thank you for the opportunity given. I am given a responsibility to talk on the advances in medical management of glaucoma. So why are we talking of the advances in medical management of glaucoma when we have so many drugs in our armamentarium? But the problem is that none of the current medication available is free of systemic and local side effects. There are quite a few medications in our armamentarium which are not able to give 24 hours control in the intraocular pressure. There are many patients who are not able to tolerate one, two, or all drugs. Even when all four drugs, we have 4 classes of the drugs are used in combination, but still many of the patients, they are not capable of lowering the intraocular pressure to the desired level. So obviously there is a quest for new molecules. So we are looking for new molecules or new agent which should have a potent IOP lowering efficacy with minimal side effect. What I mean to say that you put just one drop and you should get a target pressure in almost all of your patients. That is the most ideal situation. It should be highly effective in diurnal curve, means there should be a 24 hours IOP control with single installation or one drop. And obviously, we desire, that is our dream, that they should have an additional neuroprotective or a vasoprotective action. In this endeavor, we want that the drug should have a minimum dosing, better tolerability, and it should be affordable. So why are we looking for these new molecules? Look at this. The suspension particles are all around the eye and causing, lots of cosmetic effect, and there is significant redness of the eyes. The other lady had a redness in both the eyes, and you can see that it's a prostaglandin associated keriorbitopathy. Both the eyes in this young individual are very deep set, looks very ugly, and there is a hyperpigmentation around the eye and hypertrichiasis. You can see that, there is lots of skin excoriation around associated with the alpha agonist drug. So most of the molecules, what we have in our armamentarium, are capable of lowering the intraocular pressure, and we do get the desired IOP in our most of the patient, but still they all are associated with several local and systemic side effects. That is the history of the medical management of glaucoma. It started way back in 1875. It is almost 150 years, and still the drug which was introduced 150 years before, pilocarpine, still we are using it, still in a very important drug in our glaucoma armamentarium. And then after that, after a huge lull, the beta blocker was introduced around 75 or so. And after that, we had some other class of drugs like alpha agonist and carbonic anhydrase inhibitor. And then the most powerful drug came in 1996. That is almost 25 years before. It was the latanoprost, and still it's kind of a gold standard in the management of glaucoma. And after that, there was again a big pause, and we did not have a drug which acted through a different mechanism. There was various molecules available, but they were from the same class with a slight modification. Some company has written PF. So my colleague thought that it's a preservative free, but somebody says that no, it's a patient friendly, whatsoever it is. So, but there was some here and there rotation. And then after a big lull, we got some exciting molecule. So that is the 4 classes of drug right now we have. And if you want to add, you can add the myotics, that is a pilocarpine into that. So it becomes the total 5 classes. So out of the new molecules, what we have now is one is again associated with the PG analog, and another one is little exciting molecule. We will discuss in a brief. It's already 3:30, so I will not go into great detail, but I will just give you a brief look into that. So we will talk about the new molecule, we will talk about the new combination, and we will talk about the new drug delivery system, but very briefly. The new molecule is latanoprostate not nothing new, it's a latanoprost, but this drug get hydrolyzed in the cornea and it releases the nitric oxide inside the eye. The nitric oxide has an additive characteristic that it might be a neuroprotective, and it helps in reducing the intraocular pressure further by around 1 to 2 millimeter of mercury. That drug is come with the name of Izulta, and it's not available in our country. It was recently approved by the US FDA, maybe about a couple of years before. Another exciting molecule, which acts through altogether a different mechanism of action. It is the ROCK inhibitor. The ROCK is present throughout the body, like what we talk about the carbonic anhydrase. And they are very important for us as a glaucoma specialist when it is present in the trabecular meshwork and ciliary body area. It reduces the intraocular pressure by 2 mechanisms. It relaxes the trabecular meshwork, so it enhances the aqueous secretion. It enhances the aqueous secretion through the conventional pathway. And also it enhances the aqueous secretion through the non-conventional pathway. Also, it has a mechanism of action through the non-epinephrine transporter, by virtue of which it reduces the secretion of the aqueous humor. And because it is a potent vasodilator, it dilates the episcleral vein, and again, it reduces the intraocular pressure. So there are several mechanisms, at least 3 mechanisms, by virtue of which it reduces the intraocular pressure, as well as it inhibits the aqueous protection also. Okay, it is the similar diagram. I would not go into the details of that. So it is the nitarsudil, that is a Ropresa available in international market, and the generic one or the biosimilar molecule is available in the Indian market as well. The rocket trial which was conducted on it suggests that it is non-inferior to beta blocker. And just for your knowledge, that nowadays the FDA approves only those drugs which are non-inferior to the beta blocker. So it is non-inferior to beta blocker. But way back in Japanese market, the similar molecule was introduced, that is the Refractory, way back in 2016. Japanese are always ahead of the Americans in prostaglandin analog also. All of us knows. But same, like the Ropresa is more potent as compared to the Ripasidil. And we are looking for the ideal drug. Whether it fits into the ideal drug, I don't think so. Number one, because it causes hyperemia almost in 30% of our patients. It causes lots of burning and irritation. It reduces the IOP. They say that it is not inferior to beta blocker. But in my practice, I have started using from the Clarate, which was available in Japan. I have used Ropresa in many of my patients. I am using the generic one also, but in my experience, it does not reduce the intraocular pressure by more than 2 to 4 millimeter of mercury. And it causes lots of side effects. Like it causes this subconjunctival hemorrhage, what you can see in this slide. It causes lots of hyperemia because it's a very potent dilator, a vasodilator, and it causes a corneal verticillata. Obviously, it's a reversible changes, and once you discontinue this, this goes away. So there are lots of disadvantages. We have discussed most of this. There are some advantages also, like it is supposed to be a neuroprotective because it's a potent vasodilator. It says that it's an endothelial protector as well, but there are some papers available in literature which says that it may cause the corneal edema as well. So it is a contradictory report, and we don't go by that. And it says that it has a beneficial effect in the diabetic retinopathy, and it improves or enhances the trabeculectomy outcome. Obviously, it's a matter of debate. Whenever we will give a complete talk on that, we will discuss. There is a new combination available and supposed to be the most potent anti-glaucoma drug on this planet. The brand name of Roclatan. It's a combination of the Xelatan and the ROCK inhibitor, that is a Ropresa. So that is, again, we have a second beta blocker free available fixed combination. Obviously, yes, the mercury trial was conducted, and they says that yes, it's the most potent anti-glaucoma drug. But remember that it causes lots of side effects, and you can see that one of my patients, because both the drugs are known to cause the inflammation of the eye and they are vasodilator. So this kind of a patient you will see 2 to 3 days after the installation, and don't get be afraid and just discontinue the drug. Now, other update on the sustained release PG analog. I'm not going to talk because it's almost outdated. The ring insert, again, it's outdated and no one has accepted it. Intracameral implant, I will just show a couple of slides and that's it. That will end my talk. This is a ring insert, but because of the cosmetic effect and we don't have any control on this, that's why it's not available and it has not become so popular. But this Irosta implant, the biometric sustained release implant, is getting little momentum. I don't know where it will go. It comes in a preloaded injector. It is a 10 microgram biometroplast loaded implant, and it is injected into the anterior chamber of the eye. It floats and it settles down at 6 o'clock position, and it is capable of reducing the intraocular pressure almost equivalent to the biometroplast with lesser side effect, and the compliance and adherence is much better. And probably it has its efficacy up to 1 year. Though it is reported 6 months, but it has its efficacy up to 1 year. There are some advantages in the PAK free also that is related to preservative. Most exciting is the Nomelia free technology. Whatever I'm familiar and I have used, I did not find much benefits as compared to the drug which is loaded with lots of preservatives. So yes, to conclude that some exciting molecules are coming, but still we are in the quest of the most ideal molecule for the management of our glaucoma patient. Thank you very much for this opportunity. Thank you.
Thank you, sir. It was a wonderful talk, as usual. Dr. Darade?
Yes, sir. Thank you, sir. Very nice presentation. I think the session is, there is no answer questions. On behalf of BOA and MOS and organizing committee, Dr. Lahane sir, Ragini ma'am, and the other members, I thank to panelists, speakers, and delegates. Thanks for being. I think I declare the session is over. Thank you.
Thank you, sir. Thank you.
Thank you, everyone.
Thank you. Thank you.
Harsh is already there.
Yes, I wanted to meet Pradeep.
Good afternoon, Dr. Kumar sir.
Good afternoon, sir.
इसी बहाने लोगों को देख तो लें भाई मास्क के
Yes,
Hi,
yes,
Dr.
yes.
Harsh. Medha here.
Harsh is looking for you.
Nice. It's nice that all are.
Harsh, your user field is constricted, it seems.
Sorry.
Get the perimetry done.
नहीं भाई
Medha is right in the corner. She's here.
नहीं मैं सबको देख रहा हूँ जो इसमें हमारे उसमें 2-3 लोग नहीं
Dr. Medha, wave. Dr. Medha, wave.
अरे यार हर्ष सबके चेहरे बदल गए कोरोना में 7 साल में
चेहरे तक तो ठीक है
चेहरे लपट है खाली अंकुर के चेहरा स्माइलिंग
Yes.
Good afternoon, sir. Good afternoon, everyone.
Sir भी है
Harsh Kumar, welcome.
Dr. Harsh.
Thank you for the opportunity.
Dr. Harsh,
Welcome, welcome.
Namaskar, sir.
Dr. Paranspe sir is also here. Good afternoon, Dr. Harsh Kumar sir. Dr. Paranspe sir.
Thank you, so nice of you.
Shekhar, good afternoon.
Good afternoon.
Good afternoon. Good afternoon.
Actually, one question I always ask to all the experts in this field. Nowadays, we are using masks. So whatever hypoxia we are going to get, will it optimize the circulation of optic nerve and give the signs of glaucoma? Just for the thought, actually.
Sir, as long as it is not happy hypoxia, it is good.
Very nice answer.
It may cause vasodilatation and more blood near the optic nerve.
Hypoxia, yes, again immediately and you inhale lots of oxygen. So obviously, hypoxia is not vasoprotective hypoxia.
But if the hyperventilation gets affected, then
Raman sir, your voice is cracking badly.
Raman, your voice.
Now it's okay.
Your voice is no, still cracking. You can take the mic slightly.
बहुत सारे लोगों के माइक ऑन है, म्यूट करना पड़ेगा. सब जो बात कर रहे हैं उन्होंने माइक चालू रखना है, बाकी ने म्यूट करना है.
इसका माइक थोड़ा गड़बड़ है सर.
हाँ, तो मेरा आपका भी माइक चल रहा है, दीपक आपका भी माइक चल रहा है, अंकुर सिन्हा आपका भी माइक चल रहा है, जरा बंद कर दो so that we can hear him. Thank you very much.
One more question because the next session after proper time, the next session is starting at 3:45. So one last question.
Sir, I cannot hear anything. Is somebody speaking?
No, Harsh Kumar is going to speak now. Who is going to speak now?
Yeah, Dr. Harsh Kumar sir. Yes,
आपका हर्ष कुमार शेयर करो, आपका ये शेयर करके ये शुरू करो.
नहीं, can we start, sir? Because there is still 3-4 minutes to 3:45.
Sir, the session is all yours, sir. You are the chairman. You decide and please.
To begin with, I must.
Harsh Kumar, I think a few minutes are remain.
Yeah,
so you can discuss, and at 3:45,
right,
you can start the session.
Right. So we are grateful, right, to begin with. Lahane sir and Ragini and Manish, we are grateful to you for having us here. And we really miss the physical meeting, which was always an attraction in Bombay. And I hope you will stay safe from the storm, which is heading your way tomorrow morning. So I think it was a wonderful session, the last one. And I think Prateep has gone off. So as far as the drugs, I don't think there was any time to discuss much. So as far as the latest drug they were discussing, the last one, definitely the low pressure drug is to be added on. It's always an add-on. So I don't think it is a primary use of, because the hyperemia is really too much. And the pressure lowering primarily is not that great. So Manish, would you like to comment on that?
These are all new things which have come, and I agree completely. We are using as add-on, not even as second drug. I am using as third drug.
Absolutely.
Only when other choices are not working well enough.
Right.
And side effect profiles we are just coming to know. And redness and hyperemia is definitely there. There are corneal complications also which we are seeing now. So it is not all fantastic, but anyway, it is good to have something new so that we can try out.
I'll share with you something that I was really surprised that some of the people with a little bit of corneal edema really cleared off very well with the Refractory. And I was quite shocked. And there were 4 or 5 patients who came back and told me that there is some improvement in the vision which was not related to anything else.
But Harsh, there is other way. There is a corneal edema also used. There are couple of papers where they have reported the edema has increased. So it's a contradictory. And if you see the action of the drug, it acts through the actinomycin, and the endothelial junction is bounded by the actinomycin. So once you put the ROCK inhibitor, it should loosen up, and probably there should be more edema. So I don't know how it acts in reducing the corneal edema, but yes, even I have noticed that at least in 2-3 of my patients, it has reduced the corneal edema. But there are a couple of reports which says that it increases the corneal edema.
No.
It's very contradictory.
In India, the reports are only made by you and me. So we will only, so, unless somebody contradicts us, I think, anyway, we are just.
No, but the reports of the corneal edema increasing are with netarsodil. And that is an epithelial edema, which is reversible by stopping
obviously.
the drug.
It's the big win over the epithelial edema, yes.
And that was, I think, reported by cornea people, and they said that 70 to 80% had corneal edema pre-existing. That was a predisposing factor. That was, I think, highlighted by Dr. Nikhil Gokhale.
To reduce the corneal edema, also you will use in only the patient who has a corneal edema. Yeah?
नहीं वही सर कि एडिमा वाले पेशेंट में यूज करके उनका एडिमा वर्सन हो गया, ऐसा कुछ तो रिपोर्ट है।
यस, ऐसा भी कपल ऑफ रिपोर्ट्स है, और ऐसा भी ज्यादा रिपोर्ट है जिसपे एडिमा कम भी हुआ है। And both the drugs are on the repository. Both the reports, and you know, lots of trials are going on in Japan, particularly for pseudophakic bullous keratopathy.
Yeah,
sir,
exactly.
Prateep sir.
Yes,
sir. I will share one case. Recently, I did one high myope patient. I did IPCL for her, and she developed TAS, and we have to give her a lot of steroids. Following that, she developed high intraocular pressure and corneal edema. Routine anti-glaucoma drugs, the edema was not reduced. But when we added repository, yes, the edema was lessened. So I discussed with my cornea colleagues. They also said, yeah, continue with that. So that is my experience. Recent one. Yeah.
In the inflammatory glaucoma,
it tend to work,
where there is a corneal edema, it might be a drug of choice.
Dr. Harsha,
I think it works better in steroid-induced glaucoma, and also maybe in the post-operative cases where we can use it a little better.
Okay, Ankur, we are on time, and since it's really a tightly packed thing, I really want to thank Bombay Ophthalmic Association, Dr. Manish and Ragini and sir for having us here, Rahane sir. So I think we can start off. Manish, you are there. Can you?
Yes, sir. I'm there, sir.
Yeah, sure.
Good afternoon, sir.
Fresh and handsome as ever. So please, Manish.
Hi, Manish.
Hello, sir.
That is why
I was listening to the discussion, so I'll share my screen, sir.
Yeah, please go ahead. So Manish will be telling us about management of neovascular glaucoma. Please, Manish, stick to your time because
I'll do it, sir. Sure, sir.
Yeah,
so without wasting any time, thank you so much for this honor to being part of this program and this esteemed panel of speakers and panelists. So I'll be talking about the management of neovascular glaucoma. I'll just share one case to make it a little more practical. And I think all of us are seeing a lot of neovascular glaucoma in last year or so in this lockdown period because patients are coming late and they're not able to have regular follow-up. So this is a 55-year-old gentleman, known hypertensive, diabetic, came with decreased vision for 2 months and pain for 3 days. And on slit-lamp evaluation, as you can see, there were new vessels in the iris. Patient had a RAPD with 660 vision and mild corneal edema and 42 millimeter pressure in the left eye. So left eye had a neovascular glaucoma. You can see the new vessels in the iris. You can see on gonioscopy, there were extensive new vessels in the angle, but the angles were open. So basically, and fundus has a CRVO with macular edema. So basically, this was a case of neovascular glaucoma in open stage. So in neovascular glaucoma management, there are a few very important things. One, what is the stage of the disease? And what is the visual prognosis and what is the etiology? These three factors are extremely important whenever you're managing a case of neovascular glaucoma. And as I was telling, last year or so, we are seeing a lot of neovascular glaucoma patients. And as we know, the more and more diabetic and hypertensive patients are there, and we are getting the neovascular glaucoma is not a very rare type of secondary glaucoma, but it is definitely one of the most devastating form of secondary glaucoma which we see. Like any other secondary glaucoma, the treatment is you treat the cause of neovascularization and you control the intraocular pressure. So it's an approach, you have to combine both of them. And if we see 100 patients, 97 patients is because of retinal ischemia. So any patient in neovascular glaucoma, majority will be either a diabetic retinopathy, a proliferative type, or a CRVO, or the third common thing is the carotid obstructive disease. So we should also do a carotid Doppler in case the other two are not there. Coming to management, we should know the stage of the disease. So sometimes it can be pre-rubeotic, that is you have a CRVO, but there is no new vessels in the angle or the iris. So these patients are managed by the retina team. You have to treat the retinal vein occlusion or the proliferative diabetic retinopathy, and you have to make sure you monitor the pressure, do a regular slit-lamp evaluation and a gonioscopy so that you detect those new vessels timely. The first stage is the rubeotic stage, when the vessels, new vessels have already developed over the iris or the angle, but the pressures are still normal. In this case also, you have to treat the cause of rubeosis and you have to monitor the intraocular pressure. The third stage, where the glaucoma doctors especially come in, is the open angle stage, where the IOP has already increased, but the angles are still open. In this case, again, you have to control the intraocular pressure along with treatment of retinal problem. And the fourth stage, which is the most devastating, is the angle closure glaucoma stage, where because of the proliferation of neovessels, the fibrovascular membrane has formed, and that membrane pulls the iris towards the trabecular meshwork, causing the closure of the angle, what we call as the angle closure stage of neovascular glaucoma. Overall, prognostically, it has been seen that patients post-CRVO and VG have the worst prognosis compared to a diabetic retinopathy or a carotid vascular disease. And overall, over a 2-year follow-up, they have found to have a poorer vision in patient post-retinal vein occlusion. So early diagnosis is definitely key, because the earlier you diagnose, the much better is the prognosis, because diagnosing in a case like this is neither very difficult nor very rewarding. So coming to early detection, as I was telling you, in all these patients who are predisposed for neovascular glaucoma, like a proliferative diabetic retinopathy, patient with CRVO, you should have a high level of suspicion. Every patient with CRVO, you should have a monthly undilated 80 slit lamp and a gonioscopy for at least 6 months, so that you can detect these new vessels in time in the angle or in the iris, and you can take the action aggressively. So Treating the cause with the pan-retinal photocoagulation is the most important treatment for retinal ischemia, but there are a lot of patients who come at a stage when there is media opacity. So in these cases, anti-VEGF injection definitely has a role. Retinal cryo can also be a good option for these patients. Patients who are presenting with vitreous hemorrhage, you can have a partial vitrectomy with the endo laser for treatment of rubiosis and ischemia. Anti-VEGF have come up in a big way in these patients because, as I was telling you, a lot of patients, if you're not able to control with medication, you're planning for surgery, you can use anti-VEGF to control the new vessels, and you generally operate after 3 days to a week time because it reduces your chances of hypema and improves your overall success of the patient. Also in patients with macular edema and media opacity, anti-VEGF has a very good role along with pan-retinal photocoagulation. To control intraocular pressure, the best drugs we have is the beta blocker along with the carbonic anhydrase inhibitor and brimonidine. Now ROCK inhibitors have also come. They can also be used in patients with neovascular glaucoma along with oral acetazolamide. We avoid prostaglandins and pilocarpine because these patients generally have a component of inflammation. Steroids have a role because these patients have inflamed eye, there is pain, there is ciliary congestion. These cases, a steroid and low-dose steroid can be useful to decrease the pain and inflammation, and it will also improve your surgical success. Cycloplegics are also important to give symptomatic relief to the patient. So those patients who are not able to control medically, definitely the role of surgery is there. The two best options we have either is a trabeculectomy or a tube surgery or a shunt surgery. So trabeculectomy, whenever you're doing, you should be doing it with antimetabolites. The overall success is less than what we see in primary glaucomas. Personally, I find I've seen the tubes do very well in patients with neovascular glaucoma, especially most of the patients who come to us in glaucoma clinic generally have synechia formation, there is inflammation, and the ischemic factor is an ongoing factor like in diabetic retinopathy, or if the patient is having associated vitreous hemorrhage, these patients shunt do better because they have less dependency on inflammation. But if you see the published literature comparing trabeculectomy and Ahmed glaucoma valve, overall the surgical success is poorer compared to primary glaucomas, but have been found to be comparable. There's another study, very recent study in 2019, where they had a meta-analysis. There also they found that Ahmed glaucoma valve and TRUM have a similar IOP control when it comes to neovascular glaucoma. But in more complicated type of neovascular glaucoma, like patient where there is vitreous hemorrhage, need a partial vitrectomy. This particular article has done a study and they've shown that the success of trabeculectomy is as low as around 40 to 46% compared to 70+% in patient with Ahmed glaucoma valve. So definitely in complicated cases, Ahmed glaucoma valve does better. This particular survey was done by American Glaucoma Society for glaucoma experts in US, and they found that Ahmed glaucoma valve is the preferred line of treatment as a surgery for patients with neovascular glaucoma compared to trabeculectomy. There are certain cases where cyclodestruction like cyclocryotherapy or a diet cyclophotocoagulation definitely have a role, especially in those patients with poor visual prognosis where you mainly want symptomatic relief and you don't want to go for a complicated surgery. In case you have access to endoscopic cytophotocoagulation, that also has a good success rate, but the machine is not freely available in our country. Just to summarize, we have to treat the cause, but related to IOP, first important thing is what is the visual prognosis. If the visual prognosis is good, you be aggressive with your management of intraocular pressure. Don't start with one drug, start with 2 drugs, 3 drugs, including oral Diamox. Bring down the pressure. If you see even with the medication, you are not able to control the pressure, go ahead with surgery. Because in these patients, timing is very important, and most of the patients who become blind due to neovascular glaucoma is mainly because of optic atrophy. But if you see the vision prognosis is poor, in this case, the treatment will be mainly symptomatic with topical steroids, cycloplegic, and cyclodestruction. So to conclude, the key in management is early detection and timely detection. Have a collective approach. You have to involve your retinal colleagues in the treatment. And whenever you have any new vessels, be aggressive. Be very, very aggressive in treatment. Don't start a medicine and see the patient after 10 days. You have to see the patient every 2 or 3 days to see how the patient is responding to your treatment. Thank you so much.
Thank you very much, Manish. Dr. Paranjpe, do you have something to?
No, just a time reminder, nothing else.
Yeah, okay, fine.
Yeah, he was precisely on 8 minutes.
Yeah, good. So Manish,
once the first speaker is precisely on 8 minutes, everybody follows the.
Yeah, good.
Thank you, sir. It's a very precise talk. Thank you very much for that.
Thank you very much, Manish. Wonderful talk. Just one quick question, because most of the people in India will not be able to do a valve. So if they are forced to do a trabeculectomy, what will be your 1 or 2 hints to them that they are forced to do a trabeculectomy in NVG? What should they look for and what should they do?
So, sir, whenever you are doing a patient with trabeculectomy in a patient with new vessel glaucoma, first you have to have a proper pre-op evaluation that there are no new vessels in the iris or the angle. If there is active new vessels, active inflammation, you control it with steroid, give an anti-VEGF to regress these new vessels, because with active new vessels, you are bound to have hyphema. And whenever you're doing trabeculectomy, use mitomycin, preferably in a higher dose, like for example, maybe a 0.2 for 3 minutes or 0.4 for 3 minutes. And again, these patients post-operatively also, you need to keep them under close follow-up and use releasable suture, release them early, because a lot of these patients will have a lot of red blebs in post-operative period.
So good, Manish. I think that is what I wanted you to tell, that at least 3 days prior, you must give a anti-VEGF so that the vessels, even if you can't see them. And one hint I'll give to everybody, that if sometimes even after this you open and you find their vessels, use your cautery probe to do the peripheral iridotomy, pick it up, do a cautery and then cut it so that the vessels don't bleed. Thank you very much. I think we'll go on to Ankur. Ankur,
yes, sir.
Please be ready with your slides, and he'll be telling us about management of angle closure. And Dr. Ameya, I'll request you to collect any questions they are and keep asking if they write after the speaker, if at least 1 or 2 questions are there.
Yeah, sure, sir. I'll do that.
So, is my screens visible?
Yeah, fine.
Yeah. Thank you, BOA and MOS. Thank you for giving me the opportunity, and happy to be a part of the panel where my mentors, my seniors and friends are there. So I'll be talking in brief about approach to angle closure disease. It is one of the most fascinating of all the glaucomas and one of the great masquerades in ophthalmology. It may have subtle symptoms of headache, brow ache. Sometimes they are treated as migraine, and sometimes they are entirely asymptomatic, rapidly marching towards blindness. They may also land up with surgical emergency room diagnosed as acute abdomen because of visceral features. And most of the times it is a failure of not doing gonioscopy. So as high as 40% of OAG patients, angle closure patients are being diagnosed as OAG as per one of the studies in India. So the mechanism of angle closure is oppositional closure of peripheral iris with the trabecular meshwork. The various mechanisms which lead to this is pupillary block, inflammatory membranes, mass lesions, and disorders of ciliary body and iris. Overall prevalence of angle closure glaucoma increases with age, and as per the Western data, the OAG is much more common as compared to ACG. But the Indian scenario is absolutely different. So we find angle closure glaucoma almost as common as open angle glaucoma, if not less. Now there are various terminology and subtypes of this glaucoma which should be taken care of. PACS, or the primary angle closure suspect, is a patient who has occludable angles. That is, the pigmented trabecular meshwork is not seen beyond 90 to 180 degrees of angles in situ gonioscopy, that is without manipulation or indentation. And any evidence of goniosynechy or pigmented trabecular meshwork would point towards conversion of PACS to PAC, that is primary angle closure. Then we have various forms of glaucoma, and based upon the symptoms, IOP, fundus changes, and field changes, they can be divided into acute or intermittent PACGs, acute PACGs, and chronic PACGs. Now, parameters that govern the part of spectrum of this disease are the amount of trabecular meshwork occlusion, the rapidity of occlusion, and the ease of reversal of the trabecular meshwork block which we are having. Also, it is important to note that a lot of patients are less than 40 years of age, so there is a term called as juvenile PACG which is being used these days. We should also know that a lot of patients do not have symptoms, like a lot of subacute patients do not have symptoms, and as high as 80% of chronic patients do not tend to have symptoms, as we read in the book of pain, headache, brow ache, and color halos. Now, primary angle closure suspect is characterized by shallow AC and occludable angles. YAG-PI is to be discussed with the patient, and one can exercise the option of YAG-PI if the patient is going to be lost to follow-up. But it is important to keep the patients on follow-up and do a YAG-PI when they shift to PAC. Now, this is a patient who is having occludable angles. So we can see occludable angles here. Angles are closed. But as we indent, we can see opening of the angles. Whenever we see these goniosynechy or pigmented trabecular meshwork, this points towards the conversion of PACS to PAC, and YAG-PI is mandated at this particular stage. Subacute angle closure is characterized by normal symptom-free intervals. Then there are brief episodes of dull age, blurred vision, colored halos. They also have shallow ACs and occludable angles. Now, this is a patient where we can see this anterior bowing of iris, shallow peripheral anterior chamber, and this is an early PES formation, which we can see here. Precipitating factors for a subacute attack are dim light, fatigue, near work, and it resolves spontaneously with sleep, bright light, and lying supine. Acute angle closure is characterized by symptoms of blurred vision, intense pain, congestion, lay dilemma, visceral features, and diaphoresis. We can see corneal edema, circumciliary congestion, vertically dilated oval pupil, shallow anterior chamber, very high IOPs, and disc edemas. Now, this is a patient of acute PSEG where we can see very shallow anterior chambers, peripheral iridocorneal contact. We can also see the glaucoma flecken here, and on the gonioscopy, we have a lot of blurred vision because of corneal edema. So as the cornea clears up, we do a gonioscopy, we find the angles are absolutely closed. So acute angle closure patients have a history of premonitory attack. That is, they do have intermittent or subacute attacks in as high as 1/3 of patients. Precipitating events could be mydriasis, illness, emotional distress, or intense concentration. Chronic angle closure is characterized by chronically elevated IOP, shallow AC. There could be fundus changes typical of glaucoma. Gonioscopy would show signs of angle closure, intermittent acute attacks, and we have to understand that CPACG is progresses much faster than POAG. And there are two paths to progression, that is a gradual path formation or a creeping angle closure. Now, management line is a YAG-PI, medical management, and followed by surgical management as we do for all other glaucomas. Now, let us talk about DESI evidences in management of glaucoma. What do they say? So, 5-year conversion rate of primary angle closure suspect to PAC is 22%. That is, during the 5 years, at least 1/5 of PSCS will convert to PAC. That is why we should discuss YAG-PI with these patients. Subacute PSC is more common in 40s and 50s, and 2/3 of them can be controlled by only with laser PI. So laser PI is an important tool in management of subacute PSCGs. 5-year conversion rate of primary angle closure to chronic PSCG is 28%. Nearly 1/3 of them will convert. But out of these 1/3, with LPI, only 11% will convert. Rest all will not convert to the chronic PSCG. So LPI is 3 times more protective in prevention of conversion from PSC to CPSCG. Bilateral affected eyes are more common in subacute patients. An absolute eye is more common with chronic angle closure glaucomas because it tends to progress faster. Iridotomy alone can control IOP in as high as 2/3 of patients in subacute PSCGs and 12% in acute cases. YAG-PI alone with topical drops can control as high as 50% of acute ACGs, 2/3 of subacute ACGs, and 1/3 of chronic PSCGs. So that is why YAG-PI is mandated even in chronic PSCGs eyes. Now, what is the role of lens extraction these days? Now, this came into picture because of this study which talked about early lens extraction in angle closure glaucoma. So we should have a detailed look at the study, what it was actually. So first of all, 50% of patients of PSCG were excluded from the study. So it is not applicable for all the patients of PSCG. The IOP was less than 30 millimeters of mercury on applanation tension, not on NCT. There were 10% of patients who underwent gonioscopy at the surgeon's discretion. So we don't know what was the outcome of these patients. Also, degree of synovial and oppositional closure was not reported in these patients. Patients and investigators was not masked. The bias of study was towards the surgical interventions. So out of 805 patients, 386 were not included in their study. The outcomes in terms of pressure were not much difference in terms of LPI versus early lens extractions. So it was a small difference of 1.3 millimeters of mercury. Similar was the outcome in case of visual field analysis in the change in terms of mean deviation of visual fields. Complication risk was definitely high in surgical group as compared to laser PI. So in the lens extractions, in my personal opinion, the eyes with moderate rise in IOP, minimal or no disturbance of visual acuity because of the clear lens, no or visual field loss, none or no visual field loss, none or minimal optic atrophy, a surgical intervention creating a pseudophakia is not justified. So to conclude, LPI is still the established first-line form of treatment. Lens extraction, which is clear, and not cataract is not justified as of now. Early identification and proper management is key to prevent blindness because of chronic angle closure glaucoma. Thank you.
Thank you very much. Ahmed, do you want to ask something? Dr. Borwal?
Yeah, good evening, sir.
Ahmed, do you want to say something on this talk? Or
I thought you were asking Amia, so I was keeping quiet. Actually, excellent talk, Ankur. It was nicely covered. And the most important thing which you highlighted was the role of lens extraction. I mean, there's a bias. Everybody justifies the Eagle study, the non-glaucoma specialist, and they want to do early lens extraction to treat angular closure at glaucoma. So very nicely covered up the whole topic. And the key message what is delivered is lens extraction is not an answer as a treatment for angular closure glaucoma. You have to do a LPI. That's what I would like to say.
Okay, good. So Ankur, very nice talk, and I will never forgive you, because even as a student, you do not quote my papers which talk about peripheral iridoplasty, both for acute and for chronic angle closure, which are published papers. So
it was very nice. The Desi evidence is what he mentioned. Desi evidences.
I'm going to, yeah, that was the best part of it, the Desi. But I have to catch him for that.
Sir, we have do have a question for Dr. Manish Singh.
Yeah.
When will you advise cataract surgery and NVG is the question.
I think in a patient with NVG, our primary aim will be to control the rubeosis and to control the intraocular pressure. Once you have managed it, eye is quiet, maybe you can keep a gap of 3 months or 6 months. If in case you have done a trabeculectomy or a shunt, you can keep a gap of 3 months or 6 months and then go for a cataract surgery. Although rarely in some cases with NVG where there is a significant cataract and we are planning a shunt surgery and the chamber is extremely shallow, we have removed the cataract also along with the shunt surgery. So that can be done, but mostly we do the control of intraocular pressure and do a cataract surgery later on.
Okay,
so
thank you,
3 to 6 months.
Generally 3 to 6 months.
Can I ask?
I think we take the questions later. Okay, please, if it is for Ankur, then we can go ahead. Is the question?
It was for Manish.
Manish, yeah, you are very popular. So go ahead, please. Go ahead.
Dr. Manish, how early means the sense that if it is an early cataract, can you go ahead with this neovascular glaucoma, or you want to wait?
Sir,
Did you get me?
Can you repeat the question, sir? What is the question?
If it is an early cataract, can we go ahead with removal of cataract, or you want to wait for a longer time? I
think we should wait. Like the cases which I shared, like there have been, like I had a patient with NS3 with cortical cataract. So if it's a visually significant cataract and you feel that removal of cataract may help you in surgery, then, for example, I give an example of a glaucoma shunt surgery. You have a 360-degree synechia with a shallow chamber. There is no place to keep the tube. So if you remove the cataract, you can put the tube behind the iris over the lens. So those cases, a cataract surgery may help. But if it's a very early cataract, a cataract surgery will increase the inflammation, will actually worsen the prognosis of your trabeculectomy or a shunt surgery. So I personally believe your aim should be control the rubeosis, control the pressure. Once the eye quiet, after 3 or 6 months, you plan a cataract surgery.
So excellent, Manish. Very good answer. That ideally, the point is to control the NVG first. The cause of NVG must be taken care of first. And with an early cataract, neither the PRP nor those things will be difficult. If you feel those things are difficult, or like Manish gave you an example that putting him in a tube is difficult, yes, then you can do. So do we have Tanuj over here? Tanuj? Dr. Jansari
I'm here.
is not there.
I'm here.
Ah.
Mine is 4th, na?
No, Dr. Jansari is not there, so better.
Okay.
So please share your screen and please go ahead. So we are really looking forward to this talk because Tanuj does most complicated surgeries. And so we'll really love to see this. You want to... okay.
My screen is visible now?
Yeah, good. Perfect. Go ahead.
Okay. Let me start my stopwatch first.
That's okay, don't worry. We'll catch you.
Okay.
And tell Dr. Vaidya to catch you if you go too much overboard.
So I have no financial disclosures, and I thank Manish Sir, most sweet, humble glaucoma specialist, and this you can't refuse his invitation. So I'm presenting. So this is a patient, 40-year-old patient who came with pressure of 2 millimeters of mercury, pseudo-phakic patient, cricket ball injury. So multiple referrals. well-formed AC on the eye looks quite nice, but with 2 millimeters pressure, and patient is reporting that post-cataract surgery vision was good, but his vision is now 20/200. So you have to intervene in such cases because otherwise he is going to lose vision. And on gonioscopy, you can see the problem is that there is a large, nearly 180 degree of cyclodialysis. That means disinsertion of the ciliary body from the sclera. So that is causing the hypotony, and there is no conservative management in these cases. You will have to open up and suture the sclera back, sclera and the ciliary body together, and you can see the hypotony maculopathy that the patient is having. And you can see on UBM, although the gonioscopy was diagnostic, large cyclodialysis cleft, disinsertion of ciliary body from the sclera. So the aim is to close this cleft. So this is the surgical video. You have to do intraoperative gonioscopy to localize the area, and you can mark this area because after you put the traction suture, it rotates. So you should always mark the area, and then you have to expose the entire area. Because these eyes are hypotenuse, it is better to put a viscoelastic, otherwise dissection is difficult. So now, like you do in a trabeculectomy, you are making a lamellar scleral flap. Now I told you this is a very large cyclodialysis. And then this is very critical. You have to, this is the endo-illuminator I am putting at the limbus. And see here, this is the area of this, you can see black here, and this is the area of the detached ciliary body. So through trans-illumination, you can see this area is showing illumination. Ideally, the ciliary body should have been present here. So you can localize your area of, and then what you have to do after you have raised the lamellar scleral flap, you have to make a full thickness entry and expose the ciliary body. Now, because this is a very large cyclodialysis cleft, so I have repaired it in parts. I have done this flap, but not opened the entire thing because it's become difficult to suture. So I've opened the 50%, and you can use 10-0 simple suturing or 9-0 Prolene. So the basic technique is that you have to suture the sclera to the ciliary body and back to the sclera. And ideally, you should first pass the sutures and then tie. Then you are sure that you have included the ciliary body in all your sutures. So multiple applications, sclera, ciliary body, and then I'm opening the other half. And similarly, you suture the entire opening, and now you see the difference. This entire area has turned black now. So that shows that your repair has been successful and the ciliary body is now relocated and attached back to its normal position. And after you have done this, to be extra sure, you apply 5 seconds of cyclocryo basically to induce inflammation, so that in between the gaps you have left, there is inflammation and closure. Then you close your superficial scleral flap and close the conjunctiva. So with God's grace, we could manage this patient post-operatively. And this is 1 month post-operatively. His ciliary body is reattached. You can see the closure of the cyclodialysis cleft. And we were very lucky. The patient regained 6-time vision and was very happy. This is another interesting case. This was a case referred, and patient appeared to be had hypotony and no leakage. This was nearly 2 months after surgery, and there was no leakage, obvious leakage visible. But when we did the UBM, you could see a large area of aqueous reservoir. So that means shallow AC large, there is an over filtration occurring, although there is no obvious leakage. So in such cases, you have to go in and explore and see what is going on. So traction suture has been applied, and this is the area of the trabeculectomy that has been done. A little bit of xylocaine application. And then you try and dissect and see. You have to open up the entire trabeculectomy bleb. And now you have to see from where is actually the leakage occurring. And now I'll put the Tri-Pen blue. And I'm just taking off the episcleral tissue. And now you see, when you put trypan blue, you can see there is a large defect. So here, this area. So excess cautery has been done. The flap has, there is a shrinkage of the flap. And on the lateral side, this area is leaking very profusely. This was under the episcleral tissue, so we couldn't make out. So only when you explode, you could make out this area of defect. So then we thought of a innovative technique. This area we have to cover, and that time we had not arranged for the eye bank sclera. So what we did was we raised a lamellar scleral flap from the horizontal side and reflected it on to the area where there was a leakage. So just see again, this is a crescent knife. So you are you're dissecting it and then reflecting the flap onto the area from where you saw there was leakage. So this is like a transverse Momini's repair. And then you apply sutures and close this area. And good thing is that your posterior filtration is still okay. Because if you close this area, then it will go other way around, it will go high. So you have done a transverse repair and the posterior filtration is still intact. So this is a case which was repaired, and then you check this leakage from here has been completely sealed. And then you have to close the conjunctiva. And in this particular case, we are using the Ologen implant because you can't use mitomycin C and you want to prevent the post-operative fibrosis to some extent because a very young patient and you have to have the trab function for a long time. Although now we have stopped using the Ologen implant because long-term results have not been successful. So this is the repair being done, and this is the post-operative appearance, and the bleb has been repaired, and we are successful in treating the hypotony, and this is the repair of the patient. So now I have reached 7 minutes and 45 seconds, and this is the AS-OCT of the case. So I'll just stop here, and thank you very much.
That was absolutely wonderful, Tanuj. But at least the cyclo one, I think it is safer to refer to you than to try and do it ourselves. So, Dr. Vaidya, any comments you want to make? Deepak? Dr. Ameya?
The most important thing is to do prayer before you operate these cases and after post-op also.
Sir, I think these presentations should come with a warning. Do not try this at home.
No, but
I have a question to Dr. Tanuj. I just wanted to ask at how many degrees of cyclodialysis you will consider for taking to surgery? I mean, is it only the number of clock hours of cyclodialysis cleft which is taken into account, or the IOP also as an indication for cleft repair surgery?
If you have a very small cleft like 1 clock hour, you can attempt just cryo or laser. But whatever I have done in my practice, they have been more than 3 clock hours. So I've had to open and close them because it's a one-time surgery and very massive dissection, and you don't want the patient to come back. Other techniques have also been described. If you are doing cataract surgery, along with that, you can put an endocapsular ring and that can tamponade on it. But I find the open repair with transillumination, that is a foolproof technique, and that is you should adopt for majority of the cases.
Can I add something? This is Dr. Ganesh.
Yes, please.
Thank you, sir. If you don't have access to a illuminator, you can use the microscope and half illuminate the eye. You can still see a transillumination.
Yes.
That technique is also you can use.
Yes, even a small pen torch you can use. That is not an issue. You can
or
see
the
the
light of
body.
indirect from the other side or something.
Yes.
Tanuj sir, one small question on the case. When you're suturing the ciliary body to the sclera, you are using what kind of a traumatic needle, or you're using the spatulated needle?
No, 10 spatulated needle. I'm using 10-0 without, there is no need for any special suture. Some people also advocate ninoprosine, but I have used just a 10-0.
But the ciliary body doesn't bleed at all in this.
No, you saw, these are, old cyclodialysis. So I've seen there is no bleeding. Only thing is when you dissect, you have to be careful. You don't puncture it when you open the ciliary body with a sharp knife. That is the only precaution. It doesn't bleed.
Okay,
Tanu
thank
sir,
you so much.
Tanu sir, 1 second. Can I ask you one question?
No. Time.
Okay, fine. Go ahead.
Okay, Vedya, last question fast.
Yeah, what about the proline suture and nylon suture? Over which we will prefer if you are going to suture with 9O, proline or nylon?
No, preferable is proline suture. If patient you can get, that is preferable, but don't use the long needle one because that becomes problematic while suturing. It is very difficult to manipulate because you require only small area hitch of the ciliary body.
Okay.
So use a regular needle, not the long needle one proline.
Okay, thank you.
Okay, George, you are there? George? Is George Purthan there?
He was here only. Yes.
Yes, sir. Yes, sir. I'm here.
Please go ahead, George.
Yeah. So thank you very much, sir. So I will try to cover the indications and surgical technique for sulcus placement and vascular tube insertion of aqueous drainage implants in our hands, because this is not very frequently done. Yeah. So the main indication is of a sulcus placement is anterior PAS, and most commonly seen in post-keratoplasty eyes. So even in a phakic eye, you can get this tube safely into the sulcus because the iris is plastered to the. In many of these cases, the iris is plastered to the cornea, and obviously the advantage is that your tube is as far away from the endothelium as possible. Again, situations where you have anterior PAS in secondary childhood glaucoma, like Axenfeld-Rieger syndrome. Some of these children with congenital cataract surgery, glaucoma following congenital cataract surgery, also may have focal areas of PAS where we can take advantage to place these tubes in the sulcus. Again, iridocorneal endothelial syndrome is also an indication when there is anterior PAS to get the tubes into the sulcus. Dr. Manish was mentioning this after NVG, combined cataract and tubes, you can place these tubes safely into the sulcus. So the surgical technique is not very different from your usual anterior chamber placement when you have anterior PAs, because the tip, that dramatic change from the needle entry being sclera parallel to the iris parallel occurs almost at the same point, because the iris is plastered to the endothelium and your sulcus is quite wide. So this is an Axenfeld-Rieger where the tube goes into the. I think there is some disturbance, but now the challenge. Now the challenge for sulcal placement of tube occurs in eyes with high PAS on gonioscopy, but anterior chamber looks almost of the normal depth. The issue here is if you have to get it into the anterior chamber, the tube has to pierce through the iris, and we have some measurements. We use these 4 mm scleral needle tracks to insert tubes into the anterior chamber, and we have some measurements where we feel that it's between this 2.8 to 3 millimeter areas where we dramatically change the entry at the limbus to get it nicely positioned in the anterior chamber. And so, to give you an example of sulcus placement in an eye with high pass. So this is the mental calculation we have to do. Where do we dip into the anterior chamber to get the needle track into the sulcus? So the 23 gauge needle track needle is advanced, and if you see carefully, it is this. Once we reach this area, that is just about 2.8 millimeters. We rotate the eye slightly forward and dip and dramatically change the position to become iris plane parallel, but the needle enters the sulcus between the iris and the PCI. Actually, there's a little bit of posterior synecdoche onto the lens, so it will have to be released. So another thing we have observed in any, even in anterior chamber or sulcus placement, if you trim the tube to whatever length you want it in the anterior chamber, Like in this case, we are planning for about 3.5 millimeters. So if you drape the tube over the cornea, trim to 3.5 millimeters, and place this tube 2 millimeter medial to the original position of the tube, you can rest be assured that you still get 3.5 millimeters of tube in the anterior chamber. So a little bit of help with a paracentesis and a cyclodialysis spatula will easily get the tube has reached there because of the posterior synechiae. It is still not visible. A little bit of manipulation there, and you can easily get the tube into the sulcus. And you won't get too much of bleeding here. So I know that there have been techniques described where surgeons do a peripheral iridectomy and then try to place the tube through the peripheral iridectomy through the sulcus. You can take advantage of any pre-existing surgical PIs to get the tube in the sulcus and flat on the iris as far away from. For example, this eye had a PK. Now coming to pars plana tube insertion, some of the most common indication for us is you're planning a concomitant VR surgery, and that too in some of these bad siliconoid glaucomas that we have to. The glaucoma is refractory, and you plan for a tube insertion also along with siliconoid removal. Another indication for pars plana tube insertion is even some of these eye syndromes, they don't have adequate space for even a sulcus placement. Here we have to do a lens sparing vitrectomy and keep the tube into the vitreous cavity. Some of these phenophakic lenses where we have to combine vitrectomy, lensectomy, and pars plana tube insertion. And a short video on how the pars plana tube insertion is done in our hands. We mark 3.5 millimeter of the tube anterior to the limbus, trim it. Everything else is the same except for the two venting slits were already placed here, and now the vitreoretinal surgeon takes over. So he does a complete vitrectomy. See, you can see a lot of anterior PAS, absolutely flat chamber, a complete vitrectomy, and then one of the port, the supratemporal port near the tube is used to insert it can be a 23 gauge, it can be a 25 gauge, doesn't matter. The tube just is easily inserted into the vitreous cavity. And also we need to inspect for proper positioning. Here, the tube is clearly seen in the vitreous cavity. Sorry, I'm just not able to. Okay, so now in previously vitrectomized eyes, you can also take advantage, especially if the conjunctival mobility is very poor at the limbus. You yourself can use, we glaucoma surgeons can just use a 23 gauge needle. Only thing is it has to be perpendicular to the globe, and it just goes in and comes out. The bevel of the needle just goes in, comes back. Again, we need to ensure that the tube is seen post-operatively so that it is not inadvertently placed into the choroid. One very important prerequisite is that you need to have a complete pars plana vitrectomy for pars plana tube insertion, because any minimal vitreous left behind, even the vitreous base should be adequately shaved to facilitate pars plana tube insertion. Otherwise, you will have situation like this where we had to do a re-vitrectomy. And for anybody who's interested, we also have published our results of pars plana tube insertion 2 years back in the BJO, which will give you more clarity on the indications and the surgical technique. Thank you very much, and I would specifically like to thank Dr. Manisha for this wonderful opportunity. Thank you very much.
Thank you, George. Listening from the master and the innovator, it is really great. It is really nice to hear your views on this. Anybody has one quick comment? One quick comment from anybody, because I don't think really there's much to say on this because he's so perfect. And so you, like you rightly said, George, that sometimes going through that route will give rise to bleeding and all. And people who are like me and you who are used to doing posterior valves may sometimes choose to do that unless, like you rightly said, there was a synechial formation over there. So rightly, it's not a very commonly used thing. Anybody else, quickly?
George sir, one small question.
Yes, Sachin.
Of late, you stopped using the donor cornea and scleral patch graft because of the posterior tube insertion. Am I right?
Yeah, totally.
So, but how posterior is it safe and that the tube does not erode?
See, Sachin, the tubes do not erode 4 millimeter posterior to the limbus. If you have seen, all those tubes which erode are close to the limbus. Very rarely do they go. So having a 4 millimeter scleral tract is sufficient, and you don't need to use the patch. But the key is to have an adequate depth of the sclera also, so that your tube is well buried in patient's own sclera.
Okay, so in that case, when you are using the needle track, it is sufficiently long, say around 2.5 millimeters scleral pass followed by the dip inside. So in that, do you need a larger gauge needle to negotiate the tube, or is the same 23 gauge needle enough?
Yeah. 23 gauge needle makes a track into which tubes of all glaucoma drainage devices usually snugly fit without peritubular leakage. But I think some surgeons prefer to have 22 gauge at the entry. But we prefer 23 gauge throughout.
Okay, thank you.
Thank you, sir.
Thank you, George. Ahmed, please go ahead and share your slides. And he'll be talking about a very, very common subject, cataract and glaucoma together. Thank you, George, for a wonderful thing.
Thank you very much.
Thank you, Harsh, for inviting me for this talk. I thank Dr. Manisha, Team BOA, and Team MOS for including me in this great scientific fest. So today I'm going to talk on coexisting disease, that is cataract and glaucoma, which is most common. So we all know that both the diseases are most common conditions which are associated with the aging process, with an increased risk of nucleosclerotic cataract with elevated IOP and glaucoma medications. So modern cataract surgery has become one of the most successful rehabilitative microsurgical procedures. But when we look at our success in the management of glaucoma, either medically or surgically, it has not yet achieved the similar results what we have achieved with a cataract surgery. So the patient's expectation is a functional result similar to that achieved with the modern cataract surgery. So proper counseling is a must when we are dealing with these patients. So how do we manage these coexisting conditions for the best possible outcome? We all know that the surgical correction of visual disability cataract will not rehabilitate the glaucomatous loss of visual field and visual acuity. So initial decision making is crucial in determining the type of intervention in these coexisting diseases. So basically there are three surgical approaches. First approach is the cataract extraction with IOL implantation alone. Second is the sequential surgery, wherein you do a trabeculectomy alone, followed by cataract surgery. It is also called the two-stage procedure, and then you have a combined cataract and glaucoma surgery in the same sitting. So what are the indications for cataract extraction alone? Especially when you should have a visual disability cataract with IOP under good control, you should have mild glaucomatous damage, minimal visual field loss. A patient is on 1 or 2 well-tolerated topical anti-glaucoma medication, and also he is compliant with the anti-glaucoma medications. The advantage is there's a long-term IOP reduction of up to 5 years. There's less need of post-operative medications, and there's a small reduction in mean IOP by 1 to 3 millimeters after the surgery. Disadvantages being with an early post-operative IOP rise in these patients with pre-existing glaucoma, especially in the first 24 hours and maximum within 2 hours after the surgery. So you need a close monitoring and proper medical treatment to control this IOP. Then you have the two-stage procedure, that is a sequential surgery, wherein you do a trab first, which is followed by cataract and IOL later on. So what are the indications? In this, the glaucoma dominates the clinical picture. There's a significant optic nerve damage, there's an advanced visual loss. Patient is an uncontrolled glaucoma despite maximum medical therapy and laser trabeculoplasty. The advantage is it eliminates the need of anti-glaucoma medications and improves the quality of life and vision enough to delay the cataract surgery. In some cases, cataract surgery can be done 4 to 6 months later on once the filtering bleb is well established. Disadvantage, basically it needs 2 separate surgical procedures. Filtering surgery might hasten cataract development, and cataract surgery might have an adverse effect on the pre-existing filtering bleb. Then you have the triple procedure, that is a combined cataract surgery and combined cataract and cataract extraction glaucoma surgery. Indication being patient should have visually significant cataract with glaucoma under borderline control despite maximum medical therapy and laser trabeculoplasty. Adequate IOP control but significant drug-induced side effects. Glaucoma with history of non-compliance with medication. Is an adequate IOP control on well-tolerated medical therapy but advanced glaucomatous optic atrophy. Is an uncontrolled glaucoma and urgent need to restore vision or when 2 operations are not feasible. So advantages, we all know that it eliminates the need of 2 separate procedures. The early postoperative IOP rise is significantly less. There's a significant improvement in visual acuity. At the same time, IOP is being addressed and there is decrease in the number of glaucoma medication. So when we look at sequential surgery versus combined surgery, sequential surgery is better than combined surgery or vice versa. There is insufficient evidence to support this concept. The decision as to which option is to be adopted should be based on the specific clinical scenario and the comfort level of the surgeon after discussion of the options available with his patients. So we all know the preoperative consideration. As I told you, we should know what is the real cause of vision loss. We should do a proper slit lamp examination to look for the pseudo exfoliation, shallow AC, myotic pupil. The fundus examination should be done properly. The techniques of handling myotic pupil, basically, we all know that most of these people have irreversible miosis. So we should be prepared with rings, hooks, or expanders. If you are doing an SICS, stretch pupilloplasty, microspheroidectomy, viscoelaxation, sodium bicarbonate is a viscoelastic substance of choice. It should be thoroughly washed at the end to avoid any post-operative IOP spikes. HPMC causes less post-operative elevation compared to this high-density viscoelaxations. Adequate trachis and IOL selection. A big no to AC IOL. The rest all the other IOLs can be implanted. So the techniques: cataract extraction, that is the sequential surgery. Cataract extraction incision should be positioned to maximize the bleb survival. Cataract extraction site depends on the location of the filtering bleb. Temporal location is preferred. Phaco with foldable IOL to a clear cornea incision with or without surgery is the surgery of choice. Cyclodialysis should be done if any cyclodialysis is present due to previous surgery. And intraoperative complications, especially vision loss, have been associated with bleb failure. Triple procedure, you have the single site and the two site. Single site, basically both the procedures are done at the same site, and twin site, you have the superior trab and the temporal phaco. So just showing two small video clips of single site surgery and the twin site surgery. So I have the single site surgery. I'm showing you an SICS plus trap, and the two site surgery. Some problem with the. Just give me 2 minutes. I think videos are. In the meanwhile, Dr. Ash, can we take 1 or 2 questions? I'll just make sure that the video is shown. This is a 2-minute video. I think the system is getting hanged at my end. Dr. Harsh?
Yeah, Sachin, any question for Ahmed till he opens his video? Anybody else? Medha? Vaidya?
May I ask something?
Yeah, please, sir.
Yeah. When you are doing combined surgery and when you are using mitomycin C, what specific precautions you take so as to avoid mitomycin C going intraocularly?
Should I answer this question?
That's for you only.
Yeah, okay. So one important thing when you're doing a mitomycin application is you should always use a wet sponge. You should not use the cotton swabs. You should make tiny cuts of the wet sponges. You should always count how many wet sponges you are implanting subcongenitally, and you should count while implanting, and you should also count while taking it out. And once you're taken out after the desired time you have put, you should wash thoroughly all the mitomycin which is there. At least what I recommend is 30 ml of RL should be used to wash thoroughly on either pockets, on either side of the lateral and medial pockets, and also posteriorly. You should try to wash it. So this is very important. You should not use cotton swabs, because if you use cotton swab, any cotton fiber remains behind, then that can cause complications due to mitomycin.
So what basically I am doing is that I am doing the trap part first. So the mito is done, everything is made. There's no entry into the chamber. And once you wash it off nicely, then you can go ahead with the cataract part. But some people who are doing together, it may be a little different. Amit, are you getting your videos?
Yeah, I'm ready with my videos. If you want, can I just?
Yeah, go ahead, please.
Yeah. So this is the top video which I'm showing is basically the SICS trap, and the bottom video is a phaco trap. So initially, whenever you plan for this combined surgery, you should always take the traction suture properly. Whether you want to take a corneal traction suture or the superior traction suture, you should have an adequate traction suture. Always use a caliper and measure the site of the limbus, how much big you want to make the congenital flap. So when I'm using an SICS trap, I make a 6.5 millimeter or 6 millimeter congenital flap. I mark it on the conjunctiva and the limbus. And when I'm doing a phaco trap, I usually mark 4 millimeters on the limbus. So marking is very important because that shows how big your flap is. Then do a clear-cut subconjunctival dissection. Always make sure that when you're doing the subconjunctival dissection, there's a diffuse dissection posteriorly and on the medial and the lateral side. You want a diffuse bleb, so dissect as much as possible. And when you're doing the cautery, use a gentle cautery. You already see what complications can occur due to excessive cautery. So identify the bleeders and just cauterize the bleeder. You should have adequate cautery. You should not over cauterize it. Next is again marking the scleral flap. You should always mark the scleral flap on either side of the limbus, and then using a 15 number blade, I make a triangular flap. That is the preferred flap of the preferred shape of the triangle, the scleral flap which I planned. And you can see whenever I'm using a mitomycin, I use a waxed sponge. I count the number of sponges which have been used, and then after you have removed, you wash it thoroughly, brush the conjunctiva, so whatever fluid is remain, it is ironed up properly, and then again remark the scleral flap, and then do a scleral dissection. Tip for scleral dissection means you always hold the tip of the scleral flap, raise it up with the help of forceps, and just touch the cutting edge of the 15 number blade at the traction side. So the moment you pull the scleral flap, just touch the blade and there's a cut. So by doing that, you get a uniform scleral flap. So once the scleral flap is there in SICS, what you're going to do is you now start the normal manual small incision cataract surgery steps, what you're used to it. So take a crescent and start doing an SICS tunnel, and then all the steps of SICS are followed. When you're doing a phaco trap, that is a twin side surgery, once you've created the scleral flap, then from superior side, you have to shift to the temporal side and then start with the clear corneal phaco or scleral tunnel phaco, whatever you're used to it. I prefer clear corneal phaco. And in this case, as I told you, we always come from, most of the time we come across small pupil, non-ready pupil. So you have to be ready with any pupil expansion devices which you are going to use. I prefer the pupil expansion devices than the iris hooks because I don't want to have too many cuts at the limbus to insert these iris hooks. So rest the cataract surgery procedures are same what you are used to it. So because of paucity of time, I won't go much in detail of the cataract surgery. So coming to the once you implanted the IOL.
No, I think you're way above time, so I think we can just finish it off.
Okay, so I just
questions. I think this is standard. You have shown well, and you have shown the SICS, which was more important. Because I think everybody is doing this. Thank you very much.
The important is releasable sutures. How to do the releasable sutures. Thank you, sir.
Okay, wonderful. And I think we had the question. We have time later. We can discuss. Come back here and discuss some of the other questions because this is an important topic. So I think Ganesh, you are there.
Yes, sir. I'm here, sir. I'll share my screen.
Yeah, please share the screen.
Yeah.
And you are doing this surgery yourself right now?
Which one, sir? The non-penetrating deep sclerotomy. Yes, sir. I'm doing that. Before at the outset, I'd like to thank MOS and BOF and particularly Dr. Lahane sir and Manisha sir for giving me this opportunity to speak to you on non-penetrating deep sclerotomy. And we all know trab is the procedure of choice, and deep sclerotomy is a lot of
his voice. Can you hear us, Ganesh? You're not. I think there's a
network issue at his end.
His voice was anyway not coming well. But now till he unshares, we can't even move forward. So can somebody ring Ganesh? Ameya, can you ring Ganesh? Anybody who has got Ganesh's number?
I think his Wi-Fi has gone. Ganesh's Wi-Fi has gone.
No, but he has to remove the thing from there, na? Otherwise we cannot even proceed.
Okay.
Yeah, good.
Ganesh, your Wi-Fi is not working. He's not there, side.
He's not there?
I have called him up.
Now you can take next one, na?
Yeah, so sir, I will start this thing, and by the time he comes, then we will take his lecture.
Yes, good.
Amit. Thank you, Dr. Amit.
Okay, are you getting my slides?
Yes, sir, your slides are visible.
Okay.
Thank you, Ragini ma'am. Thank you, Rani sir. Yes, sir, it is visible.
Okay, fine. Let's go ahead then till George comes back into action.
Ganesh.
So I think
Ganesh, sir.
Ganesh.
Okay, we'll go ahead with the first slide, and this is a young 22-year-old one-eyed girl who came to us. The other, she had uveitis. The pupil is stuck. Multiple PIs were tried, which were failed. So there's an iris Bombay. The pressure is 28. There is a posterior subcapsular cataract. She cannot see through it. The vision is barely 660, and that too bad. The other eye surgery had been done, and the eye was lost. So she was not ready to touch this eye at all. And that is when we thought so much what to do, because she was not ready for the surgery. So this is how the YAG laser iridolenticular cyclodialysis were born, in which what we do is we stretch out by giving the phenylephrine, and then in the area which is now, this is a normal lens underneath. So we just hit the synechium near the iris, starting inferiorly, going on either side up, and it takes almost 4 to 5 sittings, because the area bleeds, and then you move on and the area bleeds, and then there's a lot of haze and you can't do it in a single sitting. The power to be used is very minimal, 0.5 millijoules, but it is possible, and what ultimately you find is that the pupil dilates fully, and therefore no need for the iridotomy, because the thing is now leaking from here and the pressure becomes good. And not only that, because the pupil is dilated, she could see the things from the side. So this was a procedure given for the first time in the world literature. And beyond that, the smile on that lady's face is something which will stay with me forever. And in the hard times that we have in glaucoma so commonly, it really helps. So you can see how it really works wonders. It's a difficult procedure, but not really so difficult. If you hit on the synechium towards the iris side, the lens really never gets damaged, because the power that you're using is very little. Another case that was referred to us is like what Tanuj was showing. There's a diffuse bleb, and there's macular hypotony, dysesthesia. So one part obviously is to take the patient for surgery. But short of that, can we do something? So we said, okay, let's try out something. So what we did was we painted the bleb with gentian violet. And then what we did was that we started putting spots which are large. That is 300 to 500 micron argon spots. You can use any, you can use a diode, any photocoagulative laser, which will scar out the superficial conjunctiva. And so in that case, what ultimately happened was this whole thing, this got scarred. And because it was scarred, the whole fluid absorbed. It absorbed from here, and you can see how beautiful the thing becomes. And what was a huge choroidal absorbed by itself completely in itself. Again, if there is a superficial bleb like that, which is forming a Dellen, the patient is having a lot of problems, you can actually take to the OT, and you can cause them do these sutures. But short of taking to the OT, what you can do is a similar procedure. You can paint it with the gentian violet, and then give the things which exactly like we showed you with the argon laser, and you can see it flattens out nicely. Now, one of the most underrated technique is the peripheral iridoplasty, but I can promise you, I have given it, and the last time I came to Bombay, one of the girls stood up and told me that, yes, I tried and it worked so beautifully. Most of the people are just not trying. All you have to do is you have to give a large spot, the same 300 to 500 micron of any argon or frequency doubled ND YAG. The idea is less power, wider spread, and less time, so that it just scars superficially and opens up the angle. Now you can use it either with a gonioscope, or you can even do it directly. And what basically happens, it's a classical thing for plateau iris. So that in the case of a plateau iris, what is happening is that even with a patent PI, the whole thing is getting closed up once the pupil dilates. In this kind of a situation, what you basically do is that what I showed you, you put a larger size, 300 to 500 microns on the edge of the iris just near the root of the iris, and you can put multiple spots over there separated by one spot size. You can do it through a gonioscope. Previously you can do it directly. So these are the ways to do it. Extremely simple. Anybody can do it. There's hardly any side effects, so nothing to really worry about. And this shallow chamber, as you can see, the angle really opens up nicely. The same thing you can see in an anterior segment OCT, how the angle deepens up. But the greatest benefit that I found was it's a lifesaver. So we had this one-eyed patient, very fussy, very elite, and came with a pressure of 48, had been to multiple hospitals with a lot of mannitol, everything, nothing is sorted out. And obviously with the pressure of 48, the pilocarpine is not penetrating, nothing is going in, and short of doing a surgery, everybody told, okay, we can't do anything, we'll have to do a surgery. So I thought before that, can we try something? I suddenly remembered Dr. Lamb had given in 1998 that we could do a thing which will help us. And so we did through the thing only, we did an iridoplasty, and within 1 hour, this is the result. The entire pressure came down. You can see the cornea is totally cleared out. And later we were able to do an iridotomy and everything went well. So I want to tell you, every one of you can do it. It is the simplest of simple techniques. People just don't try it. Even in cases of intumescent lens, or there's a topimerate-induced ACG. Both these cases, cataract, you are going to ultimately take out the cataract, but for that time, even if you do this procedure, the pressure comes down and you have time on your hands. Same with topimerate. You have to take out topimerate, but till the pressure comes down, if other things are not working, this works wonders. Again, in cases of chronic angle closure glaucoma, the paper we published in 91, if the pressures are just partially controlled on full medication, if you add gonioplasty all 360 degrees around, and if the angle opens up at certain areas, the pressure can come down by almost 3 to 4 millimeters, and you may be able to control the pressure. So difficult PI, again, you can stretch out the iris from all sides, and by giving a gonioplasty kind of a spot on all sides. Again, you have made an iridotomy, but you are not happy. You just want to enlarge it a little bit, give one shot of iridoplasty kind of a thing on either side of the thing that you have already made, and it just widens up, as you nicely see. And it's used in malignant glaucoma also, where the basic idea is that the pockets of fluid can be broken open, but obviously it has to be done with a usually in cases where there is no lens as such. So we have a pseudophakia or aphakia, then only you can do a laser iridotomy or laser vitreolysis. So basically you use a lens, and the trick is that if there is a posterior subcapsular, the PCO is there, then the PCO, the capsulotomy must be done so that the fluid that you are releasing from the vitreous actually travels through the this thing, capsulotomy, and then travels anteriorly. And then the flat anterior chamber can actually become suddenly deep. So before you go in for a surgery, if atropine medications are not working, this is something that you must try. Again, one of the many a times the blebs are so much vascularized. So we just did direct argon laser on these vessels, and sometimes you can see that the bleb really becomes much better. Thank you very much for your kind attention. So anybody has any questions on this? Ankur is still there?
Presentation, sir. I just had a question. When you do laser iridoplasty,
Yeah.
for how long does it work?
Oh, it does work for at least 2 to 3 years easily, and sometimes even much longer. So sometimes once the peripheral areas are flattened out, you know, even in a routine iridotomy, if you have done an iridotomy, and you do a repeat gonioscopy, you find here the angle is still very close. And if due to Valsalva maneuver, the iris is going to keep touching the cornea despite a patent PI. And so in these kind of situations where you are not comfortable despite a patent PI, you can do this iridoplasty, and I do it very, very regularly. So there's no need to really talk to anybody or think that it is a plateau iris, because to actually identify a plateau iris with gonioscopy is, I think only Tanuj can do it. The rest can actually just read it and forget it. So it's a tough card. So it is really, really useful.
Yes.
So do use it, because so many instances it will help you. And the biggest fun is that there's no side effect to it. Anybody, has he joined? Ganesh has joined back?
Yes, I joined back. And sorry for the interruption. I think some glitch in the internet.
Yeah, okay, go ahead.
It got back immediately, but
yeah, please go ahead, Ganesh.
thank you, sir. Thank you. So I'll come to the, I hope my screen is visible now.
Yeah, fine. Go ahead.
Yeah, so I'll come to the indications. The primary indications are primary open angle glaucoma, pseudo-exfoliation, pigmentary glaucoma, intraocular pressure which is not medically controlled, and patients who are poor adherent to the therapy. Relative indications include glaucoma and aphakia and high myopia. As you know, these are very high risk for failure and complication if you do perform normal trabeculectomy. Indication include angle portion glaucoma, eyes with extensive peripheral antiacynic and neovascular glaucoma, iridocorneal endothelial syndrome. As been mentioned before, tubes are better options for these, or even trab. Scar conjunctiva, traumatic glaucoma angle recession, eyes with treated with argon laser trabeculoplasty are again not very suitable for this non-penetrating deep sclerectomy. So these are the basic steps. I'll come to the video. So you lift a superficial scleral flap which is 50% thick, and then you lift a deeper flap which is again 40% thickness. That means you're lifting about microns of sclera over the bed where the aqueous is supposed to form a lake. And then once you have gone as much anterior as possible, you strip the trabecular juxtacanacular tissue there, which forms the inner wall of the Schlemm's canal. And in this process, you have already de-roofed the Schlemm's canal. So, and then you can place a spacer device. These are the spacer devices which are available in the image. You can see it's a T-flex device. And you have the Aquaflow, the HeLa-Flow, the T-flex, and also PMA implant. These are sutured to the scleral bed. Of course, in India, we don't use spacer devices. We use normal Halon to just fill that area, which gets absorbed slowly. So just to show you a small video. So you lift the deeper scleral flap using the routine instruments which you have. The superficial scleral flap with the routine instruments which you have. We use a 15 number blade, but in this video we are showing you with a diamond knife. And once you have gone as much anterior as possible, you have to go dissect into the clear cornea, and then you create a deeper groove to lift the deeper scleral flap. Now this is almost the whole thickness is 90% thick, so you have to separate the scratch incision and see whether you are close to the choroid, and just about 100 microns above that. You cannot measure it, but you have to have a feel of it, and 100 microns above that you lift the deep scleral flap. As you go anteriorly, you are de-roofing the Schlemm's canal. Now Schlemm's canal is de-roofed, and the moment it's de-roofed, you start seeing the aqueous percolating, and then you cut the deeper scleral flap. Now that area becomes the trabeculo-Descemet's window, and then you strip the pigmented trabecular tissue from the trabecular meshwork area. Once that is done, you have better aqueous percolation, and then you close the superficial scleral flap. You can place implant as I mentioned, and you can inject Helon, or what we use is our sodium hyaluronate here, manufactured by Orolab. No financial disclosure. And once you inject, you find there's blanching to your left of the vessels. That means there is a pressure difference which is created. So you find blanching to your right also. So that means that area has access to the aqueous veins, and you have better. Once you inject the colostomy, part of the steps you can combine the steps also. And if you do are not very keen for knife dissection, you can always use a laser. This is a carbon dioxide laser assisted deep sclerotomy, in which you don't have to lift the deeper scleral flap. Once you have lifted the superficial scleral flap, the laser will do all the work for you. It will ablate the scleral tissue in such a manner that the moment aqueous starts percolating, the effect of the laser is not taken up and you won't ablate further tissues. So you find that the moment the laser is being applied, you find aqueous coming out through there. That area will not take up the laser. So keep going on hitting with the laser, carbon dioxide laser, and then once the superficial area is ablated, you find that the trabecular window is still intact, but there will be no perforation. There will be no, you can perforate, of course, if you apply too much of force or if you are not in the correct position. But if you're in the correct position, you won't have a perforation. It's quite safe, and this is quite popular. Also, Dr. Venkatesh does it in his advanced glaucoma patients. And then this is, of course, combined with a combined cataract and deep sclerotomy procedure. And the suturing same as previously described. And if you can also, you can introduce a probe. Not if you have a probe, you can, but we don't have one. So what we use is a 6-0 nylon suture or a 5-0 nylon suture, which Oralab helps us with a bulbous tip, the manufacturing give it to us. And then we introduce it 360 degrees into the Schlemm's canal, and then use a 9-0 proline tied around the bulbous tip, and then retrieve the nylon suture. This is also possible. So you have a 360 channelling of the Schlemm's canal, and once you have retrieved the suture, so you are actually increasing the surface area of the Schlemm's canal. Once you increase the surface area of the Schlemm's canal, access into that area is much better, much better flow. You can also cut off the deeper scleral flap and suture the superficial scleral flap. So this is the proline suture, 9-0 proline suture has come out of the canal, and you cut it. You can reuse the 5-0 nylon, but we don't reuse it. We dispose it off. We contour things, and we don't want any false passage when we do the procedure next time. So we tie the proline suture in such a manner that it creates a little tension in the Schlemm's canal. And when you can see the suture 360 degrees. You can see the knot in the near the superior portion, and see the suture canal very nicely, very nice to photograph and document. And once you have a suture tied it, deeper scleral flap, and the surgery if you want to. So intraoperative complication, number one is being superficial, so you won't find the Schlemm's canal. If you're too deep, you perforate the trabecular distal membrane. Initial learning curve would have a tendency to perforate up to 3%, which reduces to 3%. With experience, you can have small, round, linear, or transverse tears. Big transverse tears will cause the iris to prolapse, and you will convert into a trabeculectomy. Sometimes, if it is happening, you don't cut off the deeper scleral flap. You can do a trabeculectomy anterior to the deeper scleral flap. So, post-operative complications include hypotonic choroidal effusions, which are very small in the periphery because of the low pressure. Small hyphemas, because you have introduced the instrument in the Schlemm's canal and you induce hypotony, so there is blood regurgitation. IOP spice can occur, iris prolapse, transverse hemorrhage under the scleral flap. Malignant glaucoma has been described, but quite rare. Late complications include failure due to excessive scarring, progressive increase in intraocular pressure. Blebitis has been described. Cataract has a tendency to form, and sclerectasia if excess mitomycin C or cautery has been used. But in the literature, endophthalmitis has not been described. Two meta-analyses have been done. One mentions that the complete success without implant less than 21 millimeters of merger is 69%. Another meta-analysis done about 4 or 5 years later mentions the without implant the success 48%. With implant it's 68%, and with the anti-neutralized it's 67%. So success is not as good as trabeculectomy if you were to put it head to head, but in certain situations it's good. So to conclude, yes sir, that's
please.
Okay, sir. Thank you. This is Okay, thank you, sir. This is my last slide.
Before we conclude, I would
Thank
say
you for patient listening. Thank you.
There were 25 audience, out of which 7 were the officials. These figures may interest you. That is why I am telling you. 25 to 30 listeners, viewers, and 7 officials.
This is including the YouTube and this thing.
Sir, those are the statistics of the Zoom meeting which we are logged on currently.
Yeah, what you are seeing is
that is a Zoom meeting, sir.
Yeah, but
so
you will not see the audience in Zoom meeting.
Only those who are speakers.
These
are only speakers.
Only,
yeah.
Yes.
These are not the audience numbers.
Only the faculty link. This is so.
Yeah, they have a different platform.
So don't get disheartened at all. We always keep believing they are there, even if they are not there.
No, I am happy that we started on time and we are ended on time. That itself is a success.
We still have around 5 minutes till we get, because they are going to come at 5:15. So just 5 minutes. Anybody wants to ask Ganesh?
I would like to add. I would like to add something about mitomycin. We have made little innovation in this.
Yeah.
We cut the sterile, ethiosterile Shermer strips and then imprisoned into the mitomycin C just before starting the surgery, and we totally dried in the air. And those dried up impringed mitomycin C Shermer strips, which we can measure into 3 mm into 5 mm like that. We slip it behind underneath the conjunctiva. By that, there is no seepage of mitomycin C and touching to the conjunctival border or anywhere. We can measure about 8 to 10, keep it under the conjunctival surface, and then remove it. So they remain put there. So any other problem of mitomycin C is not there. This is a small modification which we have made.
But some mitomycin C potentiality, the potential of mitomycin C decreases very fast. The potency, it degrades very fast. So you have to use a freshly prepared mitomycin C solution.
Yeah,
in almost all cases.
Exactly. Just before starting the surgery.
Yeah, would it not be unpredictable, sir, once you dry it?
No, under surface of the conjunctiva is wet. So only that much area I will take up the mitomycin.
Okay, fair enough.
It's just an innovation which we did. There is nothing.
That's very nice, sir. I think we can all try that, and we'll see whether it works in our hands or not. But yes, that's a very good idea. Sachin, you had asked something about whether the tube is to be covered with sclera with.
No. We just asked Dr. George about. He doesn't cover the tube at all.
That is the paper that he has written now, which has come in. I have given a commentary on that, so you can read that later. But I'll tell you one thing, that especially for if you're doing an inferior valve, the superior valves are very good. With this they do well. But now I've been doing inferior valves for almost 10 years. So the inferior valves, sometimes if you have not covered, they tend to protrude out and extrude, and we all know that what bloody hell it is. So now all the inferior valves that I do, besides the covering with the top, our own sclera, the patient's own sclera, I'm covering the rest of the whole thing so that nothing at all is visible. This is just because in all our hearts, the thing is that the patient should remain safe.
Correct.
So, and we can keep trying things other than that.
Yeah.
Thank you very much, everybody.
Harsh sir, can I ask one question?
Yeah.
So Amit.
Yeah.
Amit, once you're going to do a combined surgery, how will you go about your EDOF and multifocal lenses?
I don't use multifocal lenses in my combined surgeries. I prefer a monofocal lens in all my glaucoma patients.
In case if the patient is going to opt for the multifocal, would you go at one go only?
No, I don't give him a choice of a multifocal lens. I don't give a choice of multifocal lens to a glaucoma patient.
Okay.
Yeah, I think that is very good answer, because I don't think we should use a multifocal in glaucoma patients at all. Because the moment the glaucoma gets advanced, they could be in serious trouble. So anybody else who wants to, Ankur, you have any defend you on this?
No, sir. No, sir. I also don't want to give a choice of multifocal lenses. In fact, I tell them that, as you said rightly, that if the glaucoma advances, we'll be in deep soup. So better to have monofocal vision lenses in the glaucoma patients.
So Lahane sir, you were saying something?
I think, yes, Sarj Kumar, I was saying that we always avoid the multifocal lenses in the glaucoma, and we should avoid it. My question to every glaucoma surgeon here is: the patients with one eye blind by glaucoma and other eye 0.9, say this CDR, patient comes to me. By me, how I treat, I will tell you. When patient comes to me with 0.9 cup in one eye, blind other eye, I send patient to Manish.
Yes, that is the best treatment.
My God.
So just one thing, we can, multifocal reduce contrast. So we can increase other parts of the vision by anything, but we cannot increase contrast with anything. So we don't have tools for that. So that's why we are avoiding multifocals.
So I think we must thank all the panelists and everybody on the board. It was a wonderful, wonderful meeting, and thank you BOA for having us here. I think if Dr. Pandav is around.
Yeah, he's there. Good evening, sir.
Okay, Pandav, we can hand over to you.
Everybody.
Good evening, sir.
Yes, Pandav. Yes, Pandav.
Yes, sir. Dr.
Our Pandav and this PGI and JJ is a collaboration. We work together from near about now 10 years. It is compulsory that we should go as an examiner there, and they should come us. And whenever any conference, they will have to come compulsory to BOA. Without that, they are not permitted. Thank you, Pandav. Thank you. Go ahead.
Affection and respect that we share together with Dr. Lahane sir and his team and many other people in Mumbai. I think that's a great spirit. I think we all work in that, and that's absolutely fantastic. Knowing and have their blessings with us all the time.
Thank you, Harsh Kumar sir. Thank you all for being here in spite of the duties, the COVID, the relatives in the hospital. But it is science which kept us alive through COVID, and it is science which will, and you all as glaucoma specialists, because we are cataract surgeons, which is reversible blindness, but glaucoma isn't, and it is you all who keep the patient seeing. So thank you everyone, each and every one of you who were present in the session. All the teachers, all the stalwarts who took the time out to be with us and to educate us and to keep our patients seen. Thank you so much. And I pay my respect to each and every one of you from the bottom of my heart on behalf of BOA and MOS and Lani sir too.
Ragini, you also superb. You also great, Ragini.
Whatever the program is made, it is made by Dr. Agini, Sopnesh, Pritam,
Manish.
Glaucoma is Manish, cornea is Nikhil, then the squint is Hemalini, but these all sitting together, they are sitting together, working up to 1 a.m., 2 a.m., and then the program is there. And I think very good work they are doing.
We were UGs together, Manish, and we did PG together. And I'll tell you a secret. So Dr. Lahane sir has compartmentalized us very, very well. So sometimes when I'm looking at his program, Manish will say, "Shh, don't touch, don't do anything, don't spoil my minutes. You don't give me time for discussion. Don't touch, don't touch." So we are very possessive about our own programs, our own speakers, and everything, and that's how things come so well together. And of course, Swapnesh has been a warrior. He has joined, so he's the one who's evolving, changing books together. The youngest over here is Maya, who's working so hard. And I think Lahane sir, being a guru, Deepak Bhai, who's a BOA member, I think all of you, every one of you from all over India, who's a family and who've come together with Manish working so hard, Swapnesh, and I think Pritam, Pandav sir, Kumar sir, everybody, Dr. Putran sir, Dr. Ganesh sir, Dr. Ankur Bhaiya, Dr. Manish, Dr. Chandrasekhar sir, who has just joined for the next session, Dr. Pradeep sir, everybody, Dr. Hazari sir, everybody. I mean, it is you who make Amit, everybody who together Dr. Shekhar Paranspe sir, our senior from Sangli, our mentor. So I can't say thank you enough for giving Manish and me the opportunity, and Swapnesh and me, and Preetham and me the opportunity to work at these conferences. You all put all our mistakes apne man mein and give us blessings bhar ke.
I would like to just say one thing. This year, we are having the opportunity of voting for Sir for Vice President for AIOS, and it is our pleasure and privilege to see him elected. I hope everyone is the same.
No doubt about it. Absolutely.
Thank you, Manish. So I think Harsh Kumar, really thank you very much. It was a nice session. I heard everything. In between, I was not there for 5-10 minutes, but I heard everything. And because I also treat glaucoma, patient come to us, and then we are not having an actual glaucoma surgeon. So whenever patient comes to us, the normal we treat, and then some problematic we send it to VIP and problematic Manish. So, if there is any VIP Manish. So the session was very interactive, and thank you very much, Deepak. Amit, thank you, Amit. Thank you very much. Thank you, Ganesh. Thank you very much. Thank you. Thank you, Ganesh. So I will now hand over to the
Thank you, sir.
Pandav sir. Pandav sir, you go ahead now. Second. And others can sit. So I think there is enough space. Those who were faculty and moderator, co-moderator, chairman, they can continue if they want. And now Pandav sir can take over.
Thank you, sir. Thank you, Professor Lane, I think, for giving me this opportunity to chair this session. And thank you, Bombay Ophthalmologist Association, as well as Maharashtra Ophthalmology Society for this opportunity. I think it's time to start the session. So let me welcome all the chair and co-chair. We have Dr. Chandrasekhar with us, Dr. Vijaya, Dr. Reema, Dr. Upadhyaya, and Dr. Modawala in the chairs. And we have 6 very interesting topics in this session, and each topic will have it's kind of a debates. So each topic will have 2 speakers, pro and against, and 1 discussant. So thank you everyone for joining in, and I'll hand over the mic to Dr. Upadhyaya. You're moderating the session, so over to Dr. Upadhyaya for the proceedings. Welcome everyone once again. Thank you.
Good evening, sir. Good evening, everybody. Good evening, Lane sir, Ragini madam, and my seniors over here. This is the last session for today, but believe me, we reserved the best for the last. Yeah, we'll have debates. So our first debate of the day would be on pre-perimetric glaucoma, to treat or not to. We have Dr. Karishma Chavan, who would be speaking for to treat, and Dr. Pankaj would speak in the opinion to observe. Dr. Karishma, can you please start? You've got 6 minutes.
Yeah. Very good evening. I'll just share my screen.
Karishma, I'll be maintaining timing, and I'll let you know when you are close to 6 minutes, all right?
Okay, yeah. Just give me 2 minutes. I'll just start my screen. Is the screen visible?
Yes, it is visible.
Okay, I'll start. Yeah. A very good evening. At the outset, I would like to thank BOA and MOS for giving me this opportunity. My topic for today is pre-perimetric glaucoma in favor of treating my patients. So we know pre-perimetric glaucoma is the presence of characteristic optic disc fiber layer changes that strongly suggest glaucoma, but without field defects on conventional white-on-white perimetry. Just a minute, it's not moving. Yeah, so my first point of discussion is a normal perimetry really normal? So AS-OCT et al. Compared visual fields from pre-perimetric eyes to healthy eyes and found significant sensitivity loss was present, particularly in the nasal step and the germs area. Because there is considerable overlap in the receptive fields of retinal ganglion cells, there is redundancy in the coverage of a given location in the retina. Therefore, a non-selective test of visual function, such as an automated perimetry, may not be sensitive for very early loss of retinal ganglion cells. We also know that around 25 to 35% of retinal ganglion cells would need to be lost for an abnormality on conventional perimetry, suggesting an early disease. There was another cohort of patients that was studied in the diagnostic innovations in glaucoma study, and they found that a combination of test types may be more efficient in identifying early loss and confirming the area of the retina affected by glaucoma. So I think in a clinical practice, it doesn't really, it's not feasible and not even possible to subject a patient of this suspect to an FDT and a swab and maybe a CETA or a full threshold all at the same time. SAP uses a log decibel scale, which compresses data in the early stages of disease, making it really relatively insensitive to retinal ganglion cell loss in early disease. My second point, which I would like to put forth is only perimetry enough for glaucoma diagnosis? Or in other words, should I put it as, is glaucoma diagnosis based only on perimetry? Is clinical findings, OCT, HRT, and other supplemental tests useful? So I think, yes, they are useful. The Diagnostic Innovation Glaucoma Study is a longitudinal study that has been analyzing best methods to detect early glaucoma, progression, and effect on daily visual function and quality of life. So they studied that their patients with suspected glaucoma with baseline RNFL atrophy had a 4-fold increased risk of developing perimetric disease during follow-up. And those whose optic nerve showed glaucomatous progression over time had a 26-fold increased risk of developing visual field. So I think we really cannot neglect if we find any changes in our OCT. Also, confocal scanning laser ophthalmoscopy ancillary study of OHDS showed the risk for developing abnormal visual field was increased 9-fold in eyes with abnormal baseline optic disc topography. Ocular hypertension treatment study, 2 of the 5 described risk factors for converting to glaucoma, that is increased cup disc ratio and visual field pattern standard deviation, are nothing but surrogates of preperimetric glaucoma. So if you have a patient in a clinic with an increased cup disc ratio, we do not really know whether we are seeing him at a point of time which was stable, the optic disc was stable for all these years, or it is in the spectrum of an ongoing disease. High-risk ocular hypertension treatment study patients have a risk of 25 to 35% over 5 years for developing glaucoma. Eye drop treatment reduced the development of glaucoma by more than 50%. My third point is that, yes, we do have evidence to treat our preperimetric open-angle glaucoma patients. And in fact, those patients with disc hemorrhage and insufficient IOP should be carefully monitored for further risk of progression. As ophthalmologists, we not only want to maintain the vision, but also preserve the quality of life of our patients. Most of our ophthalmologists feel that the quality of life deteriorates once the patient has advanced glaucoma or the patient is partially blind. But I beg to differ that vision-related quality of life in glaucoma suspect or early glaucoma patients is also reduced, particularly for distance activities, driving, and color vision. Even collaborative initial glaucoma treatment study at enrollment, more than 25% of newly diagnosed glaucoma patients reported blurred vision, difficulty in adapting between light and dark environments, trouble seeing in dark, and problems with bright light. But the good news is that in preperimetric glaucoma, this vision-related quality of life is not impaired. So here we have a window of opportunity where we can treat our patients when they have just a structural loss and no visual field damage. So I would just like to conclude by saying that early glaucoma can undermine quality of life, and these changes cannot be reflected in traditional test data. It's not about IOP reduction, but about IOP modulation, where we want to blunt the effect of IOP peaks and IOP fluctuation. No treatment improves quality of life, I agree partly, but yes, and definitely I think it reduces deterioration. We have many safe one-time dosing preservative-free medications available, and I would therefore err on the side of caution and treat my patient. Thank you.
Thank you, Dr. Karishma, for maintaining the time.
Thank you.
Dr. Pankaj, can you please go ahead with your talk, please?
Yes, sir. Yes, sir. I'll share my screen. Yes.
Thank you.
Yes, my slides are visible?
Yeah, they are.
Yeah.
Okay. So preperimetric glaucoma, to treat or not to treat. So I will debate on observe side. So by definition, glaucoma requires definite disc changes and corresponding visual field changes. Till then, it is either ocular hypertension or glaucoma suspect. Now, ocular hypertension is IOP more than 21, no detectable visual field loss, no detectable optic nerve, optic disc or nerve fiber layer damage, open angles, and no ocular or systemic cause for increased IOP. Now, the OSTS study had this primary goals to evaluate the safety and efficacy of topical ocular hypertensive medications in delaying or preventing the development of POAG in individuals with elevated IOP. So that was the OSTS entry criteria, age between 40 to 80 with normal visual fields, normal optic disc, and untreated IOP in one eye between 24 to 32 and 21 to 32 in the fellow eye. Now, this phase 1 of OSTS started in 1994 with the eligibility criteria which I just mentioned, and patients were randomized into medication group and observation group. Medication group, the IOP was lowered by 20%, and observation groups, no topical medications were given, and they were monitored serially with Humphreys perimeter and the stereoscopic disc photograph. Whenever there is a reproducible abnormality like 3 consecutive visual fields or 2 consecutive optic disc photographs showing RNFL loss for disc hemorrhage masked by 2 observers, and then that was called as the endpoint when the case was labeled as converted into POAG. Now, this was the baseline characteristic with the IOP of 24.9 was the average IOP in the OSTS studies. So now this OSTS phase 1 had a cumulative proportion of developing POAG by race, and the data analysis shows 12.7% of POAG endpoints in the observation group in African Americans, 6.9% POAG endpoints in the medication groups with a hazard ratio of 0.54. For others, it was 10.2 POAG endpoints in observation group and 3.6 in the medication groups. Here, p-value was not significant. Now, OSTS phase 1 summary shows medication reduced the IOP of 20% from the baseline, and medication reduced the incidence of POAG in OST participants from 9.5% in the observation group to 4.4% in the medication group. So definitely it has reduced the risk of development of glaucoma by 50%, from 9.5% in observation group to 4.4% in the medication group. But there was few questions that remain unanswered with OSTS 1. So that's why OSTS 2 was started. OSTS 1 phase 1 gave us the proof of concept that medication slightly reduces the incidence of POAG, but it does not indicate when medication should begin. OSTS phase 1 does not indicate if all the OST patients should receive early medication, and is there any penalty by delaying the medication, whether patients is having any penalty to pay by delaying the medication. So with that rationale, OSTS phase 2 was started in 2002. Now the original group which was on medication was continued on the medication, and the other group which was on observation, now that was also started on the medication. Now, OSTS phase 2, after the 7.5 years of observation, the participants which were originally randomized to observation group now were started on the medication. So this created 2 groups in OSTS 2, OSTS phase 2, delayed treatment group and early treatment group. So now delayed treatment group was the observation group followed for 7.5 years and then treated for 5.5 years. And early treatment group was the medication group treated for a median of 13 years from the beginning. Now all this data was analyzed after 13 years. Now, OSTS phase 1 showed the incidence of POAG is nearly 60% lower in the medication group, where hazard ratio was 0.4. Now, OSTS phase 2 showed that incidence of POAG is not different between the observation and the medication group, with hazard ratio of 1.06. Now, this is the one important chart that shows the cumulative 13-year incidence of POAG in low, medium, and high-risk groups. Now, in the first chart, it shows for the low-risk OSTs, medication group developed 7% developed glaucoma endpoints, and observation 8% with p-value not significant. In the middle risk, medication group 14% developed POAG, and observation 19% p-value not significant. It was only the highest risk category patients where medication group developed 28% and observation group developed 40% as a POAG endpoints. Here only the p-value is significant. So not across all risks. It is only the highest risk category that shows the benefit. So here the conclusion is that most low risk OST patients can be followed without medication. Delaying treatment for 7.5 years resulted in only small absolute increase in the POAG in the low risk participants. Starting treatment when POAG is confirmed has no major negative effect on the prognosis over 5 years periods. So high risk OST patient may benefit from more frequent examination and early treatment consideration. Early treatment taking into considerations patient age, health status, life expectancy, family history, personal preference. Now OCT RNFL analysis and fundus photograph, anything showing a very definite conclusive evidence of glaucoma, and then putting the patients on the treatment. OSTs obviously had some limitation where IOP reduction was only 20%, which may not be sufficient in all the cases. No measure for medication adherence, convenience sample, not population-based epidemiology study. High threshold for diagnosing POAG. Now we have better testing modality available, as Madam was saying about HRT, OCT, and other things where we can very confidently diagnose pre-perimetric glaucomas. So in summary, individualized assessment of risk is the best course of action. absolute beneficial effect of treatment is greatest only in high-risk individual. There is little absolute benefit of early treatment in all the OST or pre-perimetric glaucoma patient. So I feel rather than treating everyone, stress on timely visit, appropriate test during the follow-up, risk status will change over a period of time. Patient education is the key, but don't overtreat all the OST patients as of that is not a evidence and that is not the right economics also. Thank you.
Dr. Pankaj, do we have Pratik, sir? Dr. Pratik?
Yeah, very much.
Yeah, sir. Good evening, sir. Please share your opinion with us, please. Because it will be open, the topic will be open for discussion in the end, but right now we'll take opinion from Dr. Pratik. Yes, please.
Okay, so congratulations to both the speakers. They did wonderful job. And if Dr. Pando asks me to vote, then I will give one vote to Karishma and one vote to Pankaj. But I'm not allowed to give two votes. So now let me put my point. You know, if you are diagnosing a condition, pre-perimetric glaucoma, that means a pathology. Okay. So any pathology, you cannot leave untreated until and unless if there is a more risk of treating the patient rather than the benefit. So if you feel that the patient will be benefited by the treatment, then we must treat. If you feel that the patient would not be benefited by treatment, then we should not treat. So obviously all pre-perimetric glaucoma, I'm sorry to say that the Pankaj has concentrated more on the ocular hypertension, and ocular hypertension is a different condition than the pre-perimetric glaucoma. Probably, you know, he might have taken more help of the early manifest glaucoma trial, which might have fit more into the pre-perimetric glaucoma. But anyway, whatsoever it is, if you have a patient of a pre-perimetric glaucoma, a true pre-perimetric glaucoma, where you are able to visualize the optic nerve changes and the RNFL defect, and there are some risk factors like patient is of young age, damaging IOP means the IOP at the presentation is very high. If there is a disc hemorrhage, if there is a strong family history of glaucoma, all these patients that deserve treatment. On the contrary, if you have a patient who have a little lower IOP and age is 75 years old, he might have a little scotoma as well, more than pre-perimetric glaucoma, then also probably I will not treat that patient and I would do the serial follow-up. So most important thing is that you have to decide which group requires a treatment and which group does not require a treatment. And for both the groups, the most important thing is do a serial follow-up. If you are decided not to treat, if you are doing the serial follow-up, and whenever you pick up progression, you must initiate the treatment. Do not delay the treatment. Okay. So I don't know how much time I have.
That's fine, sir. If you want to make any other point, you can make.
Okay. So the central corneal thickness is again one of the important things which we must consider. You know, higher the intraocular pressure, thinner is the cornea. Patient is having a pre-perimetric glaucoma. We must consider the patient for the treatment. Similarly, you know, high myopic patient, they also present with a similar kind of a situation, and then you may consider them for treating these patients. So the crux is that apply a holistic approach, examine the patient thoroughly, decide which patient require a treatment, which patient does not require a treatment, and most important, do the serial follow-up of the patient.
Thank you, sir. Thank you very much. So we go on to the next debate of this session. Although it's the last session, it's like the last 15 overs of a 5th-day test match, like what we had in the GABA 4 months ago. So it's as exciting and everybody is as awake as ever. And there's the beauty about glaucoma. You can have various opinions by various surgeons and all may be right to reach the ultimate goal of giving a patient a satisfactory visual outcome. So our next topic is on one failed trabeculectomy, what now? Which will be a repeat trabeculectomy, which will be spoken by Dr. Chanda Hingorani. Trab or a valve implant will be by Dr. Ajit Hazari, and it will be discussed at the end by Dr. Harsh Kumar. So 6 minutes to the speakers. I'll be maintaining your timing, and Dr. Chanda, you can please start sharing the screen. Thank you very much.
Thank you, Mayur. At the outset, I would like to thank Dr. Manisha, BOA and MOS for giving me this opportunity. Can you all see my screen?
Yes, it can be seen now. You can maximize it and start.
Yeah. So I'm going to talk in favor of repeat trabeculectomy. So trabeculectomy, we all know, still remains the gold standard filtering surgery, having a good success rate of about 70 to 88%. However, this surgery has a limited lifespan and it may fail over a period of time. So the dilemma is, what if a primary trabeculectomy surgery fails? We have two options, either do a repeat trabeculectomy or put in a tube. However, before we decide what to do next, it is very important to understand why the primary surgery failed. So in case the reason for failure of the primary trabeculectomy surgery was poor patient selection, that is, if the primary trab was done in patients with complicated secondary glaucomas, like all these patients with extensive conjunctival scarring, silicone oil-induced glaucoma, uveitic glaucoma, glaucoma secondary to keratoplasty, I think there is no point in going for a repeat trabeculectomy because it is not going to work and tube is the procedure of choice. However, if the initial trabeculectomy surgery was done in an uncomplicated eye with primary glaucomas, and if despite all the measures, the bleb cannot be revised, then repeat trabeculectomy definitely is the treatment of choice. Why do a repeat trabeculectomy? We know that this is one glaucoma surgery that have stood the test of time, and with rigorous and careful patient selection, it has a very good success rate. So coming to the advantages of repeat trabeculectomy, this is a relatively easy procedure to perform, does not require any special training, and most of the general ophthalmologists are well trained and skilled to perform this procedure. It has a shorter surgical time compared to tube shunts. It is a less messy surgery. There is less bleeding, less tissue dissection. So we all know that trabeculectomy does not require any fancy, expensive equipments. So in a country like India, where there are a lot of financial constraints, I think trab is a very economically viable option compared to the tube, where the cost of tube itself can be burdensome for the patient. With repeat trab, we have the option of reviving a failed bleb. There are multiple options. We can do bleb needling, releasable or adjustable sutures, laser suturolysis, 5FU injections. Whereas if a tube fails, there is nothing much that can be done. There is limited data available for the success of needle revision after tube surgery. This is the biggest advantage of doing a repeat trab. We all know that glaucoma surgeries don't last forever. So it is very important to anticipate and prepare for subsequent procedures. This is particularly important in younger patients who may need a sequence of operations over their lifespan. So if we are doing a repeat trab, only a small amount of conjunctiva is lost, and there is still a scope of doing tube in future. But if a tube fails, there is not enough conjunctiva left to consider for a trab. So this makes tube a potentially dead end procedure. With trab, it is possible to get IOPs in single digit, whereas with tubes, the IOP generally settles down somewhere in the high teens. So in case in a patient where the target IOP is 10 or below, then repeat trab definitely is the procedure of choice. In patients who cannot use anti-glaucoma medications, either due to intolerance or any other issues like that, then repeat trab again is the procedure of choice because there is greater likelihood of achieving a complete medicine-free success with trabeculectomy rather than a tube surgery. Also, unlike tube, there is no hypertensive phase with trab, hence there is no need of anti-glaucoma drops post-surgery. With retrab, there are no unacceptable side effects of tubes like corneal decompensation secondary to tube touch, tube exposure and erosions, cosmetically disfiguring blebs, tube and plate displacements, and diplopia and motility issues. So I'll quickly go through few studies about repeat trab. So this was a study published in IGO in January 2019 about the surgical outcomes of repeat trabeculectomy augmented with high-dose mitomycin C. And the study concluded that repeat trab with mitomycin C used in higher concentration and exposure time altered according to the individual risk factor plays a crucial role in the success, and hence it could be considered a viable option before planning a tube surgery. So this is a very important point when we are planning to do a repeat trab. A proper patient selection and a proper titration of the dose of mitomycin C is very important for the success of this procedure. This is another study which was published in Korean Journal of Ophthalmology in 2011, comparing the outcome of repeat trab with MMC and initial trabeculectomy. Again, this study concluded that repeat trab with MMC has a high success and low complication rate in patients with previously failed trab. Yet another study published in BGO in March 2017 to see the long-term outcomes of repeat trabeculectomy. And this study concluded that repeat trab with mitomycin C is a safe and effective procedure in the medium to long term. And in this study, at 60 months post repeat trab, a qualified success was achieved in 75.6% of the patient, which is quite a good figure. This is one of my patient repeat trab. So a combined surgery was done, cataract plus trab, in February 2014, which eventually failed. I did a repeat trab in January 2017, followed by a bleb needling in February 2017. Patient is still maintaining after 4 years an IOP between 12 and 16 millimeter without any supplemental anti-glaucoma medication. So this is the failed primary bleb. I did a nasal trabeculectomy. You can see a diffuse filtering bleb. So I still have intact temporal conjunctiva for future tube if it is needed. What counts in glaucoma surgery is scoring with efficacy, and only with a repeat trabeculectomy we can get significantly lower IOPs with less side effects. So I think repeat trabeculectomy definitely is the procedure of choice. Thank you everyone for your patient hearing.
Thank you, Dr. Chanda. That was very eloquently put. Although I hope the easy peasy, which was there in one of your slides for trab, holds true for my surgeries as well, which I'm not too sure of. Dr. Ajit, can you please start sharing your screen, please, for the valve implant?
Dr. Chandrasekhar, sir.
Right. Are my slides visible?
Yes, sir, you're visible, you're audible, sir.
Thank you. Thank you, BOA, MOS, Dr. Lahane, Ragini ma'am, Manish, Jinish, and Mayav for inviting me in this session. And thank you so much to Dr. Chanda for covering all the points so well. She's made my talk so much more easier, and my talk almost becomes like a complimentary talk to hers. So considering a tube after a failed trab is what I'm going to talk about. Now, if you look at the common indications for tube, the most obvious one is an eye with a previous surgery, like a failed trab, where there is conjunctival scarring, and there may be presence of inflammation in the eye. Other than that, as Dr. Chanda already referred to, the refractory glaucomas, which have compromised conjunctiva and increased inflammation, like the post-traumatic, uveitic, uncontrolled neovascular disease. These are the situations where a trab is very, very likely to fail. Why to prefer a tube surgery after a failed trab? The chances of failure in a repeat trab are more if there is presence of scarred conjunctiva and increased inflammatory mediators. The TVT study is a landmark study, and despite all its limitations of the implant being used and the type of patients that were used, it showed that the failure rate of tube is half of that of a repeat trab with mitomycin C over a long period of time. What does the real world experience show us? Now, we've been using tubes for a long, long time, and we've learned a lot about trabeculectomy, wound healing, and the way trabeculectomy fares over a period of time, as well as the tubes over the last 10, 15 years at least. And the same surgery, what we all know is that the same surgery, either being a trab or a tube, despite all the standardizations, has different outcomes at the hands of different surgeons, and can have different outcomes at the hands of the same surgeon, but in different patients, in different eyes. So what I firmly believe is that a skilled surgeon should have both surgeries in his armamentarium and choose the technique that works best in his hands for that particular eye. Having said that, we all know from history and what we've learned from our clinical practice over so many years and all the studies that show that repeat trabeculectomy has a lower chance of survival as compared to a trabeculectomy done in a virgin eye. If we look at the glaucoma surgeries and compare them on the basis of efficacy, that is the potential to reduce IOP, and the safety, that is the incidence of complications or the need for interventions, then trabeculectomy scores at the top at reducing the IOP, and at the other extreme is MIGS. But if you look at the safety, that is less complications and less interventions required, then the sequence is exactly the opposite, where mitomycin, the trab mitomycin C has the highest potential of causing hypotony and serious hypotony for that matter. So what are the surgical considerations after a failed trab? I'll be talking about the tube. So the challenges that we face in using tubes in our patients in our patients is that it involves a relatively steep learning curve. But my personal belief is this is more so because we are less familiar with the surgery. And the solution is an early hands-on training during residency or fellowship, and that will definitely go a long way. Then the tube always requires the availability of scleral patch graft. Whether you use it or not use it, a different issue. But even that is not so much of a challenge now, because there are so many eye banks available who are ready to offer us a scleral patch. And the only thing that we need to do is plan in advance so that we have the scleral patch graft available with us at the time of surgery. Traditionally, the implants have always been much more expensive compared to a trab with mitomycin C. But the introduction of the RD and the modifications that we've been doing with it over the last 3-4 years has definitely reduced the cost of surgery for us. The distinct advantages of a tube are that it has a better survival rate over time than a repeat trab. And there are less chances of early complications such as hypotony and early surgical interventions. And of course, it is to be preferred in situations that we know which are more prone for failure of a primary trabeculectomy or a repeat trabeculectomy for that matter. So when should you prefer a tube after a failed trab? Well, the first thing is that all the efforts of reviving the old bleb are unsuccessful. Then obviously you don't have a choice but to operate. And if there is a definite extensive conjunctival scarring, there's inflammation, and there are conditions that predispose to refractory glaucoma, these again point towards using a tube. If the IOP is more than 25, then the TVT and PTVT studies have shown us that with a higher pre-op IOP, the chances of success of a tube are much more than a repeat trabeculectomy with mitomycin C. So as a closing remark, I mean, I don't want to go into the studies all over again, but I've taken the gist of what we've learned from the studies. So the closing remark is that even if you do a trab with mitomycin C in an eye which has a previously failed trab, it is probably wiser to leave the superotemporal quadrant free for a future tube implant. Thank you.
Thank you, sir. Thank you very much. I would like to now request Dr. Harsh Kumar to give his viewpoints on this particular debate, please.
I think, like Prateep said, I have one mark to both of them. Both of Channa was so good and eloquent. I don't think there was anything that she left out. And same with Ajit, very nicely he put all his points. But the hard fact in Indian population is that I think we will have to go for a retrab. All said and done, because not only the fact that, see, most of these people to you are not coming from your local area. A whole lot of these people are coming from outside. And let us be very frank, and I think Ajit did a very wise thing to say that we have to start teaching our people the valves at the standard level. Otherwise, they just don't know, and the general practitioner of ophthalmology does not have an idea. So let me give you a very important hint, which is more important than all the debate, that whenever you have done a valve and the valve goes outside somewhere, tell them to tell the doctor to pull down the lid or pull up the upper lid if it is there and see the valve. They just see the central area, forget to see the area of the tube. The tube gets exposed and they come back with endophthalmitis. So maybe you people are not doing that volumes. The volumes that come to me from complicated cases is enormous. And definitely the complications of valves are much more difficult to handle. And like Chanda rightly pointed out, that it's pretty much the dead end. Yes, we can sometimes do a second valve also. We can do a diode laser cyclophotocoagulation there also. But primarily, if you find that you had done a trab and the trab had failed because of the reason that probably you did not put enough mitomycin, probably you did not take out the sutures at the right time, probably there was a bleeding or something which can be redeemed, then you have to do a retrab. If there's an area which is available in the superior quadrant, then one must go for a retrab. Be careful in this retrab, though Chanda had told indirectly, you should increase your timing of the antifibrotics, and you have to release the sutures earlier. You have to tell these people to come for a much more regular follow-up. And though Chanda, Ajit rightly said, Chanda had very beautiful slide and she made it sound very, very simple. It is not many times a very simple surgery.
Yes.
But I think that is where it stands. And she rightly pointed out, yes, if you have done the trap for the wrong reason, like Ajit also showed that there are cases of PK and post-silicone oil removal and RD and secondary glaucomas, where anyway you should have done a valve in the first sitting. So I think the matter stands there. Each patient will have to be treated on its own merit, but classically we should try for a trap first.
Thank you, sir. Thank you very much.
Thank you, sir. Thank you for your valuable opinion. Now we have a third debate. There's a case of narrow angle glaucoma with cataract. We have Dr. Neeta Asher, who would prefer a YAG PI prior to the cataract. And we have Dr. Pooja Bomraj says no PI necessary. So let's go and hear both of them. Dr. Neeta, please go ahead.
My slides are visible?
Yeah, they are. Please go
Sure.
ahead.
Good evening, everyone. At the outset, I would like to thank BOA and MOS team for giving me this opportunity. My topic for debate is narrow angle with cataract, and I will be speaking in favor of YAG PI. That is, YAG PI is indicated prior to cataract surgery. It is always wise to be well prepared in advance when you know the chances of bumpy ride ahead. We all know that eyes with PACG, they are functionally and anatomically different. They have flatter corneas, they have shorter axial lens, shallow anterior chamber, and they have thicker and relatively anteriorly positioned lenses. And this narrow anterior segment, which is seen in PACG eyes, is most often secondary to pupillary block. And this pupillary block component, if we can relieve by doing a laser iridotomy, an anterior segment can become deep enough to perform a safe intraocular procedure. We have enough evidence to show that there is anterior segment morphology changes after laser PI. As with anterior segment OCT images, we can see that after laser PI, there is definite increase in angle width, anterior chamber depth, and anterior chamber area. There is also flattening of the iris. Lens also shifts posteriorly after resolution of the attack, especially with greater lens wall. And all these changes, which are visible, studies have shown that these changes persist even months after the laser iridotomy. So why not take the advantage of these morphological changes after laser PI? Let us look at the difficulty which one faces while performing a phacoemulsification in narrow angles. You are working in a shallow anterior chamber with high intraocular pressure. There may be associated corneal clouding also, especially after acute attack. There may be floppy iris. This floppy iris with high intraocular pressure in a shallow anterior chamber can lead to repeated iris prolapse into the wound. There is a possibility of small pupil also in narrow angles. It can be because of chronic inflammation or because of chronic meiotic use, or there may be posterior synechia which may be adherent to the lens capsule. Sometimes these eyes, they have zonular dialysis also. So all these factors, zonular dialysis or small pupil or iris prolapse, they make phacoemulsification difficult and requires repeated manipulation and extra tissue handling. We know when iris prolapses into the wound, it is very difficult to manage. Sometimes there is damage to the iris also because of repeated manipulation, and one may require a surgical iridotomy to handle this situation, which may be large enough to create a visual disturbance post-operatively. In contrast, after doing a laser iridotomy, anterior chamber becomes deep, iris remains in position throughout the cataract surgery, making phacoemulsification much more easier. Another alternative to this laser iridotomy may be use of intravenous mannitol, which can lead to vitreous shrinkage and a relatively deeper anterior chamber, but it may not be suitable for all patients, especially in elderly, when they are associated with cardiovascular or urological conditions. Another complication which is seen in narrow angles, although it is rare, but the possibility of malignant glaucoma is also there. Here, transient anterior chamber shallowing can precipitate aqueous misdirection, and it is recommended to avoid frequent anterior chamber shallowing and IOP fluctuations during cataract surgery. By doing a simple laser iridotomy, this anterior frequent chamber shallowing and IOP fluctuations can be avoided, and thus malignant glaucoma chances can also be minimized. So in summary, by considering all these factors, I agree in an experienced phacosurgeon, he can perform phacoemulsification alone without laser iridotomy in cases of occludable angles with normal intraocular pressure or with mild to moderate glaucomas when IOP is medically well controlled. But YAC-PI is certainly indicated in acute angle closure glaucoma, and one should relieve pupillary block by doing an iridotomy, and ideally a cataract surgery should be performed once inflammation subsides. It is also definitely indicated in nanophthalmos, and I will also recommend in all primary angle closure glaucoma with high intraocular pressure, as it reduces difficulties during phacoemulsification and thus reduces the chances of intraoperative as well as post-operative complications. Thank you so much for your patient hearing.
Thank you, Doctor. Yeah. Dr. Pooja, can you please go ahead with your talk, please? Dr. Pooja, can you please go ahead? We can't hear you, please. Can you unmute yourself, please? You're showing mute. You need to unmute yourself, Dr. Pooja.
Yeah. I have unmuted. I am not able to share my screen. Just a minute. Sorry.
It's there on the screen, na? Share screen.
Yeah, it's there.
Green icon. It's a green icon, Pooja.
Yeah. Is it seen now?
Yeah.
Sorry for the delay. Good evening, everyone. And I thank BOA and Dr. Manish sir for giving me this opportunity. This has been a really wonderful seminar all throughout the day. We have been listening to so many stalwart people. So I'll just go ahead with my talk. That is narrow angles with cataract. No PI necessary. So let's get the terminology clear. Actually, when we say narrow angles, that is primary angle closure suspect with normal IOP, no pass, no discharges, and no which was previously called as narrow or occludable angles. Also, in this situation, when there is more than 180 degrees of angle closure with raised IOP and pass, we say that is primary angle closure. And when there is associated glaucomatous changes, disc changes, and field changes, we say that it is primary angle closure glaucoma. So we all know that glaucoma is multifactorial in nature, and Neetu also previously mentioned about all that details. But we need to understand that lens occupies almost 4 mm of space in the anterior segment, and it tends to increase in size over the life, like from 20, at the age of 20, if it is 4, as the age increases, it tends to increase in size and contributes significantly to the anatomical crowding in the anterior segment. So
when we are looking at the phacomorphic factor, there is increase in the lens thickness in cataractous lens. This leads to increase in iridolenticular contact and hence leads to pupillary block. This kind of pupillary block will not be treated by doing an YAC PI. Removing the lens will definitely solve our problem. So when we are looking at a case, 60-year-old patient with narrow angles, more than 180 degrees of angle closure, no pass, no significantly raised IOP, and there is visually significant cataract, no disc and field changes, obviously. Then we first do a gonio, confirm that the cause of angle closure is primary, it is not secondary, that is due to NVI or eye syndrome or something like that. Then we can straight away go ahead and do cataract surgery. When we do cataract and IOL implantation in this case, you can significantly see opening of the angles as seen in this slide. Also, when a 5 mm thick lens is replaced by a 0.72 mm thick, there is definite evidence of increased opening of the angle, decrease in the IOP, and visual rehabilitation. So we need to aim to treat the cause, not the effect. So when we are trying to do laser peripheral iridotomy in a case of angle closure glaucoma, especially with significant cataract, we are trying to treat the effect, not the cause. As has been described by various studies that have been done in recent time for angle closure. So decision to perform cataract surgery is clearly straightforward. When there is significant reduction in the IOP, especially in the angle closure group. There are multiple studies like Chen et al., Dr. Ravi Thomas et al., and Kim et al., where they have done studies of post-phacoemulsification results in glaucoma patients, and they have found out IOP reduction in the angle closure group as compared to the just open angle group. Recently, one study was published by Dr. Pandav et al. In IGO in 2019, where they have studied the intraocular pressure reduction in the spectrum of angle closure disease. So all the patients of PACS, PAC, and PACG were included in the study. Patients with LPI, laser peripheral iridotomy, were excluded from the study. They underwent cataract surgery with IOL implantation, and the patients were followed up for a period of 1 year. And over the period of 1 year, they found out that almost 23% of reduction in the IOP was found, and 37% reduction in the dependence of anti-glaucoma medication. So the benefits are very obvious. And laser peripheral iridotomy is not benign, totally benign. You might come across iritis after the procedure. There might be hyphema. You might damage the endothelium in the process. It might just accelerate the cataract, and also you might end up having an attack of angle closure after the PI. There might be a past development. There are reports which say that the angles fail to open up even in almost 30% of the cases after LPI. LPI is indicated in eyes with PAC and PACG in absence of cataract. So, and in addition to what I've already said, there were other trials also, ZAP trial and EAGLE study, which have repeatedly re-emphasized the importance of not doing PI in asymptomatic PAC, and also the importance of having cataract extraction. A cataract extraction with LPI should be our first option of treatment in patients with visually significant cataract, especially in PSCS. So to conclude, we can say that PSCS with cataract is the surgery of choice. PSC with cataract, anti-glaucoma medication with surgery, cataract surgery, and in PSCG with advanced glaucoma, combined surgery should be our treatment of choice. So thank you. That's what I.
Thank you, doctor. Can we have Dr. Devin, sir, please, for your explanation?
Yeah, I think first, let me congratulate both Neetu and Pooja for trying their best to win the debate, but it's not just about winning the debate. One thing is that Manish is there. So Manish, when you had this topic in mind, I think he was referring to only primary glaucoma. So let's not go into secondary glaucoma here. And narrow angle, probably he had only PSC and PSCS in mind. PSCG, mind you, if it is advanced enough, there are enough K, then laser PI or cataract both may not work up. So you have to combine it with the trab. So let's not go into advanced PSCG. Let's stick to narrow angles, which is PSCS or PSC in my thinking. For for this category where there is primarily appositional closure, let me say that both a laser PI and a cataract surgery can do the trick. So as regards the glaucoma control or the IOP control is concerned, so that part is quite even on both fronts. There are two other factors to consider. One is the ocular parameters. So let me tell you, for the benefit of the audience, you just can't say that how thick the lens is, how shallow the AC is. So we have identified at RP Center, the work has identified some basic, the actual numbers. So the risk for when the AC depth is less than 1.8, then it becomes a difficult surgery. The risk of progression is also there. So this is one thing in the AC anterior chamber depth. Second is the length, the axial length. So whenever it is less than 22 in the pre-op, when you've done the biometry, so less than 22, most of our lesser experienced surgeons will struggle. So please keep that in mind. So if that is there is no harm in doing a laser PI. It relieves to some extent the appositional closure and makes your cataract surgery easier and less complicated. Third risk factor in terms of numbers that we've shown is that if the lens thickness is 5 millimeters or more. So in this regard, yes, lot of the experienced, see, I don't do cataract surgery for the last 22 years, but I have a lot of glaucoma patients where my colleagues do the cataract surgery for. And just before the lockdown in Delhi, there was one of the most experienced surgeons I visit, the cataract surgeon. He was struggling because the axial length was 21.5. So this is just to drive home that this thing that please don't have ego. There is nothing wrong in doing a laser PI if you're less experienced. Your surgery becomes easy and you are, the medical legal angle is taken care of. And they had to do a vitrectomy because the pressure went up so high in that patient in trab. So keep that in mind. Having said this, if your ocular parameters are not in this range, say the axial length is more than 22, the AC depth is more than 2 millimeters, so on and so forth, then I think doing a laser PI may be a futile exercise beforehand, because most cataract surgeons can manage that much of this thing and there is hardly any complication. And the angle opens up. You have to consent prehand that if it is PSC, that yes, the patient may need post-op medication to supplement the cataract surgery. So keep that in mind that you also have to define the ocular parameters. Third thing I partly said is the surgeon experience. So the cataract surgeon experience is a vital this thing. A lot of them take time. They take 20 minutes to do a phaco, even more. So I think then it becomes a struggle for them. Some of them can finish it in 3 minutes. So then it's less of a struggle. The more time you take, it allows more disturbance of the ocular dynamics in trab and more chances of surgery. So I must congratulate both Neetu and Pooja for trying to drive home their points. But I think in this, you have to really individualize the patient and decide this thing. There cannot be one winner in this, that always you have to do a laser PI. That is not correct. But there are a lot of cases where a laser PI makes your surgery more comfortable if you are more of a beginner or a less experienced. Thank you.
Thank you.
Thank you, sir. Thank you very much, sir. Before we move on to the next couple of talks, Dr. Pandav, sir, Dr. Janshekhar, any comments on any of the debates which we've had so far?
I think I'll tell at the end of the thing, I'll just probably able to summarize the.
Thank you, sir. Dr. Pandav, sir, anything right now, or can we go ahead?
All the speakers have done justice to their talks, basically. But at this point, I just a couple of points, basically. There's regarding the resurgery, the trabeculectomy or or a tube. I think if you trab and then you're doing a resurgery, you're doing another surgery which an eye which is already failed. Most of us will prefer that procedure before you go for the tube. But I just want to mention here that instead of doing a full trabeculectomy, there is also a procedure called a revision trab, or trab through a limited posterior revision trab. So there are other procedures also available in such situations, and they can also be kind of considered if you don't want to do a full trabeculectomy. So there are other options as well. And in all these debates, actually, there might be some more options as well, but because the restricted time, I think the speaker is kind of bound by certain things. So, they only focus on, what is the center of the point is. And also, I think regarding laser iridotomy, I think Dr. This has all been summarized very nicely, both of these, and also the discussant, Dr. Tulli. I think he has summarized actually the gist of it. So I think we can go ahead to the next section.
There is a question from the audience, Dr. Pandav, that if there is PACS and if no YAC PI is planned, can we still safely dilate for preoperative cataract evaluation and fundus evaluation? Do you have any mantra for that, sir?
PACS is only suspect, and it's unlikely that it will go into angle closure. So we can suspect, but the only caveat here is that whenever you dilate these people, make sure that you check the intraocular pressure afterwards. So,
right, sir.
No, in fact, I can just add to this. In fact, that works like a very good provocative test. So if you can actually do that in the clinic, don't allow the patient to go, like Sir said, you must measure the pressure, say about 1 hour after the dilatation and the procedure is over. And if the pressure is gone up, say beyond 8 to 10 millimeters of mercury, then I think it works like a provocative test. And that means that the patient is likely to have, in that regard, I think it's a good thing to do a laser PI before cataract.
Right, sir. And there's also a question for you, Dr. Devin, that is there any documented cutoff of anterior chamber depth, which for
like
cataract?
No, I think this is a paper which is first authored by Professor Sehota. You could just look up the PubMed and look at this, whoever is asking, or if I get hold of it, the PubMed reference, I'll send it across.
Thank you, sir. Thank you very much. So we'll go ahead now with the next part of the session, where we have Dr. Vijay Shetty, glaucoma specialist from Navi Mumbai, who will be speaking on approach to disc suspects. So you can start whenever you're ready, sir.
Good evening. Are my slides visible?
Visible and audible both.
Thank you. At the outset, I would like to thank BOA, MOS, and Dr. Manisha for giving me an opportunity to be a part of this session. My topic is approach to disc suspects. Disc examination helps in distinguishing between healthy glaucoma and non-glaucomatous disc damage. It quantifies the amount of damage, and it also helps in monitoring the change, whether it's stable or worse. It can be done with slit lamp biomicroscope, fundus photography, direct ophthalmoscope, or indirect ophthalmoscope. Axons of the ganglion cells forms the nerve fiber. Approximately 1 million nerve fibers pass through the optic nerve head. Cup is the area in the optic nerve which does not have the nerve fiber. However, cup disc ratio is higher in large disc as there is a larger space to accommodate the axons. And likewise, the cup disc ratio is smaller in small disc. Cup disc ratio is higher in glaucoma due to loss of these axons, which leads to enlargement of the cup. If you have to go only on the cup disc ratio, the right hand side image shows a larger cup than the left-sided image. So which is the abnormal disc? So first we measure the disc size with a slit lamp examination with a 90D or a 60D examination. So anything which is less than 1.65 millimeter is considered a small disc, and anything which is greater than 2.2 millimeter is considered a large disc. And there is a correction factor if you are using any other lens. For example, you use 1.36 correction factor for vertical disc diameter measured when you use a 90D lens. So there are certain fundus camera images which has the ability to measure the disc size as well as in optos. But in other fundus camera images, you can approximately say whether the disc is small or large by comparing the disc size with its distance from the fovea. Now, normal disc size would be, in normal disc size, the distance from the fovea would be around 2.5 disc diameter, whereas in large disc size, it would be around 2 disc diameters. So if you look at the disc, now the left-hand image shows a nerve fiber layer defect, which is more in favor of glaucoma compared to the right-hand image. So if you look at the sensitivity of the vertical cup disc ratio is around 67%, and which improves to 76.6% when corrected for the optic disc size. The other one is the Eisen rule, which says inferior rim is greater than superior rim, which in turn is greater than nasal rim and temporal rim. If you look again, look at this disc, here the inferior rim is less than superior rim, which again suggests that it's a glaucomatous disc. Presence of disc hemorrhage in ocular hypertension suggests that there is a higher risk for glaucoma and higher risk of converting to glaucoma, and presence of disc hemorrhages in established glaucoma predicts the impending progression. RNFL defect by far is the most reliable sign in diagnosing a glaucomatous disc, which is best seen with a red-free filter. Coming to peripapillary atrophy, it consists of beta zone and alpha zone. Beta zone is adjacent to the disc and it's devoid of retinal pigment epithelium and hence appears whitish. Alpha zone is hyper or hypopigmented area. If you look at this disc, this is the disc margin, this is the beta zone, and this is the alpha zone. Note that the beta zone is larger in the inferior area, which corresponds to the wedge RNFL defect inferiorly, and then again corresponds to the field defects in the superior arcade area. If you look at the sensitivity of beta zone, it's approximately 50% in diagnosing glaucoma. There are other signs of glaucoma, which are vascular signs as well as laminar dot signs. Certain anomalous discs give us difficulties in making out the glaucomatous disc, like dotted disc, tilted disc, and myopic disc. Again, we need to differentiate glaucomatous cupping from non-glaucomatous cupping using a Greenfield's criteria, where the age less than 50 years, visual acuity less than 612, pallor more than cupping, and vertically aligned field defects are more suggestive of non-glaucomatous cupping. The other factors like presence of optociliary stent and early involvement of color vision again goes in favor of non-glaucomatous disc damage. Morning glory syndrome and optic disc glaucoma should also be kept in mind when you are looking at the glaucomatous-like picture. How do you approach a patient with this suspect? A detailed history, complete eye examination with gonioscopy is mandatory. An additional perimetry, OCT for glaucoma analysis, disc analysis, and pachymetry is helpful. In the family history of glaucoma, presence of diabetes, trauma, uveitis, sleep apnea syndrome, medication use like steroids and drugs causing angle closure should be noted. Among the drugs causing angle closure, by one mechanism is via pupillary dilatation, and the other mechanism is idiosyncratic reaction, wherein there is a forward movement of the lens iris diaphragm. Toperimetry is typically causes angle closure through this mechanism. Clinical examination consists of refraction to know whether the patient is hypermetropic who are at risk of angle closure glaucoma, external examination for ciliary congestion or presence of hemangiomas, pupil for relative efferent pupillary defect, slit lamp examination for presence of pseudoexfoliation, Krukenberg spindle, presence of evidence of previous trauma including sphincter tear and glaucoma flecken and uveitis. IOP measurement by applanation tonometry. Gonioscopy is a must, and again the dilated examination of the optic disc and retina. If you look at the natural history of the disease, in presence of risk factors, there is an acceleration of the apoptosis leading on to ganglion cell death, and which in turn leads to undetectable RNFL change, which becomes detectable at a later stage, and finally leading on to functional impairment. This functional impairment is detected on perimetry. The detectable RNFL layer change can be documented using red-free filter photograph, but the undetectable RNFL change can be made out on OCT RNFL evaluation, and ganglion cell death can be made out on ganglion cell analysis on OCT. So correlation of the disc features with OCT findings and perimetry helps in confirming glaucoma diagnosis. So this is a typical case who is a 65-year-old male patient with a family history of glaucoma in elder brother, whose IOP was 23 millimeter of mercury in both eyes with open angles on gonioscopy. The disc in the left eye showed inferior notch with two distinct retinal nerve fiber layer defects in the infratemporal peripapillary area. Humphrey field analyzer showed a correlating defect in the superior hemifield. The defect also was involving the central 10-degree field. So the OCT showed retinal nerve fiber layer thinning in inferior peripapillary region in the RNFL thickness map, deviation map, and flock R map, correlating with the clinical and Humphrey field analyzer examination. Again, the field defect involving the central 10 degree correlated with the inner retinal layer thinning found in the macula scan. Hence, the disc findings, perimetry and OCT correlated well in this case. So to summarize, detailed examination of the disc itself in suspicious disc is mandatory. Comprehensive eye examination, including gonioscopy, aids in diagnosis of the type of glaucoma, and correlation of the disc findings with OCT and perimetry helps in confirmation of glaucoma. Thank you.
We have Thank you. Now we have another talk on uveitic glaucoma by Dr. Sunny Badwani, please. Dr. Sunny, are you here?
Yes, sir.
Okay, very good.
Give me a minute, I'll stop sharing.
Yeah, take your time.
So, good evening all. Thank you MOS and BOA for giving me the opportunity. Is my screen visible?
Yeah, go ahead.
So today I will discussing one simple uveitic case. So a 48-year female housewife by occupation was referred for second opinion. So her presenting complaints were diminution of vision since 6 months. It was gradual, progressive and worsening. Apart from mild redness, she didn't have any complaints. So past history, she was treated elsewhere and report for further management. History of 7 attacks of redness and blurred vision in left eye since past 5 years. Attacks were relieved by anti-glaucoma medications and topical steroids. Her medical history was insignificant except for hypothyroidism. There was no history of any joint pains, morning stiffness. Also, there was no history of any allergic reactions. So currently she was using Dimox half tablet QID, tablet Ultroxin for hypothyroidism, and locally she was using Predfort eye drops 8 times a day, dorzolamide tumoral combination 2 times a day, and brimodidine eye drop 3 times a day. Her visual acuity was 6/6 N6 in right eye and left eye 6/12 and N8. It was due to cataract. So anterior examination, anterior segment right eye was within normal limit. Left eye shows few small to moderate KPs and few pigmentation inferiorly. Also, there was significant cataract in left eye. So you can see some KPs in left eye inferiorly. They were moderate to small. And gonioscopy was open in both the eyes except for pigmentation in left eye. On fundus examination, the fundus of both eye was fairly within normal limits. Her applanation tonometer was 14 and 16 millimeter of mercury, and pachymetry was 500 microns in both the eyes. So to sum up the findings, it was a case of unilateral recurrent uveitis with open angles. So on the basis of above findings, a differential diagnosis of Posner-Solson syndrome, Fuchs heterochromic cyclitis, sarcoidosis, rheumatoid arthritis, acquired syphilis, Grant syndrome, that is a rare pigmented KPs or trabecular measure causes IOP rise, and a rare case, rare chance of TB was assumed. So on some investigations were done. All investigations were normal limits, within normal limits, like CBC, ESR, HLA-B27, RA factor, chest X-ray and X-ray of sacroiliac joints, Munn-Tooks test, VDRL, and tests for syphilis were normal. So on clinically, diagnosis of Posner-Solson syndrome was made. So we will discuss mainly of this rare but simple topic of Posner-Solson syndrome. So glaucoma in ocular inflammation may be due to uveitis, scleritis, keratitis, or orbital inflammation. So uveitis in glaucoma the overall prevalence is 10 to 20%. It is more commonly associated with herpes zoster, herpes simplex, toxoplasmosis, pars planatis, and rheumatoid arthritis. So pathogenesis, it may be due to closed angle or open angle. Closed angle may be due to pupillary block, oppositional, and synechial closure. It may be due to anterior rotation of lens iris diaphragm, and in cases of late neovascularization. And open angle may be due to trabecular obstruction. It may be due to trabeculitis, scarring of trabecular meshwork. It may be due to steroid induced, and it may be due to prostaglandin mediated. So coming to our case, Posner-Salzmann syndrome, it was originally described in 1948 by Posner and Salzmann. It is a rare, self-limiting and benign disease. Most common, it is seen most commonly in middle decades, 30 to 60 years old, and possible association by CME virus is also seen. Clinically, it presents as unilateral recurrent attacks of non-granulomatous iritis. Symptoms of mild discomfort, brow ache, halos, and slight blurring of vision are present. The IOP is acutely elevated during the attacks. It ranges between 30 to 70 millimeters of mercury. There is mild conjunctival congestion. Corneal edema can be seen. Scanned KP is present all over the endothelium. The inflammation is traced. Midrise is there in the affected eye. Attacks last few hours to few weeks. The angles are open and the fields and optic discs are fairly normal. In between the attacks, the IOP is normal. There is association between open angle glaucoma and Posner-Salzmann syndrome, with as many as 45% of PSS patients having concomitant open angle glaucoma. Also, glaucomatous damage from PSS itself has also been seen. The risk of glaucoma developing after 10 or more years of exposure is 2.8 times higher than in those with less than 10 years of the disease. So treatment, usually it is a benign and self-limiting disease, but it is always better to treat for good prognosis, as there is association with open angle glaucoma also. Glaucomatous damage has also been reported. So topical mainstay of treatment are topical steroids and anti-glaucoma medications, except for PG analogs. In a recent study by Wang et al., out of 74 eyes, medical treatment was effective for 62 eyes. 12 eyes exhibited progressive cupping and visual field loss that required trab with mitomycin C. All 12 eyes had not reported further attacks of PSS after surgery. In a brief, PSS is a benign and self-limiting disease, but rarely glaucomatous damage may occur with long-term disease. Hence, patients with Posner-Salzmann syndrome must have regular evaluation of visual acuity, visual fields, and IOP. Thank you all.
Thank you, Dr. Sunny. And we go to the next talk by Dr. Gayatri Roshing from Kolhapur on normal tension glaucoma, case discussion based, which will be the last topic for the day.
Am I audible?
Yes, ma'am, you're audible.
My screen is shared.
Not as yet, ma'am. At least I cannot see it.
Now?
Not yet.
Now?
Now the Zoom link is showing, ma'am. We need to go to your presentation.
Okay. Yeah.
You can maximize it and you can start, ma'am.
Thank you. Good evening, everybody. At the outset, I would like to thank BOA and MOS for inviting me. I'll be talking about normal tension glaucoma, a few cases that we routinely see in our OPD, and sometimes we may just not look into the detailing of the disease. This was a case of a 57-year-old male. This is a very routine case who had come for a checkup. On examination, his visual acuity was 6.6 and 6. Slit lamp was normal. Intraocular pressures were around 16 in both the eyes, and CCT was 500 and 506 microns in right and left eye, respectively. The angles were open. Optic disc evaluation showed a right eye was normal, but the left eye showed an inferior notch with a wedge defect. So fields was done. For the right eye was normal, but left eye, it definitely showed some defects here, which were nearing the fixation. Very typical for a normal tension glaucoma. What was done was a diurnal measurement. IOP was done. A minimum of 13 in the right eye and 16 in the left eye, and maximum was around 15 to 17. So this was a very typical case of normal tension glaucoma. Points in favoring were a normal IOP, asymmetric cup, disc and field changes which were correlating. So the patient was started on prostaglandin analogs and is being maintaining. Now that was quite a clear-cut case, but in this patient, 37-year-old male, he was a diabetic and hypertensive, under treatment and under control, was being treated elsewhere for a normal tension glaucoma with brimonidine eye drops in both the eyes. This was where the patient was earlier being treated by a general ophthalmologist. His vision was 6.6 and 6. Then applanation was 16 and 12 in the left. Gonioscopy was open. Right eye, the disc showed 0.7 and inferior and superior in thinning, and left eye was 0.5. CCT was normal. I do not have the disc photographs because the patient was being treated somewhere else. These were his field defects during the first visit over there. Showed some earlier superior defects, though they are quite unreliable. 10 months later, when the patient had reviewed with that ophthalmologist, the best corrected visual acuity was 6.6 and 6. Applanation was again 16 with medication. Disc was the same, and CCT and CCT2 was same. However, that person had again repeated the fields, and this was what happened in the right eye. He suspected the doctor suspected some progression and hence was referred to me. So this is the first visit and this is the second visit of the patient. About 10 months gap definitely shows some changes, though the fields are unreliable. Would like to repeat the fields to say a progression, but yes, something was happening there. So then I did a disc photograph and these other disc photographs when the patient had come to me. What I did was a diurnal variation, and what we found out that the 16 pressure, which was pressures which was supposed to be normal by the doctor on medication. However, during a diurnal, the right eye showed a change of 24 and left eye 20, highest IOP. So the patient was switched to a bimatoprost eye drops in both the eyes. After 1 week, I repeated the pressures, preferably this time at 8 o'clock. It is easier because it is a small city. We can call the patients in the early timing over here. And the pressures were like 16 and 14. Now the patient is maintaining a pressures of around 12. And so I would like to stress that in spite the patient is being treated for normal tension glaucoma, and if you are suspecting some field changes, it is always better to repeat a diurnal in that, even if the patient is undergoing treatment. Now this was the case. This is a third case, a 50-year-old male, no specific complaints, but he had a family history of glaucoma and he had come for a checkup because he had a family history. He was borderline hypertensive, not on any treatment. These were his findings. Vision was normal, anterior segment normal, IOP was 18. His angles were open, healthy rim 0.6, 500 microns CCT. These were the discs. They were quite normal in both the eyes. Did not show any defects. Fields were normal when the patient had first consulted. So it was an option whether to treat or not. The patient was quite aware, and so we thought that we will not treat him and get him for a regular follow-up. He came for the first year, second year, but then afterwards he came after 3 years. And then this was what we found. The disc had showed in the right eye showed a superior wedge defect. Left eye also the same. There was a superior wedge defect in the left eye. So a swap was done and we could see an inferior defect in the right eye and some defects in the left eye. So considering thinner corneas and family history, we started him on a prostaglandin analog. Target pressures were like to be maintained for less than 15, and now the patient is on a regular follow-up, maintaining his fields and IOP are now stable. So when we have such patients of normal tension glaucoma, I would like to emphasize on that it is a diagnosis of exclusion. So we have to rule out all other causes of glaucoma or any other of disc damage, like previously told by Dr. Vijay Shetty. We have to go in for a diurnal fluctuation to just see whether there is any wide fluctuation and we are not missing any POAGs. We have to ask the patient whether the patient is on any systemic medications, has had used any steroids earlier, or whether the patient is a case of burnt out pigmentary old glaucomas, whether past uveitic or trauma patient. Also, we should evaluate the disc if it has had any trauma, or if it is an optic disc pit, any toxic neuropathies, anemias, or any sudden acute blood loss. So while evaluation, we should take a proper history, any eye disease for migraine, current medications, any coagulopathies, sleep apnea and nocturnal hypotension. That must be emphasized because many times the patients take antihypertensive at night and then they have a dip, and that causes any progression, may cause progression in the disease. So to take home message, whenever patients with normal tension or suspicious disc, glaucomatous discs come, we have to be very particular about the ocular examination, perform CCT, perform a diurnal even during the first visit, and even during, maybe you can perform some other time also after 3-4 years, or whenever you feel that there is any progression or the patient is not doing how you want him to go. If look for the other risk factors, close and meticulous follow-up, extensive systemic workup in patients who are more than 60 years, like if there is, especially the optic disc pallor is more than the cupping, or the rapid progression in spite of your treatment. Thorough systemic examination, including medical history, neurological examination, any carotid Doppler or angiography if required to see whether there is any non-arthritic ischemic neuropathy playing a role, any blood or a CBC for hematocrit and ESR, and a CT or MRI if required. Thank you.
Thank you, Dr. Gayatri. Dr. Manisha has had a question that in place of diurnal variation testing, is there a role for water drinking test as a provocative test? Because there are some studies in this regard. Do you have any experience on the same which you would like to enlighten us?
Yeah, we can also do water drinking test. It has been proved that water drinking also increases the pressures once you do. But I feel that a diurnal is much better. At least we get a clear-cut idea like how is the phase, what are the phases, and at what time the patient increases, the pressure increases in the eye. So that maybe we can even manage our treatment doses also, or the medicine also accordingly.
Right, right. Can you stop sharing your screen, please?
Yeah.
Any other program in this after this, or because
no, sir, we are at the end of the session, so we can do a little bit of discussion if people if it's possible.
We only have finished our allocated time, but we can continue for some more time if you have any questions.
Ganeshan sir, your opinion, please, if you want to opine about on any of the topics.
Dr. Vidya as well, Dr. Reena as well, our convener and co-convener. If you can please switch on your video so we can hear your inputs as well, please.
Regarding the first case, that was the uveitis patient. Maybe I missed it or something. Did this patient also has cataract? Posterior subcapsular cataract?
Yeah.
I saw that was quite blurry in the.
Yes, yes. She was having dense nuclear sclerosis as well as PSC cataract in the left eye.
Only why did she get cataract?
Maybe due to repeated use of steroids in the past. Maybe due to inflammation.
This could also be.
Dr. Pandav, you're not audible, sir. Can you just be a little louder if you don't mind, please? Thank you.
Diagnosis. Fuchs uveitis actually. That is present. However, the spikes are much more in the partial sources. The characters of the KPs will be a little different, but
yes.
Also depends on what time. I think it again comes down to the proper history. So if yes. Minimal inflammation, actually, the posterior loss of the inflammation is minimum, and it lasts only for some time. But if you have, posterior subcapsular cataract and KPs that are persisting, you might have to think in terms of an alternative diagnosis. And Fuchs is quite often missed, and that may not have its typical heterochromia seen in all patients because of the because we have dark iris pigmentation already there. So I think I would also consider that diagnosis in the patient, the uveitis patient.
Yes.
There's a situation where the patient has got secondary angle closure glaucoma with raised anterior posterior diameter. He's not in the position to to undergo immediate lens extraction. What will be the role of PI and how would one approach? Anybody?
You want me to?
Anybody would be fine, like any of the panelists.
Before I comment, I think doing a laser iridotomy is doesn't do much harm, I would say. So if you have any doubt of whether you do it or not do, it's better to err on the side of doing it rather than not doing it. There's no clear-cut cutoff parameters actually. If you look at the biometry in the lens thickness, or nowadays they look at the dome of the lens or the vault of the lens on anterior segment OCT. That probably is of whether the closure. But none of these parameters actually, there's no mathematics there. There's no there's no set formula that if the ratio is much, you're going to end up into trouble. These are things are only indicatives, So if you have anterior side, chamber depth less than 8 millimeters or more, then the relative risk is higher. That's I would say, and it's not that it's very important. But the only thing is that if you find in a situation where the relative risk is higher, so if the lens dome is bigger, lens vault is bigger, or the lens thickness is bigger, then the primary problem is somewhere with the lens rather than other things. So there you would focus on removing the lens. If there's a cataract, there's a you can make it an indication for early removal of the lens. But if a lens vault is normal and if a lens thickness is normal, and then you look at the anterior, like that proportion of the axial length and the anterior chamber depth. Again, there's no clear-cut criteria there again. But again, if the ratio is disturbed, then again you look more in terms of doing a laser iridotomy. Perhaps if the lens is not really playing a role, then you will think in more in terms of a pupil block element. So there are, I think, is also the configuration of the anterior segment, which is again important. So there's no one parameter which is absolute, but sometime I like to do, anterior segment OCT, or more often like UBM actually, to look at the configuration of that area, how the relationship of the peripheral cornea with the iris and the ciliary body is, that and the lens, of course. So that gives you a little much more idea about the anatomy of that region, and that can be better guide for deciding what you want to do or you don't want to do. So like on UBM, if you see the peripheral iris is very close to the cornea, or there's a iris Bombay configuration, or if there's a plateau iris kind of configuration, so you kind of have some guide to decide. So if you have a iris Bombay kind of configuration, those are the cases where laser iridotomy should be done, right? But if you don't have that kind of configuration, then laser iridotomy may not be useful. Okay, so I think that's how I would approach these.
Thank you, sir.
So I have one question, sir, in the context of a patient of normal tension glaucoma who is steadily progressing despite pressures being in low teens consistently noted. You have ruled out non-IOP risk factors of nocturnal hypotension, carotid angiography, etc., and you're not really finding anything positive, yet patient is progressing. How easy or difficult is it for you to think of a trab in that case? And if so, any modifications do you make compared to when you do a trab for a high pressure or a primary open angle glaucoma in these cases, sir?
I think that's a little difficult to answer, and also because the situation is difficult, and sometimes we do see cases where you have a glaucoma which is progressing, and the IOP is in the low teens, and you don't really know what to do in those situations, because but the first thing you always said is that you said yourself is to like rule out other factors, and I think one of the speakers on the NTG also spoke that you rule out the other risk factors, and it was hypotension, nocturnal hypotension, or sleep apnea is something which we miss, and patients also do not actually complain unless you really probe them poke them into, in the details of the history. So that could be one of the factors which we have to take care of. But if nothing is there and the glaucoma is still progressing, do look into other factors also. There are some nutritional aspects. Are they smokers, or any vascular other vascular pathology, or is there smoking, or is there any B12 or some vitamin deficiency? Sometimes they are also contributing factors which we don't ask for them, but I think in one odd case you'll see that those are also responsible. But I think then the question of whether you want to do trabeculectomy to reduce further IOP or not, I think that actually is a bit of a tricky question, and there's no clear answer for that. But if there's nothing else is there, then probably you would like to reduce the pressure to less than 10 at least to 9-10 millimeters of mercury range, and with the hope that that will stop the progression. But there's no guarantee, because if you have a glaucoma which is progressing at 10 to 12 millimeters of mercury range, or 12, in that range, where it will stop progressing at 8 to 10 millimeters of mercury range, again is just you hope that will happen. But I have seen cases where I have reduced pressures to 7, 8, 9 millimeters of mercury range, and glaucoma continued to progress, and I didn't find any cause whatsoever after extensive investigation. So those situations also happen, sometimes. But definitely, so this is a bit of a decision which you will have to talk to the patient and kind of inform him that we are doing, with the hope that reducing pressures to lower than 10 would help. But there are two things here. Again, number one, there's no guarantee that what your surgery is going to end up with that kind of pressures, because titrating pressures that precisely after trabeculectomy is not easy. And you could end up with a hypertony, or could still end up with the pressure which are more than 10 millimeters of mercury. So that's one that has to be discussed with the patient. And second aspect again is that even if you achieve your target IOP, whether the glaucoma is controlled or the progression stops or not, that again cannot be guaranteed. So this is a territory which is actually difficult, I would say, and so it has to be a very considered decision either way. But if there's nothing else, is working, then obviously you don't want to see your patient losing vision, and you don't do anything. So definitely I would, reduce the pressure further in these patients, and also look at other factors, giving some supportive treatment.
In this situation, can we go a little less aggressive, like start with SLT and then progress, or go for an invasive procedure or something like that?
Absolutely. So I kind of take it that way, that you have tried everything, to reduce pressure to below to say 10, 11, 12 millimeters of mercury range. And drugs, SLT, whatever.
Thank you, sir.
Dr. Chandrasekhar, Dr. Ragini, Dr. Manish sir, Swapnesh, please, any comments, anything which you want to end the session with?
Yeah, see, when we were students, we were taught all the glaucoma, open angle glaucoma, depends on one side, the tension, ocular tension. The other side, it depends on the vascularity. So it is all the glaucomas fall in between these two. That's why in spite of doing, active medical treatment, surgery, on one side, the glaucoma progresses, even if you control the pressure to even less than 10 and all those things, because those things are totally dependent on vascularity. So the other side, where what we tackle is the ocular pressure. That is what we can tackle maximum by bringing down the pressure. That's what we used to think, and
Yeah, I think sometimes these glaucoma also progress because of other factors, like IOP is, of course, there's the focus, but sometimes other factors are also there. It could be the compliance related factor, or, associated conditions. I think we need to, when you have a progression which is not explained on the IOP basis, then you have to look into compliance, because sometimes the patient, they come to you, they are compliant on those particular days and your pressure is good, but in between they may not be compliant. So I think you have to rule out that factor as well. And of course, other things we have already kind of discussed.
Do we have any questions? Any more questions for the panelists and the experts?
Dr. Lahane sir, Dr. Ragini ma'am, Manish sir.
It's end of the day, so
Dr. Lahane sir.
At the end of the day, should we formally conclude the session?
Yeah, I think so, because we have already
conclude the session.
I think the session was very good discussion, and thank you very much, Pandav sir. बहुत अच्छा डिस्कशन हुआ. It was very good. Chandrasekhar sir, the this Mayav sir, the Jinis was and everybody took part in that, and all the faculty. It means it was a, you can say yes or no, but I think it was a good discussion. I was hearing the discussion, and yes. Then I think you can conclude, Pandey sir. Thank you very much for coming.
Thank you, sir. Thank you all the chairpersons, especially Dr. Pandav, Dr. Chandrasekhar, Pratik sir, Devin sir, and rest of the speakers. Special thanks to Lane sir, Ragini ma'am, Dr. Preetham, Dr. Savan, Dr. Manish Shah, Dr. Nikhil Gokhale, Dr. Sumit Lane, Dr. Himalini Sam, and other members of scientific committee for giving us another wonderful day of this academic feast. Till we meet again on next Sunday. Thank you, everybody. And
Absolutely.
Thank you.
Thank you so much.
Everybody. Thank you,
Good evening.
Manish.
Good
Thank you,
night.
Manish.
Big thank you to
everybody.
Manish sir.
Thank you. Thank
Manish
you
sir.
very
Manish
much.
sir.
It has been a very good session all through the day. Lots of knowledge being shared, and I'm sure everybody has benefited, including me. Thank you very much.
Thank you, Dr.
Thank
Man.
you. Thank you,
Thank you,
sir, and
Pandav sir.
you,
Thank you,
Rajeev.
Chandrasekhar sir. Thank you,
Yeah, thank you.
everybody.
Thank you.
Thank you. Thank you. Thank you, Pooja. Thank you, Jinish. Thank you, Maya. Thank you, Dr.
Thank you, ma'am.
Gayatri.
Thank
Thank
you.
you, Dr. Chanda ma'am. Thank you, Karishma. Dr. Reema ma'am. Thank you. Dr. Azit bhai. Thank you. Dr. Sunny. Thank you. Thank you. Thank you. We had a beautiful day today. We started with Pandav sir and we ended with Pandav sir. Thank you, Chandrasekhar sir. Thank you,
Yeah,
everybody.
thank you.
Thank you, Lane sir, for being our mentor. Thank you so much.
Thank you.
Thank
Thank
you,
you all.
Karishma. Thank you. Goodbye, everybody. Please be safe and please take care. Manish, once
Thank
again,
you.
a big congratulations to you for putting up such a beautiful glaucoma program.
It was my pleasure, and it is really, I am feeling satisfied that everybody has been happy. And thank you. Thank you.
Thank you. Today we had more than 1,500 people attending the sessions today, the whole day. And so it's been a good traffic, and that does not include the YouTubers. It includes the people who logged in. And that does not include all our faculty and all who are in the halls. So that is just the audience. Thank you so much.
Thank you.
Thank you.
Bye-bye.
Thank you, Meenal. It took me a long time to find out that Dr. Hoshing is the same as Dr. Meenal Antarlikar. Thank you.
Thanks, sir. Thanks a lot.
Thank you. Bye.
Bye.
Thank you, ma'am. Thank you, sir.
Thank
Bye.
you. Thank
Bye.
you. Thank you. Bye. Thank you.
Bye.
Thank you all.
We must thank Maya for the work that he's doing, working so hard for BOA. Maya, a big hands up to you.
No, thank you, ma'am. Thank you. It's my job, ma'am. I love doing it. Thank you so much.
No, your
You're
mother
an
and I
inspiration
are
for all
very
of us.
great friends, and I'm so proud of you.
Thank you, madam. Thank you so much. Thank you for the opportunity. Bye.
I had a chance to learn from him directly, not about his discipline. Saw sir walking on the road, so I just stopped, got down from the car, and I asked whether he was having fun. He said, no, this is 6 o'clock, this is my clinic. So he used to see his patient till the last time. Last year, I and Vaishali went to his place to wish him on his birthday. And that time, we didn't even think that it was his last birthday. We will remember only his memories in our heart forever. I humbly pray for the departed soul. And we also pray for his near ones, his relatives. May God give them strength to bear the loss. Now, as a mark of respect to the departed soul, we'll maintain 2 minutes silence, and then we can conclude.
लगेच सांग.